Drop the neck down, shoulders relaxed, gazing between the feet or gaze at the tip of your nose. Stay here. 10. No push, no pull. 9. 8. 7. 6. 5. 4. 3. No pulsings. 2. Just hold. And gently hands on the waist. Soften the knees. Inhale, come all the way up. And from here, keeping the same distance, just give a counter stretch. Lift the chest up. Give a slight back bend. Do not drop the neck behind. Chin lock. Keep lifting the chest up. And relax. Come back. Okay. Before you start any practice, any workout, any asanas, it's very important to move the spine in all the 5 directions that we did right now. Okay. So from here, we'll go to our next stretch, which is called as Parshva Uttanasana, pyramid pose. Taking your right leg forward, take the left leg back. Both the hips in one line. So do not look, one hip is not facing the other side. Both the hips in one line. Inhale, you raise the hands up. We'll do it together. And exhale, extend and bend forward on the right leg as much as you can. If you are here, stay here. If you are all the way down, just stay there. And breathe. Stay. 10. 10 counts here. 9. 8. Try not to hunch your back too much. Keep the spine straight. 6. 5. 4. 3. 2. From here, soften the right leg a little. Both the hands forward and come on your fingertips. And raise the back leg up. And keep lifting the chest up. Stay on the fingertips. If you want, keep the standing leg slightly bent. But keep lifting the chest and the leg up. Hold. 5. Balance. 4. Keep the left leg active. 3. 2. Gently come back and change. Left leg forward, right leg behind. Same thing. Again, make sure, check with your hips. Both the hips in one line. Inhale, both the hands up. Lift the chest up. And exhale, extend forward as much as you can. Remember not to push or pull. Just listen to your body and stay there. Last 10 counts. 9. Keep extending. Try not to round the spine. Try to keep the back flat. 7. Gazing at the left big toe. 6. 5. 4. 3. 2. Same thing again. Soften the left leg at the knee and take both the hands forward on the fingertips. As you get comfortable, lift the right leg off the floor, lift the chest up, lift the leg up. Both the movements happening at the same time, chest lifting up and leg lifting up. Hold. 5, 4, 3. You can keep the base leg slightly bent if you want. 2. And bring the right leg also forward with the left leg. Inhale, lift the head up, chest up. Even if you're here, stay here, but keep the spine flat. And exhale, go into a complete forward fold. If not, just stay here. And stay there, last 10 counts. 9, 8, 7, 6, no need to push or pull. 5, 4, 3, 2, hands on the waist, soften the knees, inhale, come all the way up And one more time, taking your feet slightly apart, give a counter pose to the spine. Inhale, lift the chest up, chin locked, stay. 5, 4, 3, 2, and come back. And one last stretch before we go to Surya Namaskars. Coming to 3 feet distance with your feet, take your toes outside, heels inside. We'll go to Kali Asana or Utkat Konasana, basically a sumo squat. So we have 2 variations of this. If possible, with both the hands, you first bend the knees and grab your heels. Use the elbow to push the knees out and look forward. So either you stay here as if you're sitting on a chair, keep pushing the hips back. If this is difficult, if this is not accessible, come into a normal sumo squat. Whatever works for you, and stay. 10 counts. Keep lifting the chest up, belly pulled in. 8, 7, 6. If you're doing this variation, keep pushing the knees out. 4, 3, 2, gently palms on the floor, press the floor, come up and shake your legs, just release any pressure from the knees, and we get ready for our Surya Namaskars now. Okay, perfect. So now we come at the top of our mat. We'll start with Surya Namaskars. So the Surya Namaskars which we are doing are called as Hatha Surya Namaskars. If you've done it already or if you know something about it, you can do it with me. If you've never done it before, you can see the right side and you can join me for the left side. So we'll start keeping your feet together and join your hands in Namaste, center of the chest, and gaze at a point in front of you. And we start. Inhale, both the hands up. Lift the chest up as if you're giving a gentle back bend. Don't look back, look forward only. Exhale, bend forward as much as you can. Padahastasana. Bend both the knees. Take the right leg back, right knee on the floor. Ashwasanchalanasana. From here, take the left leg back to a high plank, Dandasana. Place the knees on the floor, chest and chin on the floor, Ashtanga Namaskar. If this is not accessible, completely lie down on the belly. Point the toes. Inhale, come up, Bhujangasana. Now, in Bhujangasana, the hands are never straight. This is a different practice. Keep the navel on the floor, chest lifted, elbows bent. Tuck the toes in, lift up to Parvatasana, feet together. From here, bring the right leg forward, left knee on the floor, chest lifted up, Ashwasanchalanasana. Same thing, left leg forward, Padahastasana as much as you can. Inhale, come all the way up, arch back, and exhale, Namaskarasana. So we go on the left side. So if you were watching the right side, you can do it with me on the left. And we go. Inhale, both the hands up. Hasta Uttanasana, arch back. Exhale, bend forward. Padahastasana. Inhale, left leg back. Left knee on the floor. Ashwasanchalanasana. Exhale, right leg back to Dandasana, high plank, knees on the floor, chest and chin on the floor, Ashtanga Namaskar. Point the toes. Inhale up to Bhujangasana, navel remains on the floor, elbows bent. Tuck the toes in, lift up, Parvatasana. Inhale, left leg forward, Ashwasanchalanasana. Exhale, right leg forward, Padahastasana, standing forward fold. Inhale, come all the way up, arch back, and Namaste. Okay, we'll do one more set. If you are tired, you can take a little break. If not, join with me for the last set. So we go Namaskarasana, gazing at a point in front of you. Inhale, both the hands up. Hasta Uttanasana, arch back. Exhale, bend forward. Padahastasana. Inhale, right leg back. Right knee on the floor. Ashwa Sanchalanasana, chest lifted up. Exhale, left leg back. Dandasana, high plank. Knees, chest and chin on the floor. Ashtanga Namaskar. Point the toes. Inhale, come up. Bhujangasana, navel on the floor. Exhale, go back. Parvatasana. Inhale, right leg forward. Ashwa Sanchalanasana. Exhale, left leg forward. Padahastasana as much as you can, no push. Inhale, come all the way up, arch back. Exhale, Namaskarasana. Last one on the left, we go. Inhale, both the hands up. Hasta Uttanasana, arch back. Exhale, bend forward. Padahastasana. Inhale, left leg back. Ashwa Sanchalanasana. Lift the chest up. Exhale, right leg back. Dandasana, high plank. Inhale, knees on the floor. Exhale, chest and chin. Ashtanga Namaskar. Point the toes. Inhale, come up. Bhujangasana. Exhale, go back. Parvatasana. Inhale, left leg forward. Right knee on the floor. Ashwa Sanchalanasana. Exhale, right leg forward. Padahastasana. Inhale, come all the way up. Either stretch upwards or go back. Exhale, Namaskarasana. Okay, this was our Surya Namaskar. Now we'll go into seated for some relaxing poses. So from here we come into Vajrasana or the Thunderbolt pose. And we go into cat and cow. We'll be doing 5 breaths of Marijarasana and Bittilasana. So this is how you will take your measurement. Elbow touching the knee, and then you walk one palm forward and come on all your fours. Okay, that is the measurement for your own body. So watch again, starting with your elbow touching the knee, and from there walk one palm forward, coming into cat and cow. Knees apart, ankles pressed nicely on the floor, gazing between the palms. We take 5 breaths in this. So we go, inhale, push the back in, lift the head up, chest up, look up. And exhale, pull the spine up, look between the knees, completely hunch the back. Inhale, push the back in. Lift the head up, chest up, look up. Exhale, pull the spine up. Look between the knees. 2. Inhale, press the back in, lift the head up, chest up, look up. Exhale, pull the spine up, look between the knees. Go with the breathing. Inhale, push the back in. Lift the head up, chest up, press the shoulders back. And exhale, pull the spine up, look between the knees. 4. Last one. Inhale, push the back in, lift the head up, chest up, look up. And from here, keeping the arch in the spine, tuck the toes in from behind. Lift the right hand up. Lift the left leg up, look down or look forward. Try to balance. If this is difficult, both the hands on the floor and keep lifting the leg up. Keep arching the back. If you're comfortable, hand also up. Right hand, left leg. Stay 5. 4. Keep lifting the body up. 3. 2. Gently come back, change, tuck both the toes in, left hand out, right leg out. Keep lifting the leg and the chest up, stay. 5, 4, If balance is not happening, both the hands on the floor. 3, 2, gently come back. And from here we go to puppy pose directly, Anahatasana. Wherever you are, just stay there. Just take your palms forward and press the chest onto the mat. See if you can touch your forehead, nose or chin on the mat. Okay, again now here one correction. Do not sit back on the hip. Okay, that's a different posture. Hips lifted up, elbows straight. If possible, knee and hips in one line, and breathe. Stay there. 9, 8, elbows will remain straight. Don't bend the elbows. 6, 5, 4, 3, 2, and gently crawl back and come back. And from here, just bending forward to a child's pose, Balasana. Again, if this is not accessible, stay on the elbows, or if you have any knee issue, just keep your eyes closed and sit cross-legged. Okay? And we take 10 counts here. Just use this posture to gather your breath. Stay. 9, 8, keeping your eyes closed. 7, 6, 5, 4, 3, 2, and gently come back and relax. Okay, so this was a small seated sequence for us. From here we'll go into a supine position. We'll lie down. So don't directly lie down, okay, that can harm the back. Turn to one side and gently lie down. Both the legs straight for now. We'll go to Ekpada Pavan Muktasana. From here, lift the right leg straight, hug the right knee, interlock the hands and stay here. Right toe pointed, left toe flexed, and just breathe. You can keep your eyes closed. Just try to relax, allowing the body to cool down naturally. Stay there. And gently release. Lifting the left leg up, hug the left leg at the shin, right toe flexed, looking at you, left toe pointed, and gently release. And this time bring both the legs in towards the chest. See and make sure that you do not lift your lower back up. So we do not have to do this. Keep pressing the lower back on the floor. It's okay if the knees do not come way closer to the chest, but keep pressing the lower back on the floor and breathe. And now, keeping the knees wherever they are, just bring your hands in a T position or under your neck, depending on the space you have. The knees will remain up in the air only. Inhale, exhale, drop both the knees on the right, look at the left, giving a supine twist. Supta Vakrasana variation 1. Stay there, breathe, keeping the eyes closed. And gently come back. Change the side, dropping both the knees on the left. Make sure you don't lift the opposite shoulder up. Keep the shoulder grounded. Inhale, come back. And exhale, we relax in final Shavasana. Make all the adjustments you need to make. Palms next to the thighs, keeping the eyes closed. Make sure the inner thighs are not touching each other. Outer edges of both the feet falling in opposite direction. and taking abdominal breaths. Try to breathe through the abdomen without using the chest muscles. Doing yogic breathing, that is breathing only through your abdomen. Breathing through the nose. Completely letting go with the body. The entire spine nicely resting on the mat. Chest relaxed. Shoulders relaxed. Consciously keep relaxing all the muscles of your body. Relaxing the entire face. Relaxing the whole body from the crown of the head to the tip of the toes. Just completely let go with your body. And continue with abdominal breaths. Keep going further deeper into your relaxation, keeping complete attention on your breathing. And see if you can equalize your inhalation and exhalation. Very slowly, keeping your eyes closed, we'll prepare to come out of Shavasana. Do not come back abruptly from your posture. Just gently move your fingers, gently move your toes, and gently move the head and neck left and right, just waking up the body. Without any abrupt movements, gently start bringing your feet together. Interlock the hands over your head, point the toes, give a full body stretch, Yashtikasana, stick pose. And gently relax, fold your left leg, and with the support of the left leg, turn to the right side of the body, making a pillow of your right hand. Stay there for a couple of breaths, Indridasana. See if you can still keep your eyes closed and body relaxed. Now very gently, with the support of the left hand, come up into a seated posture and sit in Sukhasana or a cross-legged pose, keeping the spine straight. Body relaxed yet active. And complete attention on your breathing. Shoulders relaxed, face relaxed. We join our hands in Namaste, center of the chest. We'll be chanting one round of Om. Take a deep breath in. No chanting is compulsory. And we go. Take a deep breath in. Gently bend forward, palms facing up, forehead towards the floor, just with an attitude of surrender, attitude of gratitude for our practice today. Completely drop the head and neck down, Yoga Mudra. Gently crawl back, keeping the eyes closed. We start rubbing our palms. Cup your eyes, And whenever you feel ready, gently open your eyes inside the cup of the palms, blinking a few times softly. And whenever you're ready, gently relax the hands and come back. Thank you so much. This was a small yoga session from my side. I hope you enjoyed it. Thank you and namaste.
So this is introducing firstly the semitendinosis single strand, so using a 4-strand, what was it, semitendinosis graft, so single tendon, so-called star technique. You can see that we've just doubled that through the adjustable loop, and then I'm going to whip stitch that end of the graft, so just 2 ends being whip stitched together, having passed that through the first of the ultra buttons. So yep, standard whip stitch using number 2 ultra braid.
Very fast pair of hands, Robbo.
Yeah, well, that's slightly speeded up from this morning in the interests of time, and you can see that there when we've done that whip stitching, really important to cinch that down, to tighten that, and then that is then passed through the second ultra button. You can see that going through there. And there you've got the lengths set up, as you can see. So that's going to be your 4 strands. Now it's important, this is really critical when you're tying this, is to pass one limb of that the ultra tape, the ultra braid suture, sorry, through that loop, so that when you cinch that down, you're tying not only on top of the graft, but on top of the ultra button as well. So you see as we then tie this knot, it's on top of both the ultra button and on top of the graft itself. So I have to credit Alistair today for shooting these videos and editing them. He's done a superb job, really nice quality. It's nice to see these actually, having done them this morning. So that's then cut, and then you can see there's the 4 strands there of the graft. And then it's these circular sutures. So this first suture goes from inside to out, and then that's passed back through the graft across all 4 limbs, as you can see here. That goes through all 4 limbs. We then wrap that ultra braid suture around the graft 3 times, just to create a sort of cerclage. You'll see us passing that around 3 times. And then that then has to be taken back from outside to in order to finish to tie back to where you first started. So you'll see us just past that now, just to finish up where we started on the inside of the graft. So if you like the numbers, you go from strand 2 to 1, back across all 4, and then back through. And you'll see as we cinch that back down, you'll see it lie all those cerclages around that graft. So as we tension that down, you'll see it has the effect of tying that all together. So having done that, we bury the knot. So we're inside the graft, we lead that to the outside, and you see the knot then disappear. And then those ends can now be cut. And so that's one end. And then that has to just be repeated on the other end of the graft. So we just cut the ultra braid, and then we're going to do exactly the same. So from inside the graft to outside, then a suture that goes back across all 4 limbs. The cerclage again passed 3 times around the graft. So 1, 2, 3. So 3rd pass. And then having done that 3rd pass, it's again coming back from the outside of the graft to the inside. And then that knot is again tied and buried. So that's snugged, and you can see as you tension that back down, It has that effect of cerclaging the graft. And then Speedy Gonzalez with his knot tying. Thank you, Alistair, for speeding that up. And then we bury the suture. And again, those ends are tied. And you can see that using a single semitendinosus tendon, that's going to give us a graft of about 70 mil. We're calibrating that at 8.5 at one end, so a pretty snug 8.5. Sanj, you want to make me make the point of not using this device in real life?
Yeah, I think if you've got an all soft tissue graft, these measuring tubes have an exit, a slot on them.
Yeah.
So you can get soft tissue escape. So
yeah,
I think it's
that's
important
right.
with soft
use
tissue
the
grafts,
solid ones.
Use the solid tubes.
And there you can see your graft of about 70 mil. So you've got an 8 at one end. Now, for this, we're marking the distance of how much we're going to go into each tunnel. So 20 mil in the tunnel. And again, at the other end, just a pen mark of 20 mil for the other end. And then to have an idea of where we're going to flip the button, we're going to mark that on the graft there using about 40 from the endo button. Past this graft, one of my colleagues is going to do that. He's going to bring all of that through for me, Tom, please. Good, keep going. So I've got the button. That's really important that you don't end up letting that go. He's going to just pull that through. Just keep coming with that. Okay. Why is that snagging? Just popping through there. That's great. So we're just coming through there. So excellent. Great. So we now need to pull on the end.
Put on the greens and whites together.
So greens and whites together, and you'll see this will deliver that button up into the tunnel. And Sanj can watch that button going up. There you can see, and then we'll see our mark, hopefully. There it is. And that tells us that we're outside the tunnel, so we can then flip the button and pull back on the tibia. We've got to go a little bit further, and that should then deploy as we then bring that back. Still not quite through. There we go. And now I've deployed. So Sanjay, if you look there, you can see I'm now deployed on my button. So I'm now pulling on that, and I can't get that out of the way. Now, for me, what I do is use a marker pen here, which goes nicely into this little loop at the end. And the key is to get the tensioning right. So you put it, so basically your finger goes in the loop here, okay? And then you've got to sort of equalize the tension. And then when you've equalized the tension, you just give a little bit more on your left arm. And that should slowly bring it all up. When you've got enough out of the thing, there's the second loop appears, as it does, thank you, Tom, okay? And again, you equalize the pressure, and then just slightly increase onto your right hand again, and then you see the graft coming up, and so my left hand, and as you go up again, we're just going to see if Sam just stitched me up with a wrong size tunnel.
I did think.
And I think that's about right. I think that's enough graft probably in there. You can see my pen mark there. I could give it a fraction more if I wanted to, but just see how much I've got in there. So Sanjay, if you look down the barrel of the graft, just orientate your scope, just go more vertically, that's great. You can see that looks a pretty nice graft there. I've gone up to my pen mark. I think you can just see the purple mark appearing. I could possibly give that a little bit more actually. Give it a little bit more into the knee, and I will go a fraction more. So again, equalize the pressure and then put a little bit more just coming through there. But I think that's almost there. Give it a little bit more. It's quite a tight, snug graft. There we go. And I'm thinking that looks pretty nice. And then it's a question of doing exactly the same on the other end. So I find this marker pen trick quite nice. It's just to pull there. And then we're going to just swap sides. And then I'm just going to put one of these buttons. I normally use a slightly smaller button than this. But basically, this is going to sit against the tibia. We pass that through. Like that. Thank you. Great. Well done, Tom. That's great stuff. And then it's exactly the same, that we just basically, you can see they're there. Now, one of the key tips here is to put a finger in the loop to keep these running smoothly until you go down onto the tibia. So you can see now I can advance that, and it's just going to stop that, and I'm going to do that, and then I'm pretty happy. I'm now going to change that for a clip actually, but I'm pretty good. It just keeps everything orientated correctly. But as I run that down there into the skin, final bit, boom. Okay, so that is our fixation. Now what's really nice about that is I can really snug that down, and I can then tension at both ends. So I can really give that tension on both ends. We can then cycle the graft. So there's your view from the anterolateral portal. There's your view from the anteromedial portal here, looking straight up the graft. Okay, that's pretty good.
Thank you for your interest in the mechanism of action and preclinical data for Durolane. Let's get started. The aim of this course is to provide you with the information needed to understand the mechanism of action and effectiveness of the HA class. Durolane is indicated for the treatment of pain in OA of the knee in patients who have failed to respond adequately to conservative non-pharmacological therapy or simple analgesics such as acetaminophen. Durolane should not be used in certain situations as noted here. Refer to the full prescribing information available on the product labeling at durolane.com or by contacting Bioventus customer service. First, some key facts about Durolane. It is the first HA designed for single injection and based on its physical chemistry results in a long residence time in the joint. More clinical studies have been conducted with Durolane than with any other single injection HA knee therapy. Durolane has a history of safe use. However, due to the gel nature of Durolane, it should not be injected into the fat pad of the knee. Durolane is stabilized using a synthetic linker, BDDE, which forms a covalent bond between HA chains. Durolane has a minimal level of interchain HA crosslinks, which is very different to extensively cross-linked HA products, such as Synvisc. The three-dimensional HA gel provides an enduring viscoelastic network within the joint. Durolane has the longest residence time in the knee versus other HAs. Competitors may reference the latest time point for which their product can be detected, but this reflects only trace amounts still present in the joint. Durolane is the only one with published human data. Half-life is the time it takes for a drug in the knee space to be reduced by 50%. The product will stay in the joint for much longer than the estimated half-life. Elimination is via first-order kinetics. The rate of elimination is directly proportional to the amount in the knee. So theoretically, product will remain in the knee until roughly 5 half-lives have passed. Data are from 4 separate studies, 3 rabbit and 1 human knee study. Durolane is the only HA product with half-life data in humans. Durolane data in the rabbit model were consistent with human data. Other HA products investigated in rabbit knee studies had far shorter half-lives than Durolane. One of the main aims in treating the symptoms of osteoarthritis is decreasing patients' pain. Babhulkar et al. Investigated the anti-nociceptive properties of Durolane in an animal model. Anti-nociception is the reduction in sensitivity to a painful stimulation. Babhulkar et al. Chose a preclinical rat model. In this model, a pain response is created by injecting the joints with bradykinin and prostaglandin E2. Both of these are found in osteoarthritis. Bradykinin binds to receptors on neurons, causing them to fire. Because this response is very short-lived, prostaglandin E2 is injected at the same time to extend and potentially enhance the effect by allowing more neurons to bind bradykinin. Painful joints treated with a single injection of Durolane maintained weight-bearing behavior close to baseline, BL values. For example, 50% weight distribution on hind limbs, whereas animals treated with saline displayed significantly less weight-bearing on the painful joint. Note the prolonged period of the effect over 56 days, N equals 11 animals per group. AUC calculations of the data to measure the effect over time showed a significantly better effect for Durolane, NASHA, compared to Synvisc, Hylan GF20, or Hyalgan, sodium hyaluronate. In summary, the research by Babhulkar et al. Shows that in an animal model where a pain response is stimulated using PGE2 and bradykinin, Durolane treatment completely normalized both the mechanical intolerance and weight-bearing imbalance of the affected painful knee. Plaz et al. Investigated the effects of Durolane in a mouse model of OA by evaluating gait and histopathology of knee joints. In this study, OA was induced by unilateral intra-articular injection of TGF-beta plus daily treadmill running. After a single treatment with Durolane or saline, gait analysis was performed on days 1, 8, and 15. Durolane normalized gait parameters in the OA knee relative to saline treatment. Durolane treatment also demonstrated histological evidence for protection of cartilage erosion and proteoglycan loss. Treatment of OA mouse knees with Durolane significantly reduced the stance time that an animal puts maximum weight on the limb, compared to mice with knee OA which were either not treated or injected with saline. N equals 14 mice per group, OA and OA plus Durolane, or 8 mice per group, OA plus saline. To further characterize the macroscopic differences in tissue erosion and remodeling among the 4 groups, sagittal histologic sections from sites known to be involved, medial femoral condyle and patellar groove, were stained with safranin O. In OA animals exercised on the treadmill but not treated with saline or Durolane, histology showed the femoral condyles had severe cartilage loss down to the subchondral bone on both the femoral condyle and patellar groove areas. In addition, fibrous tissue with underlying chondrophytes was detected adjacent to cartilage erosion on the anterior aspects of the medial femoral condyles and on the patellar groove in 4 of the 5 OA specimens examined. OA animals treated with saline prior to exercise histology showed that saline gave some protection against cartilage erosion and fibrous or chondrophytic remodeling in both the groove area and the posterior medial condyle, but showed no prevention of cartilage erosion on the anterior medial condyle. In comparison, in animals treated with Durolane, histology confirmed essentially complete cartilage protection seen macroscopically on the femoral condyle and the patellar groove. In summary, the research by Plaz et al. Shows that an animal model where OA was induced using TGF-beta and exercise, Durolane normalized stance time and protected against cartilage erosion. And in a study by Babhulkar et al., Durolane has been shown to have an antinociceptive effect, decreasing sensitivity to painful stimuli. In an animal model where OA has been induced, Plaz et al. Showed that Durolane can prevent gait changes associated with OA in animal model, and it can also protect against cartilage erosion and fibrosis. In conclusion, preclinical data supports Durolane as an antioceptive and joint protective treatment for OA.
Symbios is the foremost opinion in the design and manufacture of custom hips, with over 30,000 implantations Europe-wide and 20-year published clinical results which are supported by the most robust National Joint Registry data. Symbios is your clinical partner in finding accurate reconstructive implant solutions for the most active, high-demand patients, with or without complicating hip dysplasia.
Hello and good morning, and welcome back to the day 2 of the BIOS conference here in Cardiff. I'm Sanjeev Agarwal, one of the consultants here in Cardiff. We've had an excellent day 1. We had a huge audience engagement, over 800 people registered for this conference, which is a record in itself. We had 1,500 people watching the conference on OrthoTV, and the engagement from the audience has been truly extraordinary. We had an excellent faculty yesterday, and the same, we've got a lot more lined up for today. The plan for the next half an hour is to present 5 podium presentations, and the remaining 5 that we selected will be presented in the afternoon. We had 150 submissions for the podiums, and it's been a tough task finding the best. Commiserations to the one who did not make it to this group, but the quality of the presentations was extremely good. We do not have any live questions for this session, so if you have any questions, then you can text the speakers directly through the platform. And one request is for our viewers to visit the industry exhibits. We've had a good support from industry to run this conference, and be grateful for your appreciation of that. We'll go to the first presentation, which is by Dr. Fernandes, and it's an experimental study of tension band wiring configurations on a model of patella. We'll go to the video now, please.
Experimental study of various configuration of tension band wiring on a model of patella and introducing horizontal figure of tension band wiring with clinical results. Aim was to show on experimental lab load displacement graph and testing various tension band wires and calculating the forces, and then clinical study. We all have visited London Eye, which is supported by the cables and the pillar. If you see with end-on view with mirror image, and it will represent a tension band wire. It has 2 forces, angulation and distraction, which needs to be neutralized. Riley Martin has mentioned that squatting can increase body weight up to 7.6 times, or force can go up to 8,000 newtons. Powell introduced tension band wire from distraction to compression, and Muller explained importance of anterior cortex. Menon mentioned that the tensile surface and compression surface can change depending on position of the knee. We are aware of various tension band wiring techniques. We have different forces in different planes. So to prevent tilt between the fragments, you need even compression by mid-thickness wire, opening anteriorly with anterior cross wire. Similarly, posterior opening need posterior wire, and rotation stably, we need Kushner wires wide apart, or to gain more compression, wires very close by, and horizontal figure of 8 will help to do that. This is frontal and lateral projection with K-wires, without K-wires. We devised this technique in 1987 and was presented in WIROC meeting in 1990. So it has 2 V-shaped wires with equal length and angle. The perpendicular part of the wire gives good compression. Anterior cortex crossover prevents anterior opening, and it has a straight pull. But what we don't know is twisting end of wire, whether it secures, what's the position of K wires, what's the best configuration, and forces in tension band wire and their analysis. So we did this study on experimental model and then clinically with the help of police trainer and devices. So we devised a wire straightener where you got telescoping rods, and the wire gets pulled as we spin it there. And then it's possible to have position of P1, P2, P3 on a tension band wire wooden model with strainer, and position with P1, P2, P3. It was also carried on in Royal Liverpool University Hospital, and each wire were tested, and then on a high density polyethylene patella when it was stressed, and a graph is plotted as seen, and various readings were taken. And if you see with different wires methods to twist the wire, you can see the electrical connector holds and then it gives away, while the loop fixation is lax and twisted wire is very much at the bottom. In tension band wire assembly, the Muller's configuration and the circumferential wire is over in the center, but if you see the V8 is very much at the bottom, and H8 gives almost twice the compression. P3 position, which is close to the midline, gives better compression as compared to other methods. We could calculate the forces and how the theta changes with the position of the wire. and it's possible to calculate the forces. So H8 over V8, we get 1 plus 1 sine theta, and with other methods, 1 plus sine theta. Since 87, we have done clinical studies. These are the X-rays to show the fixation with good movements and position of wire. We have got, in summary, we have put down guidelines for the tension band wire. In our conclusion, H8 achieves maximum compression. Wire should be placed at 1/4 distance from the edge of patella, and crimping ends of wire is the best way of securing fixation. I'm thankful to all the senior teachers who guided us for this experiment. Thank you.
Thank you, Dr. Fernandes. The next presentation is by Dr. Gautam Reddy, and this is a cohort study on the midterm outcome of fracture dislocations of the knee. Video, please.
Good morning, ladies and gentlemen. My name is Mr. Reddy. I'm a knee fellow at Leeds Teaching Hospitals. I'm really grateful for giving us an opportunity to present our work on midterm outcomes of fracture knee dislocations. In order for a knee to dislocate, at least 2 ligaments should be disrupted. And whenever there is an associated tibial plateau fracture, it is called fracture knee dislocation. These injuries should be identified and treated promptly, otherwise can result in a limb-threatening injury. Schenk has classified these injuries into 1 to 5, 5 being fracture knee dislocation. The aim of our study is to look at the functional outcomes of the patients who underwent surgical management of fracture knee dislocation. This is a single surgeon case series. A prospectively collected data was analyzed for a 5-year period. Primary outcome measures chosen was IKDC and KU scores. Secondary outcome measures were Tegner Activity Scale, knee range of movements, and complications. A total of 70 patients were presented with a knee dislocation. Of these, 33 were fracture knee dislocation, which are KD5, and this study looked into this subgroup of patients. The mean age was 37 years, the mean BMI was 25.8, mean follow-up of 3 years. 90% of these patients sustained a high velocity injuries, and only 10% had an ultra low velocity injury. 14% of patients sustained a vascular injury, 19% had a common peroneal nerve injury. Priority was given for early total repair or reconstruction of the injured ligaments with the fracture fixation within the first 3 weeks whenever feasible, and we achieved this in 90% of the patients. Mean IKDC score achieved was 67 with a range of 35 to 100. 100 is the best score one can achieve. KU score mean was 73. Postoperative mean Tegner Activity Scale was 3.6. The mean flexion achieved was 115 degrees. We not only achieved a good functional results, we also observed some pattern of tibial plateau fractures were consistently associated with similar pattern of ligamentous injuries. 25% had a posteromedial tibial plateau fractures, which had consistently had an ACL injury. 52% had an anteromedial tibial plateau fracture. These patients had consistently had a PCL, LCL, and posterolateral corner injury. 90% of the neurovascular injuries fell in this group. 23% had a complex fracture patterns. And looking at some cases, see the 22-year-old had a posteromedial tibial plateau fracture. Sagittal view shows a ACL avulsion injury. Intraoperatively, we noted increase in medial joint space, which was captured on the arthroscopy as well. We treated with the ORIF of the tibia and cannulated screws with the avulsion ACL injury, and MCL was primarily repaired because this is a proximal MCL injury. Another case of posteromedial tibial plateau fracture which is consistent, which again there is a consisting ACL avulsion injury. This was treated with a single incision technique where 2 plates were applied medially, and an anterior window was developed, and the suture anchors were used to pull down the ACL avulsion and repair it. This is the second pattern of injury, where this is a anteromedial fracture pattern, and you can see the joint is subluxed. This patient had not only the anteromedial tibial plateau fracture, he had a posterolateral corner, LCL, and PCL injury as well. This patient had a foot drop as well. We explored the posterolateral corner, primarily repaired and augmented You can see the bone tunnels with allograft posterolateral augmentation. PCL was treated non-operatively with a functional brace. This is again another anteromedial fracture pattern, posterolateral corner injury with the avulsion of the fibula head, and the fibula, and the PCL injury. You can see high signal in the region of the PCL. And there is an increased joint space. You can see through in arthroscopy opening on the lateral joint space. It's called lateral drive-through sign. This is a complex fracture pattern in a 20-year-old. He had a PCL avulsion, a half-off fracture, posterolateral corner injury, and most of these fracture fragments able to fix with the cannulated screws, and posterolateral corner was repaired and augmented with a allograft augmentation. So knee fracture dislocation can often spontaneously relocate, and the severity of the injury can be underestimated. Our study showed a good functional results with early surgical management of these injuries. And to our knowledge, this is the first kind of study to report some fracture patterns are associated with similar ligamentous injuries. We want to supplement our findings with a biomechanical study to look at the axial loads and at the same time the rotational forces going through the knee joint and the pattern of the ligamentous injuries that can happen. Thank you for your attention, and for any questions, kindly email us. We'll get back to you. Thank you.
Thanks to Dr. Reddy for the presentation. May I just remind that for any questions, please send a message to the speakers directly through the platform. The next presentation is from Dr. Naveen Mathai, and this is a prospective multi-center study on the restoration of elective spine surgery during the recovery phase of COVID-19. Video, please.
Good morning, everyone. My name is Naveen. I'm an orthopedic registrar working at University Hospital of Wales, Cardiff, and I'll be speaking to you about a multi-center BIOS collaborative study on restoration of elective spine surgery in the UK during COVID-19 recovery phase. Resuming safe elective spinal surgery during the COVID-19 pandemic involved creating patient pathways in accordance with the resource feasibility in individual units. It was facilitated by a combination of national and specialty surgical recovery plans, which were put forward by organizations such as the BIOS, BOA, Royal College of Surgeons of England, and the NICE organization. It also involves strategies such as patient prioritization and risk stratification, and creating COVID-free or COVID-light zones, which were undertaken locally. Given the significant complications of COVID-19 infections, a UK-wide multi-center collaborative study to examine the clinical outcomes of elective spine surgery at the reintroduction phase of the pandemic was required. We sent out study protocol as well as data collection form to multiple spinal centers in the UK, and we received responses from 8 centers within the time frame of the study. We included all adult and pediatric patients whose procedure was completed in the COVID-19 pandemic recovery period. We excluded patients with clinical reason where the planned surgery had to be performed as an emergency, or patients who were test-proven COVID-19 positive. The primary outcomes were the 30-day mortality rate and the 30-day post-operative COVID-19 infection rate. The secondary outcomes were the surgical adverse events and medical complications and the length of inpatient stay. We had 257 patients in cohort of study, of which 129 were females and the mean age were 49. The average workload from each unit was 32, which ranged from 16 to 101. As per the BOA categorization of facilities, 122 of the 257 patients underwent surgery in the gold facility. That means that the operations were carried out in a separate site or a separate facility with a separate team. As per the prioritization category, 81% of our patients were under category 2 or 3. As per the risk stratification category, 87% of them were either low risk or medium risk. 195 patients had self-isolated in the initial 2 weeks prior to coming in for the elective surgery. The most common cause or the most common indication for surgery in these patients were degenerative spinal conditions. For the primary outcomes, the 30-day post-operative COVID infection was actually 0, and there were 25 patients who had symptoms suggestive of COVID, however, who were negative for RT-PCR test. One patient died in the first 30 days of surgery, which was COVID unrelated. It was a patient who had a metastatic renal carcinoma and who had underwent ACDF. As per the Clavian-Dindo classification of surgical complications, 7 of our patients had to undergo surgery for surgical complications. The average length of stay was 5.2 days, and 78.4% of them were discharged within 1 week. Now, in literature, there are evidence to suggest that safe resumption of elective orthopedic surgery is possible following the peak of COVID-19 pandemic. However, no study to date looks into the safe resumption of elective spinal surgery, and our study is one which looks into the same. Now, to continue elective spinal surgery, it would require a dynamic and flexible approach and a flexible solutions along with diligent monitoring of outcomes and resources. To conclude, our study shows that despite variations in infection prevalence rates and service provisions across UK, there is very low risk of hospital-acquired COVID infection. This study also adds confidence that planned spinal procedures can be performed in a safe environment with appropriate infrastructure, COVID-secure patient pathways, and robust governance arrangements. Thank you.
Thank you, Dr. Mathai, for the presentation. The next presentation is from Dr. Abbas C, and this is an epidemiological study on distal clavicle fractures. We'll go to the video now.
Good morning, everyone. My name is Abbas C, and I'm a core surgical trainee in the East Midlands South Deanery. Today, I'll be talking about the epidemiology of distal clavicle fractures. Recent evidence has shown that the incidence of clavicle fractures has more than doubled, with approximately 4% of all adult fractures involving the distal clavicle. Although many different classifications exist, the modified Neer classification proves popular as it describes both the extent of displacement and the stability of the fracture. There is little consensus with regards to treatment. Age and fracture pattern often determine the treatment option chosen, but at present, there are no guidelines to determine the management of these injuries. There are also a wide range of operative treatments available, but there is limited evidence to suggest the indications of these techniques. Here we have an illustration of the modified Neer classification. The primary aim of the study was to describe the frequency of distal clavicle fractures, as well as the number that are being treated operatively, and to further describe what techniques are being used and how often. Secondarily, the study also describes the complications arising, the rate of fracture union, and the relationship between treatment and Neer classification. We conducted a multi-center cohort study across the UK over the course of 2019. Collaborators were recruited from both major trauma centers and trauma units. All patients over the age of 18 with an isolated distal clavicle fracture were included in our study, and their data were collected within their respective trusts. Using this data, we describe current trends in management, as well as complications and radiological outcomes. A total of 859 patients were included from 18 trusts. 5 of these trusts were major trauma centers. There were slightly more male patients than female patients, but even signs of injury. The majority of patients underwent conservative management. Falls, both low energy and high energy, were the leading cause of distal clavicle fractures. Unsurprisingly, 61% of patients who sustained an injury from a simple fall were over the age of 60, while 75% of patients who had a high energy fall were under the age of 60. All sport-related injuries also occurred in patients under the age of 60, and only one case of pathological fracture was noted. Over 50% of the fractures were type 1 fractures. Interestingly, 64% of the type 1 fractures were also due to simple fall, and 51% of the type 1 fractures were in patients over the age of 60. Hook plate and locking plate appear to be the most popular operative fixation method. There were also almost equal numbers of dual technique surgical fixations involving locking plates and tight ropes. This table shows the number of patients who underwent surgical fixation broken down by age. 89% of patients who underwent surgical fixation were under the age of 60. The majority of type 1 fractures were treated conservatively, which is in keeping with previous literature whereby they are regarded as stable and minimally displaced, hence not requiring any surgical intervention. At most recent follow-up, 45% of patients did not have bony union or had inconclusive bony union. From the data, it is clear that there is no clear consensus for the management of distal clavicle fractures. Although the majority of patients undergo conservative management, there were no long-term functional outcomes recorded for these patients. In addition, a large proportion of patients do not have clear fracture union, and the ongoing effect on shoulder mobility is unknown. Although hook plate and locking plate fixation proved popular, there is limited evidence to suggest the indication of one over the other, and the choice of fixation is likely down to surgeon preference. And here you can see an example of the hook plate and the locking plate. This study was able to record the volume of patients, but an overall incidence could not be calculated. Furthermore, no functional data was recorded for the patients. One could say this is a limitation. However, we are the first to show a snapshot of the prevalence and management in the UK. This study represents the largest epidemiological study in the UK for distal clavicle fractures to date. However, distal clavicle fractures remain a challenge to treat, with no clear guidelines on how to best manage these patients. A pragmatic randomized controlled trial is needed to establish the right treatment for the right patient in order to maximize clinical outcomes. Thank you very much for listening. Any questions?
Thank you, Dr. C, for the presentation. For questions, you have to just message the speakers directly through the platform. The next presentation, the last one for this session, is by Dr. Nimesh Nibani, and this is on surgical complications of atypical femoral fractures. We'll go to the video now, please.
Hello. Hi, my name is Nimesh Nibani. I'm one of the registrars working in trauma and orthopedics at Liverpool University Hospital's NHS Foundation Trust. Today, I'm going to present my presentation on surgical complications of atypical femur fracture fixations and its management. So what are atypical femur fractures? These are fractures which occur with no or minimal trauma, with having prodromal pain, and especially on patients on bisphosphonate therapy for osteoporosis. There are major and minor features which help in recognizing these fractures, and the definition is given by the task force of the American Society for Bone and Mineral Research. So the problem with these fractures is the biology is affected due to osteoclast dysfunction caused by bisphosphonates. Hence, these fractures go into non-union more often than not. And relative stability is required for fixing these fractures, as there is no cutting cone formation due to osteoclast dysfunction secondary to bisphosphonate therapy. Now, the aim of this study was to analyze the causes of surgical complications in atypical femur fractures and provide algorithm for their management. This was a retrospective study for 10 years, and we collected all the patients' data from name, age, hospital number, and surgical complications like non-union stress fracture, infection, type of implant used, when the surgery was performed, comorbidities, time to union, and type of revision surgery if they had any. Results. So there were total 57 patients in our study, 49 females and 8 males. The mean age was around 69. There were subtrochanteric fractures in 30 of them, and 27 had sharp femur fractures. They're all of transverse morphology. Most important mode of fixation was nail. In some patients also had plate, and some had nail plate combination as well. Now, 40 out of 57 fractures united clinically and radiologically at the end of 1 year follow-up, and there was no correlation between non-union versus age and duration of bisphosphonates or the type of implant. Most important relationship was found between suboptimal fixation and non-union. During the revision surgery of these non-unions, 11 were revised with better stability, alignment, better biology with bone grafts and bone morphogenic proteins, dual implants to give a better construct. In one case, we had done an arthroplasty. Patient went into infected non-union, so patient underwent 2-stage proximal femur replacement. Moreover, there were also 3 failed revisions and which were redone and achieved non-union at the end of 2 years. In addition, 14 patients also had prophylactic fixations of the opposite femur. You can see this is an example where first image shows a atypical femur subtrochanteric fracture fixed in slightly varus with a nail. So alignment is in varus, and stability is probably not good for this subtrochanteric high shear force fractures, and biology is obviously affected. Hence, no doubt this went into non-union and later on revised by providing better stability with 2 constructs, and biology improved with bone graft, and alignment is also satisfactory. So the major cause of non-union in our study, which we found out, was suboptimal fixation, and revision rate was higher in such patients, and non-union also had a high complication rate. So the learning points in our study were to prevent non-union, we need to have better contact, stability, alignment, and stimulation. Better contact was achieved by providing osteotomy at the non-union site, and also we have started to do osteotomy of sclerotic bone in the primary fixation of such fractures nowadays, which gave us good contact and stability. Preferably we go for nail, but if we think it is not stable enough, so we can add a plate as well to provide enough stability to give secondary intention healing as a relative stability. And yeah, to improve biology, we have used bone graft or bone morphogenic proteins, and all these things together have resulted in better outcomes for our patients. Thank you very much.
Thanks, Dr. Nibani, for the presentation. So this concludes our morning session of the first 5 podium presentations. Next session is on necrotizing fasciitis, for which I hand over to my colleague, Mr. Rahul Kotwal, who is a consultant knee surgeon at the Princess of Wales Hospital in Bijayendra.
Thank you, Sanjeev. Borida, a very good morning to everybody who has joined us for this session. This session is on necrotizing fasciitis, and we are very fortunate to have Ms. Lorraine Harry with us, who is a consultant plastic surgeon based at the Morriston Hospital in Swansea, and who also provides orthoplastic input at the Major Trauma Centre in Cardiff. Lorraine is also the lead for plastic surgery across the South Wales Trauma Network. Now for this session, I'll start off by presenting a case of my own, and then Laws will take us through her experience of dealing with this orthopedic emergency. So this 66-year-old gentleman who was extremely fit and active, whose day-to-day activities involved sea swimming, cycling, and walking, went for a walk with his dogs a couple of years ago and was probably bitten by a spider. About a couple of hours after this suspected spider bite, he developed excruciating pain in his leg, and his daughter brought him to the hospital with a painful, red, hot, swollen knee. Interestingly, he was afebrile at that stage. However, his vitals showed that he had tachycardia and hypotension. He had cellulitis on his leg, extending from the middle of the thigh to the distal leg. There was no swelling within his knee, and he had completely pain-free range of motion from 0 to 90 degrees. The interesting finding at that stage was that he had patchy bruising on his posterior thigh. His initial bloods revealed a CRP of 209 and a white cell of 22.4. The initial diagnosis, or the suspected differential diagnosis at that stage, was septic arthritis or cellulitis. Now, given that his knee had pain-free range of motion and there was no effusion, we excluded septic arthritis of the knee clinically. I did suspect necrotizing fasciitis at that stage. However, as I'd never seen a case before, wasn't entirely sure. Got a second opinion, and they weren't sure either. We decided to treat this as cellulitis, but continued with hourly observations because we did suspect necrotizing fasciitis. 24 hours later, he did respond to the initial antibiotics. His heart had slowed down a bit, his blood pressure had improved. However, his cellulitis had spread proximally, and he now developed blisters on the back of his thigh. So I got a third opinion at that stage. However, it wasn't very helpful. We carried on observing the patient, and just a further 6 hours later, he became increasingly confused, and the blisters started spreading distally. The CRP had jumped up massively in spite of the treatment he was receiving. We made a diagnosis of necrotizing fasciitis and took him straight to theatre. Over to you, Laws, now for further management.
Well, thank you, Raoul, and thank you for the invitation to present in the sunrise session. So we're talking necrotizing fasciitis, and that's exactly it. You know, not many of us have seen it in terms of the clinical exposure. It is very rare, but of course, cellulitis is actually common. So there's a very difficult diagnosis, and we're talking about the fulminant progressive bacterial infection that gets within the fascia, and it then spreads, and then it causes destruction to the tissues. It's been sensationalized in the media. We talk about the flesh-eating bug. And also, I mean, if I can thank Dean Boyce for a few of these slides. I don't think that he reads the Sun, mind, but I think that he was able to get a few of the media pictures. But so we know that actually the concern is valid because these are the infections that we're talking about. This is the mortality rate. We very rarely come across some condition that is so devastating. There are different types. They're mentioned here. Type 1 is the polymicrobial. Type 2, the group A strep. Types 3 and 4, marine and fungal, are very, very rare. Why are these infections so deadly? Well, as we've discussed, it's the delayed diagnosis. It's rare. Cellulitis is not. We infrequently get exposed to it. I think there are 500 cases reported incidents in the UK. So it presents very insidiously to many specialties, and there's a dilution then of when you get it. If you make a diagnosis as well, it's a really brave one, because as we've heard, actually you can have to do brutal surgery to these patients to treat them and then get them better. Here we have a real-time live microscopy of the fulminant organism. So this is what we're battling against. So really what I want to do is discuss how we can become more confident in diagnosing necrotizing fasciitis, and a little bit of the surgical overview as to how and what to debride. So, I mean, it presents in phases. You will have an early, an intermediate, and a late. And I'll give some pictorial pictures again, thanks to Dean Boyce, my clinical director, for giving me these. You know, the initial early phase, it doesn't really look much, does it? It's a bit of redness, a bit of tenderness, but you can see that it is progressing, and very helpfully and correctly, this is being marked and timed, and that's the key. In an intermediate phase, you begin to get bully, you begin to get skin fluctuation and induration. I think we'll all agree by at this stage with the hemorrhagic bully, the necrotic skin, the crepitus, I think we'd all be confident in diagnosing this as a necrotizing fasciitis. The systemic signs, I mean, I used to be petrified as a plastic surgery registrar being called to see a neck fash because I hadn't seen, I hadn't seen any when I obviously first started, and it wasn't very well presented. And I used to get called to the wards, and I remember someone actually sitting in a bed applying her lipstick with a red foot, and my consultant telling me that no, that's not necrotizing fasciitis. But you can be, it disarmed, because early in the stages, the skin looks normal, and the patient can be just a little bit off. But look for the pyrexia, the tachycardia, the tachypnea. And of course, once you get to your sort of anuria, your confusion, you know that this is a moribund patient that needs to go, needs to have something done. So what do? The differential should be high in your index of suspicion, and you do not delay with fluid resuscitation. You get the fluids in, and then you get the antibiotics in. And then you order the investigations at the same time. The fluid resuscitation is key, and you're needing to speak to your microbiologist, you're needing to speak to your critical care team immediately. Really, the only investigation that is diagnostic is the finger sweep test. Your surgical incision, your finger in, and you sweep it through. And if the fascia is involved, it'll just literally fall away. And then you send your samples for microbiology and histopathology. And then obviously, actually, you will begin to get your diagnosis. Radiology. Actually, it shouldn't delay you going to theatres. I mean, there are radiological investigations. MRI does show up on T2 waiting, but this should not delay your surgery. Diagnosis and treatment is surgical. What about transfer to the plastic surgery unit? Well, if I'm next door in a room at either Cardiff or Swansea, I do want to know about this. But if I'm down the road 50 miles away, then no. And that's the key, really. All surgeons should be able to diagnose and treat the initial stage of it, because that's what saves patients' lives. What do? Well, you take your samples. We'll go through a scoring system in a minute. You give your antibiotics, your beta-lactam, your clindamycin, always with microbiology advice. And then you resuscitate. You're resuscitating at the same time, as I've mentioned before. Is there a role for hyperbaric oxygen? Well, actually, I've never had to use it. I've never been involved in cases on fellowship in Toronto or in the UK. But I mean, that's something to do with obviously oxygenation tissues and stopping the toxin that's being produced by the bacteria. So there is a role. I just don't have experience, but really you take to theatre, you diagnostically explore, and then you surgically debride. Surgical debridement, well, you're confirming the diagnosis. You are isolating the causative organism, and then you're defining the extent of that fasciitis and removing it. And we talk about the dishwater fluid. You never forget it when you get it, because actually it is putrid, it smells horrible, it looks horrible, and it really is classic. And once you have that, you know that you are needing, it's a race against the clock, basically. First debridement should be your last, because in essence, if you've not removed it all, your patient is not going to survive. And you need to reach healthy tissue with a safe fire break. So we talk about zones of tissue. Zone 1 is the classic necrosis. Your zone 2 is then your early necrotizing fasciitis. And as you are cutting, you really do see that change in sick tissue. And then your zone 3 is your normal tissue, where the skin and fascia looks normal, and you actually need to take a 2 to 3 centimeter fire break of that normal tissue, and you're sending samples off. Urgent microscopy, urgent culture. You need to get those clear. It's like a cancer excision. Remember, it goes up and it also goes down. So muscle invasion is also seen in later stages, and this has an amputation rate. You just have to cut out what tissue is involved. The post-excision, well, we dress with dressing, so pause, simple dressing, and then the patient is supported and then returned to theatre 12 to 24 hours to then look and to assess the wound, and then we utilise back dressings until reconstruction. And that, usually then is when you do call your friendly plastic surgeon 50 miles down the road. It's usually after a second or third look. And there are various ways of reconstruction. In the main, we use split skin grafting, again, thanks to Dean for these pictures. But we can also require free tissue transfer. So, again, the reconstruction can be complex, but the patient has had to be cured and ready for treatment. Here we see a picture of an initial and secondary debridement. Those Charney sutures are a thing of the past, but they're doing a job here. And then you see, a repeated trip to theatres where actually we now have a stable wound bed and we are putting skin grafts on. And this, I think, is the fourth trip to theatres for this gentleman who survived. You may know the Elrinex score, the laboratory risk indicator for necrotizing fasciitis. It has 6 factors. This is the literature. This is the paper. Effectively, the maximum score is 13. You're measuring your CRP, your white count, your hemoglobin, sodium, creatinine, and your oh gosh, I knew I would have, that's right, it's your glucose. You say you're 6 and you remember you're 6, it's in there. But it's interesting because, you know, a score of 6 or above is suspicious of neck fash. And all you need is a diabetic with a red foot, cellulitis, and a chronic renal impairment to actually to hit the 6. So it is quite blunt. It is to be used as an adjunct, but it is a very valid tool. And I think that the problem is, of course, we don't see many, but it does help. So just to be aware of that. And then there's other literature that I've posted up here. Again, you know, reviews, many case reports, because of course people, you know, are not seeing this in their local district general or indeed teaching hospitals. As I said, 500 cases in the UK incidence wise. Okay, so in summary, we've got neck fash as a high mortality rate. Early recognition can be curative. The only real investigation is a surgical incision. You put your finger in, you sweep the fascia, you get your dishwater fluid, and you excise all skin and fascia in a zonal manner, and including the fire break. And of course, that may mean muscle, that may mean taking off limbs. You know, you're excising the tissue involved. And the first debridement needs to be your last. I think I've hand back over to Raoul.
This absolutely fascinating presentation, Loz. That was simply superb. I would like to ask you a question about this finger sweep test that you mentioned. Number one, who should ideally be doing it? Can it be even a junior doctor, an SHO, or does it have to be somebody senior with experience? And secondly, is this test best done in theatres, or are we allowed to do it under local anaesthetic on the wards, or even maybe in A&E?
So really good question. So first of all, I think if there is a patient who is moribund and there's a high index of suspicion, you'll already have got senior members of team. So if you are actually a junior on the ward asked and you see a patient like this, you need to be phoning your senior, you know, your senior surgical colleague. I have done it as a junior. In fact, I've actually aspirated the blisters, which is far less invasive, because really doing a cut down in a ward or an A&E is a significant thing, and it's quite a scary thing. So I've aspirated blisters, and that's a good way of actually sending off some tissue or some fluid to get an urgent microscopy and an urgent culture. So I wouldn't, I mean, it needs to be done expediently, and I think that's the key. So if you are literally someone who has got that sort of, you know, late presentation of a type 2 or type 1 group A strep, you know, you need to be getting that. To be fair, I've only done one outside of theatres. So I think in terms of getting the patient through, what you don't want, and what has happened many times, as we all know, is that the patient goes to the MRI scanner, or they've got different reviews of people who are like, not sure, it's neck fash, we'll just treat it long. And as I said, your case, your patient is a classic example. You know, you had a high index of suspicion, but you had no support to, or little recognition, because it, you know, when we don't see them, we don't know. So yeah, so I guess to answer your question, really, it's not necessary, you know, you're cracking open your chest or you're whatever in A&E, but you do need to be doing that fairly quickly and responsibly. So maybe aspirate the blisters, call your registrar or your consultant. Remember, these cases are really difficult from a point of view of the anaesthetist as well. So the senior guys should be getting involved fairly quickly.
Yeah, that's great. That's really helpful. I'm sure this finger sweep test will give a lot of my colleagues the confidence now to diagnose this really devastating condition quite early on. I think we can give our listeners and viewers a closure on my case now. So just for everybody's information, what happened was this patient went to theatre 8 times for surgical debridement, followed by 3 plastic surgical procedures, and I'm pleased to inform that he survived his ordeal and is back out sea swimming, cycling, and enjoying life. Thank you, everybody.
Thank you.
Thanks, Loz.
Thank you.
Right, for this next session now, on a debate between high tibial osteotomy and unicompartmental knee replacement for medial compartment OA, I would like to hand over now to my colleague Sanjeev Anand, who's a consultant orthopedic surgeon and a specialist knee surgeon working at Leeds. Over to you, Sanjeev.
Morning all. I'm really looking forward to this next session, and this is very personal as well, because we're treating our president of BIOS, and I can assure you all he has given his consent for his case to be discussed. got really eminent speakers in this session. We got Professor Chris Wilson from University Hospital of Wales and Professor Hemant Pandit from Leeds Teaching Hospital. And they both have extensive academic and clinical interest in topics of HTU and partial knee replacement surgery. Have the next slide, please. So that's our outgoing president, Bijay, and upcoming president, Prof. Talat. And you can see they stick to a type, really. They're 50-something. I hope I got the age right. And they both want to stay very active and have medial compartment knee osteoarthritis and pain. So let's see what my colleagues, Prof. Wilson and Prof. Pandit, offer this to them. So first speaker will be Prof. Chris Wilson from University Hospital of Wales.
Hello, can you hear me?
We can.
So I'm just going to give a 10-minute presentation on the topic in general. Is that okay?
Perfect. That's perfect.
No, let me navigate. So you can all see that, can't you? So we're going to talk about whether to do a uni or an osteotomy, and it is often quite an issue. First of all, we all know, most of the orthopedic surgeons listening to this will know that total knee replacement is not the answer for lots of our patients, particularly the younger ones. It's now well established that the level of function with total knee replacement is not ideal, particularly in the under 55s, so the results are very good. And partial knee replacement and osteotomy both offer better prospects in terms of proprioception, fast walking, athletic activity, etc. So some patients have a unicompartmental disease, and we want better function, and we're all familiar with these x-rays, and we at the outset have to distinguish or think separately between the arthritic change and the actual deformity, and it's important to have a clear idea of which is the dominant factor. Now, I wouldn't argue that all deformity is pathological. We know that most high-level footballers have got very varus knees, some more than others. So this is not an argument that we need to treat deformity per se. But we know that pathological varus always progresses. And when a patient reaches a tipping point, for example, loss of neuromuscular control or a ligament injury, maybe articular cartilage damage, we know that established varus or valgus tends to progress. And this is well established in the rheumatology literature, actually, especially by Sharma and Felton. And they've shown fairly clearly that if you have a varus knee or a valgus knee, is someone advancing the slides? Or I'm not doing it. Once you have a varus or a valgus knee, it always progresses. So we've got an issue of, first of all, do no harm versus waiting the inevitable. And so we've got this concept of a tipping point. At what point should we intervene, realigning the limb? At what point can we save the day? We do know, and it's no surprise, but there's a lot of literature to show that you get increasing articular cartilage loss with increasing varus or valgus. So it's a mobile situation. Now, this is Roman Sales' slide, and we can see here that the traditional view of osteotomy is there's a very narrow window of opportunity, a narrow window of treatment, if you like, in between the biological and the arthroplasty options. But I want to argue that this window of opportunity is actually a lot broader, and we should consider osteotomy in early disease and in later disease. So this is an example of a chap who's had an osteotomy on one side for what we might consider end-stage disease. And we can see here that the straight leg functions well, the unoperated leg has a visible varus thrust. So osteotomy, apart from treating symptoms, it also will preserve the joint. It's going to give us a high functional level. We're going to be offloading the painful or degenerative area as our primary goal, but also secondary goals are relieving instability and, best of all, avoiding arthroplasty. Now, why is osteotomy so much better now than it used to be? Well, that's because we plan it better. We make a plan, we correct to appropriate levels. We know where we want to put the weight-bearing line. There's much more emphasis on measuring angles, planning osteotomy. So this is helping us achieve better results. And in addition, our methods of osteotomy are so much better than they used to be. Picture on the left is an older fashioned Purdue plate. Pictures on the right are these fixed angle devices we now tend to use. And these are a big step forward because they make for rigid fixation, no brace, no plaster, and very early rehabilitation. So that's contributed in a lot to the, let me just go back there. That's contributed a lot to the success of osteotomy. Now, osteotomy also has a biological effect. I just want to show you a couple of slides, a biological effect that obviously a joint replacement wouldn't have. This is a 22-year-old. He had intractable osteochondritis dissecans, fixed many times, actually 4 times, and basically leaving a large hole in the lateral femoral condyle, a pre-arthritic lesion, you might say. And we see from the long leg views that he had some valgus malalignment, and we see from the plain X-ray there's a large hole in the lateral condyle. Now, when he came to me, we didn't do anything to the hole in the femur. We simply did an osteotomy and corrected his axis. And you see that 3 months after his osteotomy the MRI scan shows some healing of the lesion. And 3 years later, the lesion's disappeared arthroscopically as well, and he's got a high Oxford score. And you could say that we've reversed the natural course of events in that knee by simply altering the mechanical environment. Now, results of modern osteotomy, it's often said that they're patchy, but that's not the case. Over 85% good or excellent at 15 years, pain relief better or as good as knee replacement. Obviously a better level of function, a very good Oxford and Coos scores. Look at some cases then. This chap's a keen runner. He's 50 years old. He's got a knee that many of us would consider a uni would be a much more direct solution. He's got end-stage arthritis medially, a little bit of varus arising from the joint, and a little bit of metaphyseal varus. That's important, as we'll see later. Now, we did in him an osteotomy, much slower recovery than a uni, longer rehabilitation, but returned to a very high level of function with some visible recovery in the medial compartment. Now, this reveals the sort of central, I think, important point about osteotomy. If you're considering someone for osteotomy, you do have to, in my opinion, have a starting deformity. I think osteotomy in patients with no deformity, no metaphyseal deformity, is quite risky. In terms of indications, however, we've got to think in terms of exclusions. So the exclusions will be widespread arthritis, very severe fixed deformity, poor healing, diabetic or a heavy smoker, no metaphyseal deformity, but things like age, gender, stage of disease, BMI, later arthroplasty make no difference at all to the outcome of osteotomy. And that little table on the right there is a result of a French study which shows that with increasing metaphyseal varus of the proximal tibia, the results of osteotomy are better and more predictable, as we might expect. Indications for uni, well, we all know about those, but really we want grade 4 disease, we want isolated disease and a neutral alignment, but importantly, we want a patient with quite modest expectations, a relatively sedentary but high functional lifestyle and intact ligaments. So if we're looking at a patient deciding whether we want an osteotomy or uni, we have to get certain things clear in our mind. Are we treating pain or instability or both? How much deformity is there? What's the starting deformity? Is the loss on X-ray partial thickness? And what does the patient want to do? Because osteotomy involves quite a bit of rehabilitation. Uni is a much more direct solution. Don't forget that even Oxford themselves say that in partial thickness disease, unicompartmental knee replacement offers unpredictable results. Some cases then. This is a colleague of mine, 52-year-old. As you can see, really quite end-stage lateral compartment osteoarthritis, but importantly, a very valgus knee. Couldn't do all the things she wants to do, like running and walking. So in her, despite the severity of disease, we did a realignment osteotomy, and she's 8 years down the line and can still function at a very high level. Now, this is buying her a little bit of time, but you know, the result at 8 years is much more satisfactory than it would have been with a joint replacement. Conversely, this lady, who's a very high level hockey player, has got lateral compartment osteoarthritis, as you'll see from the Rosenberg view there, but she has very little deformity. So she's not a good case for osteotomy, despite a high level of function and high functional aspirations. So she's had a very good result from a lateral uni and can still run a bit, but she's had to accept the fact that the international hockey days are over. This chap came to see me recently. He's a mountain rescue person at the age of 69 and wishes to continue in mountain rescue. And he's got a very varus arthritic knee, but he's got a very high level of metaphyseal varus in his proximal tibia. And therefore, I would consider that for him, despite his age, osteotomy is the better option, because that's the only thing that will keep him going up and down the mountains in his rescue. But there we are. But conversely, this chap, who's much younger than him, 58 years old, he's an office worker and a golfer. He's got very little metaphyseal deformity, and he can't really be bothered with the rehabilitation either. He wants to wait back quite early. So for him, a unicompartmental knee replacement is a much more direct solution. Now, don't worry if you're doing osteotomy about conversion. There's a story amongst orthopedic surgeons that your subsequent knee replacement will be more difficult. And I've not found that to be true at all in 15 years of doing these conversions. And in fact, the literature supports that. There's no evidence that total knee replacement after high tibal osteotomy is any more difficult than a primary knee replacement, especially in view of the fact that nowadays we're doing lots of open wedge osteotomies, which in a sense create additional metaphyseal bone. So in the final analysis, you've got a patient in front of you, you're trying to choose between the two things. What are you going to do? Well, decreasing age pushes you towards an osteotomy, but the age group of 50 to 65 can be tricky decision making. But if the patient wants a very high level of function and wants to run and lift heavy weights and go up and down mountains, you know that a knee replacement is not something that that's going to deliver that level of function in most cases. However, if they present with this dilemma and they don't have a metaphyseal deformity, my advice would be don't do an osteotomy, because you'll need to overcorrect them and you'll get an unhappy patient. Conversely, if they present with an arthritic knee but the joint space loss is very minimal, don't do an arthroplasty. Always bear in mind that the rehabilitation after osteotomy is longer and more arduous than rehabilitation after a joint replacement. So you have to be sure that your patient knows that and can buy into it. So there we are. There are overlapping populations between a uni and an osteotomy. High deformity, desire for high function, partial thickness loss pushes us in one direction. Full thickness loss, moderate aspirations, and no deformity pushes us in the other direction. There is a population of patients in the middle who've got full thickness deformity. They wish to have a decent level of function, and they've got some deformity. Well, they present the treatment dilemma, and you have to put the options to the patient, I think. Thank you very much.
Thank you, Chris. I would next invite Prof. Hemant Pandit, and he'll lay out case for partial knee replacements.
Thank you, Sanjeev. Can you hear me?
Yes, we can, Hemant.
Okay, thank you. Martin, am I allowed to share slides?
Yes.
Okay. Give me a minute. Struggling to share slides, I don't know why. You must have my presentation as well.
We do have your presentation.
Don't mind if you want to.
If we can.
Earlier, Sanjeev, I apologize.
No worries. Can we get Prof. Pandit's presentation running if it's possible? Okay, thank you. While we're waiting for,
Yeah.
we have some questions. I've got Mr. Amit Chandra with me. He'll ask the questions while we're waiting.
Hi, Chris. Are you?
Hello.
Hi. Yeah, there's a question here that do you ever consider osteotomy below tibial tubercle if the deformity is severe? I suspect it's a biplanar question they're asking.
Yes. Well, some of the orders will be familiar with biplanar osteotomy, others won't. This is a technique where we make a coronal cut to go behind the. Oh, hang on, stop my video. We make a coronal cut to go behind the tubercle. Now, with a very high deformity, we don't want to drag the tubercle down, so the coronal cut goes inferiorly. So it's called inferior biplanar. It adds something technically, because in order to prevent the quadriceps pulling the tubercle off, we have to fix the tubercle separately. And I tend to use an inferior biplanar if I'm going to do an open wedge correction of more than 15 mils. 15 mils is very big corrections, quite rare. But if you are not someone that does biplanar, you have to make an assessment of whether your osteotomy is going to significantly alter patella height. And if it does alter patella height, you have to try and arrange things so that the tubercle is on your proximal fragment. Now, that's actually quite a difficult thing to do with a proximal tibial osteotomy if you're not using a biplanar technique.
Okay, I think I've got that covered later on. So I think we got...
Slides?
Okay, Hemant, I think you on, yeah.
Can you see the slides?
We can.
Okay, thank you, and I apologize. So, first and foremost, thank you, Amit, thank you, Sanjeev, great meeting. And Chris, I must give him credit. He has given a very balanced view, and I don't disagree with anything that...
Hemant, can you go full screen, please?
Yeah, sure. Yeah.
Yeah, thank you.
Okay, thank you. Sorry, I have messed this up. I have a feeling. Give me a second. Okay, I think we'll go with this. Let's see, because the full screen doesn't show everything I wanted to show. Anyway, thank you. So, I must give credit to Chris. He has given a very balanced view. I don't disagree with anything he has said. I'm going to compliment some of the things that he has said. I think I'll try and keep this discussion, this presentation short so that we can have some good discussion. Thank you. So most of us have seen these slides, some of these slides before. This is an original patient from Goodfellow series, severe arthritis, bone on bone, medial compartment. She does have tibia vara, but clearly she's not suitable. Even if she was 50, I would doubt whether she would be suitable for a HTO. So in my mind, and clearly the deformity was correctable when she applied valgus stress to the knee herself. And more importantly, when she sat down, the deformity did get corrected because there was bone posteriorly on the tibial condyle. This is the patient's X-ray, which to confirm that it has all the necessary classical features of medial compartment arthritis, intact ACL, affected patellofemoral joint, and intact ligaments. So to diagnose anteromedial osteoarthritis, you do need bone-on-bone arthritis in the medial compartment with functionally intact compartments as well as ligaments in the rest of the joint. And to do so, we would always depend primarily on plain X-rays rather than on MRI scan. When we start our journey with uni knees, probably you need to do stress radiographs because they are helpful for you to identify the right patient. It shortens your learning curve. Importantly, you can talk to the patient, counsel the patient better, and therefore it helps both the parties and expectations are better. Of course, as you move on with your practice, you can confirm the findings intraoperatively anyway. And more people will go away from doing stress views more for logistical reasons rather than anything else. I'm always wary of any designer series data. So I think this data is very useful. This is an independent series from Ulfsward, 35-year plus experience, 1100 patients, key bits, none lost to follow. And he has shown that in his and in his center's hands, the 20-year survival is in high 90s. All comers, you can see the age range is wide, so quite young as well as quite old age, with mean follow-up at that time was 6 years. I have a feeling that I have started with some wrong slides, but it doesn't matter, it will still convey the message. The patients are able to get excellent function. They are able to squat as well as sit cross-legged, able to do most of the day-to-day activities. I agree with Chris. If you ask me whether they'll be able to do very high-level sports, the advice is not to do them. We did talk to patients who indulged in high-level activity. What we noticed is what we tell the patients, they don't listen to you. If they want to do it, they will do it. And when we reassessed our cohort of young patients who were indulging in Tegner level 5 to 8, they did not have high failure rate and were able to continue to indulge in these activities on a regular basis. Probably more importantly is to understand the clinical outcomes. This is against total knee replacement, and as all of us know, unis give better outcomes than total knee replacement when it comes to Oxford knee score, and the number of patients who have excellent outcomes are far more than with total knees. Satisfaction is better, EQ5D is better. However, more important from the patient perspective are major complications. So the complications of DVT, infection, stroke, MI are far less in patients undergoing uni as compared to total. I don't have similar data with age and gender matched patients in HDO, so I can't comment on that, but I guess in young and fit patients, those rates are quite low. Any operation does have complications, so we need to be aware of that, bearing dislocation, fracture, and we need to be aware how to minimize those risks by taking various steps that are necessary. Progression of arthritis is another key complication which tends to occur with partial knee replacement, but it can of course occur with high tibial osteotomy as well, especially if you overcorrect or damage the medial collateral ligament. When it comes to whether one should do fixed or mobile bearing, it is entirely up to the surgeon to decide what he is more comfortable with. I think the results are quite similar in the two groups in independent series. If you go to designer surgeons or those who strongly believe in doing one over other, they will continue to do mobile bearing. But we recently published this work where we looked at a significant number of patients. And what it showed is that there is no real difference between the two when it comes to the revision rates. Polyethylene, but the mode of failure is different. So for mobile bearing, it is bearing dislocation, while for fixed bearing, it is polyethylene wear. Number of cases is important. I'm going to skip that. So the take-home message from my perspective is probably whatever you want to do it regularly. Remember that the patient is on a continuum, and patient, as Chris very clearly pointed out, patient can present at different time points in the continuum. So we really need to know what are patient's expectations. And if the expectations are for moderate function, I would be very happy to do a partial knee. If the expectations are for a very high level function and patient is looking for a temporizing procedure with a clear extra articular deformity, then the answer is going to be HDO. I agree 110% with Chris that we would never ever, or we should never ever offer a partial knee or any arthroplasty to patients with partial thickness cartilage loss. But by the same definition as Chris said, if there is no extra articular deformity, then I really don't see a point in doing a high tibial osteotomy. I'm going to stop here, and I apologize for some issues with the slides. Thank you.
That's wonderful. I was hoping there would have been more disagreement from your side with Chris, but both seem to agree. Can I have my slides as well, please? I mean, what we seem to agree is that patient with severe cartilage loss, grade 4 arthritis, metaphyseal deformity, high demand, we're looking at more of HTO, but with no deformity, moderate cartilage loss, we're looking for HTO, but severe cartilage loss and no deformity, less demanding, we're looking for partial knee replacement. So what are you going to offer to my colleagues over here? I mean, they're 50-something. They both want to stay active. They want to run. They got medial compartment arthritis. So I can say, ask Chris first, what would you offer to one of my colleagues, these colleagues? Chris, can you hear me?
Right. I've just unmuted. Okay. I'm struggling with Zoom like anybody else of my age. Well, now, your colleagues, I didn't see, did you show their x-rays before?
Okay, there you are.
Let me just...
obviously, there are radiological parameters, but there's a lot about patient profile, as you mentioned, isn't it? That's where a lot of discussion comes in. So both of these guys want to do marathon running. So what do you think?
Look, let's look at the factors in favour of osteotomy. There is a metaphyseal deformity. It's only looking at that, I'm guessing 4 or 5 degrees, and the weight-bearing line is through the medial compartment. So in that regard, osteotomy is feasible. I would also say you've not done a Rosenberg view, but it's not full thickness loss. The patient also has got a level of function and ambition that outstrips any form of joint replacement. So in that case, I'd be happy to offer that patient, your colleague, an osteotomy. Bearing in mind, as a runner, you have to accept the much longer rehabilitation. You have to be honest with the patient about that. So on the specific issue of that case, I would offer your colleague an osteotomy and promise him that he'll be back to running in about 6 months, all being well. I'm presuming he's not a smoker and there's no other reason that his bone might refuse to heal. Just while talking, I would take issue with one comment from the previous talk, in that osteotomy is not always a temporizing procedure. And in my experience, doing it in early disease, and I showed those cases of, if you like, the biological effect of osteotomy, we haven't got enough to write up yet, but we will in due course. Some patients with early arthritis are in effect are cured. Their arthritis progression stops. We see some regeneration. There is an evidence base for it. So I think that it shouldn't always be considered as simply temporizing.
Okay, thanks, Chris. Hemant, you mentioned that you find that uni patients sometimes are doing more than what we think they would do. So would you offer uni to my colleague then?
So far, I mean, I take on board what Chris has said. That patient on the scanogram and what x-rays you have shown me, I am not convinced the patient has significant deformity. It is borderline, but clearly my field is more skewed to the knee replacement rather than osteotomy. So it has to be a balanced discussion with the patient. If the patient wants to go back to running, understands that it will need longer rehab, then I am more than happy to refer this patient to somebody like Chris or to you, Sanjeev, or whoever do the osteotomy on a regular basis. I still remain to be convinced. I have heard many conversations and many presentations. I have no doubt that osteotomy does well in patients who have partial thickness cartilage loss in the mid to long term. And I agree with Chris that it does stop the progression of the disease. Similarly, there are various studies which have shown that even unicompartmental knee replacement will reduce the progression of arthritis. You do get caught out in both the scenarios. If I was the patient, I would probably stop running, first of all, and I have to change my activity level. Secondly, I think the x-rays do show bone on bone. I mean, they will definitely show bone on bone arthritis if you either do a Rosenberg view or a stress view. So I don't believe this is partial thickness, but I would like to confirm that on the X-rays.
So,
thank you.
So, would you ever depend on MRI to confirm? Can our slides, are they coming? Or is just X-ray kind of diagnosis for looking at arthritis? So we did MRI. I mean, do you ever depend on MRI, Chris, to look at cartilage loss?
Actually, MRI is in my workup for both uni and for articular and for osteotomy, really to look at the health of the contralateral compartment and to see, in the case of HTO, whether there's an intact lateral meniscus, which I think is quite an important factor, particularly for osteotomy. One of the advantages of a partial knee replacement is that you can leave the knee in some varus or valgus if it's a valgus knee, but usually leave it in some varus so as not to suddenly overload the lateral side. But with an osteotomy, although we're looking, it's very important to avoid overcorrection. If we correct to a neutral axis, then of course the lateral side will take a little bit more load than it's been used to. So that has to be borne in mind. But for these MRI scans, I think probably show that parts of the medial compartment are full thickness loss, and you wouldn't feel too guilty about doing a uni in this patient. But I'll go back to the fact that there is some deformity, not a huge amount, but some. There is scope for axis correction. The patient's young and aspires to a high level of function, and that will push me in the direction. This patient represents someone who's in that overlapping group, doesn't he? And that will push me in the direction of an osteotomy. I would do osteotomy for this patient.
So, Chris, can I ask, like, he's got a radial tear of lateral meniscus with some lateral osteophytes. Does that worry you when you do osteotomy? I guess, Hemant, that won't worry you for your uni. Is that right?
No, it won't worry me. My uni, I'll just make a point I forgot to make. I apologize to digress a bit. Chris did show X-rays of post-HTO total knee replacement, and I know with the modern techniques you probably will get away in most of the cases with a straightforward total knee replacement. You don't have issues with patella tendon length, etc. I would caution you about changing a post-HTO patient to a unicompartmental knee replacement. So that needs to be discussed with the patient, that you then don't necessarily, so you're probably burning the bridge of unicompartmental knee replacement if you have performed HTO before. There are some series which we'll talk about it, especially if you have undercorrected. I would just have a word of caution. Coming back to your osteophytes and lateral meniscus, if intraoperatively the lateral compartment has full thickness cartilage, I won't worry about it.
Okay. Very quick one, Chris. We're running out of time. So, does that worry you? Lateral radial tear, lateral meniscus? Yes. No?
Well, I think it's a factor, but then it's a bit like cookery, isn't it? You know, there are lots of different ingredients here. I think it'd be very important. It's always important, but especially in this case, to avoid overcorrection. So we're looking for a neutral axis, despite the fact that there's full thickness loss there. We're not looking to put the weight-bearing axis lateral to the spine. We want it through the spine. But in that regard, I've found that the effect of axis correction is so powerful that it has almost, if you like, changing the mechanical environment of the knee has a biological effect. There's no two ways about it. So I think that despite it's noteworthy, but it would not put me off doing an osteotomy in this patient.
Okay. And just a quick one, audience question. Patellofemoral arthritis, does that worry you? I mean, I guess unless it's severe lateral patellofemoral rest, does that rest worry?
It doesn't. No, I think the same argument applies to both medial uni and high table osteotomy. If you've got a very severe lateral facet and overhanging beak of bone, you know, of the type that we all know, then pushing the patella even further laterally with either technique is likely to result in some problems. So the only type of patellofemoral area that worries me is really quite severe lateral facet with overhang. Everything else I effectively ignore.
Hemant?
I agree with Chris. Same applies to partial knee. I just want to make one quick comment, Sanjeev. So clearly, for both for Chris and for me, there is potentially a patient who has, say, more or less partial thickness cartilage loss, maybe some areas of exposed bone, but no metaphyseal deformity. Okay? And both of us would be wary of treating these patients. I just want to say something here, and probably advertising something here, is that the Dutch would very clearly, and again, any surgery, the indications you start with, like onion peel, isn't it? You start with the golden indication and then you try to expand. So the Dutch would, in those patients, do knee distraction. So we are embarking on the distraction. It's called knee arthroplasty versus distraction study. It's an NIHR funded study. And in those patients, so if your patient does not have major deformity, and patient has always lived with a touch of tibia vara during his growing years, a knee distraction is a potential option with similar outcomes that you would expect with HTO, but the numbers from the Dutch are small, 500 odd patients. So I'll update you with time. Thank you.
Thanks, Hemant and Chris. A really interesting discussion. There are a lot more questions from audience, and maybe we'll pass them to you, but I'm afraid we'll have to close this session. Thank you for your time. So next session is we have a coffee break, and we have an industry session from Hospital Innovations on Osteotomy. Please stay for that session. And after that, there is a talk on spinal emergencies, so hope to see you then. Thank you.
Hi, I'm Nick, BodyCAD Product Manager at Hospital Innovations. BodyCAD's fine osteotomy system is a new and innovative way of looking at osteotomy around the knee, offering a level of precision and personalisation in osteotomy, planning and execution not seen before. With 3D planning, 3D printed custom cutting guides and a patient-specific manufactured plate, fine osteotomy offers a unique solution to achieve the planned correction safely and precisely. Please enjoy our software demonstration of the planning stage.
So the first step is to load the case. So here what we are seeing is the CT scan of the patient. So we have all the bone anatomy in 3D model. So we have the tibia, femur and fibula, and we can rotate it and see all the anatomy of the patient. The next step is to, the software is superimposing the bone model over the X-ray. So it's a long-standing X-ray. So it's for it serves to have the bone model in a weight-bearing position. So now the tibia and femur has been superimposed perfectly to match the X-ray. So we have the CT now in load condition. Next step then is the software is positioning some landmarks. So all the dots we are seeing at the screen are specific anatomic landmarks. So some are for the epicondyle example, or the other are for the plateau point, the tuberosity, etc. So with all those dots, the software is able to draw the line for the mechanical axis and the anatomical axis. So we have all this information in 3 dimension, and there's also the disc we are seeing here are representing the plateau, the tibial plateau. So with all this information gathering, the software is able to calculate all the measurement. So now we are seeing the landmarks also overlapping on the X-ray. So with all these landmarks and mechanical axis, the software is able to calculate specific measurements. So for example, the MLDFA or the MPTA. The software is able to show or hide every measurement. So we have more than 50 measurements in total. But here on the screen we can see a resume of the knee measurement used for a stotomy case. So for example, here we will see the medial tibial slope angle, and since we are in 3 dimension, we have also the lateral tibial slope angle. So also on the screen we can see cadran that are showing if the measurements are in the green acceptable range or in the red non-acceptable range, so we can see where is the deformity of the patient. For example, this patient is in varus. So we can have all access of the information of the measurement. So we have a description of the measurement, and we have description of who publish, what standard are published where. So this provide the prep tech, the technician, the ability to see what is the initial situation of the patient, and then on the next step, planning the osteotomy according with this measurement to know what exactly will be the best opening or closing wedge angle for correcting the patient. So as we can see now, we are seeing the red line is defining the cutting plane of an open wedge. The green dot is representing the hinge axis of the cut. So we can see that the software is positioning the hinge axis at 10 millimeters from the lateral plateau and 10 millimeters from the lateral cortex and 15 millimeters from the lateral plateau for an ideal opening wedge as written in a reference book. So we can see that the osteotomy is represented all in 3 dimensions, and the hinge axis is also represented in 3 dimensions. We can adjust the cutting angle and adjust the correction also. So the software is calculating the opening, ideal opening 8 to be able to correct the mechanical axis at a specific measurement. So for example, here we have corrected it at 55% of the tibial width. So it in the new measurement panel, we can see the measurement are changing with the amount of correction. So now we are giving it more correction or less correction, and we can see all the measurement in the panel at the right changing at this simultaneously. All the measurements are also calculated in every dimension, so we can have see also the effect of this osteotomy on dimension in the sagittal plane. For example, the tibial slope angle. So we can be sure that with this correction we don't change the tibial slope. So here we are seeing is that the measurements are classified in initial measurement, final measurement, and the difference between both measure with the osteotomy applied. So this gives be planned for opening wedge, closing wedge, also an opening wedge on tibia or closing wedge on femur. We can plan any type of osteotomy around the knee with this software. The next step will be the design of the cutting guide. What is interesting to note about is the special way how we cut the bone. We are using drilling technique. So the drills are depth calibrated, and with the cutting guide there's a drill sleeve that will control the depth of the drill for each drill. So with this concept we can be sure to respect the hinge position, to respect the hinge axis actually, and also to cut only the bone necessary enough bone to perform the whole cut, and not cutting more than what is needed. So here what is showing is the drill guide. So the drill guide are labeled with a blue 110 millimeters. It was the type of drill necessary to use with this specific cutting guide. In the surgical reusable instrument tray, we have different drill to use with different guides. Also, the guide is used for the bone spreader. So the box we are seeing in the posterior side of the cutting guide are used for the tool bone spreader. Final step is the plate design. So here we already have a plate that have been designed. We can see the specific part of the plate have a specific wedge. So the wedge is respecting the opening that was calculated in the step in the osteotomy step. We can see the wedge have a different height, so it's in a taper shape. So it's respect the exact opening we have decided to do. So the ratio are not the same for the opening. So we are opening less in the anterior part than in the posterior part. So we can see also that all the screws have been positioned correctly. So the software is calculating the correct length of each screw. So in the kit you will receive only the screw needed to implant this in specific plate. So when we are designing the implant, we can adjust the direction and the depth of each screw, so we have a perfect coverage of the plateau of the tibial plateau. So as you can see, the software is changing from length to respect if it's a bicortical screw or a cancellous screw. The software calculates automatically the right length to be used.
Good morning and welcome back. I'm Ashish Khurana. I'm a consultant spinal surgeon at Royal Gwent Hospital and Grange University Hospitals, Newport. This session is on spinal emergencies as to how to get through a night or a weekend of on-call from a general orthopedic rota point of view. With me, I have 4 eminent spinal surgeons. The first talk is on a topic that still puzzles us all, Cauda-Equina syndrome by Mr. Mike Grevitt. Mr. Grevitt has been a consultant at Queen's Medical Centre in Nottingham for over 20 years. He's the current UK Spine Society's secretary and a member of the Spinal GIRFT team and North American International Education Committee. He was the inaugural chair for AO Spine Community Development Commission and also served as a chair for the Global AO Spine Education Commission and a AO trustee. Mr. Grevitt has held a wide range of advisory roles for various national bodies and a very well-published consultant. He has several seminal papers, including on Cauda-Equina syndrome. So over to Mr. Grevitt.
Thank you very much, Ash, and good morning, everybody. So I'm going to talk about Cauda-Equina syndrome and offer you, I hope, a survival guide and some insight into this really difficult problem. And it is a very stressful problem indeed, due to several factors. Firstly, it is a very common problem. Suspected Cauda-Equina syndrome is something that bedevils all of us, and matters made more difficult by lack of clear definitions. 2 experts in a courtroom can be arguing whether in fact Cauda-Equina syndrome exists at all. And that's due to the fact that atypical presentations is rather the norm, rather than the classical clinical presentations that you will have read about in textbooks and during training. And matters are made more difficult by restricted or lack of out-of-hours MRI access. And most of you will know that getting an MRI scan is key to the final diagnosis. And of course, there's the fear of litigation. So over the next few minutes, what I'd like to offer you is some insights into the concept of incomplete versus complete chordoequina syndrome. What are the three central tenets of CES and how those are challenged when it comes to practical reality, and how that they're poor predictive values of what we term clinical assessment. And I'm going to introduce a topic that is close to my heart, which is the use of post-void bladder scans as an adjunct to diagnosis of chordoequina syndrome. So it's Gleegan McFarlane in 2002 who helped us with introducing the diversification of chordoequina syndrome, which is not a homogeneous diagnosis. So they termed incomplete as the patients who'd had any form of neurogenic urinary difficulties, whether it be inability to void, altered stream, the need to push, etc., versus complete or CES with retention, that is complete paralysis of the detrusor muscle with retention and overflowing continence. And the value of surgery, if any exists at all, is to prevent that transition from CSI to CSR. And there's some evidence to accumulate that if you manage to prevent that and intervene less than 24 hours since the onset of symptoms, the outcome is much better in CSI compared to CSR, where many of us think, in fact, the game is over by the time patients present with that. But it is CSR which, in fact, dominates the NICE CKS guidelines, which I'll elaborate on shortly. So the three central tenets of CSE may be thought as a progression, a clinical progression, whereby you have some form of sphincteric dysfunction or autonomic dysfunction. Because we pass urine much more frequently, it's urinary problems which dominates the picture. There has to be some objective damage to the chordoequina, and there must be chordoequina compression on an MRI scan. So that's the progression, and those are the three central pillars of that diagnosis, which at first glance would appear to be simple. But ladies and gentlemen, it's a jungle out there. And the problem is that when it comes to sphincteric disturbance, urinary incontinence is very common. The point prevalence of urinary problems in middle-aged multiparous females is anything between 35 and 40%. The physical exam results have, in fact, poor predictive values. And we all know that it's a challenge at times getting an out-of-hours MRI scan. So what about sphincteric disturbance? And all of us will be familiar with a Friday night suspected CES. And that's only 15% of scans that are performed for suspected chordoequina actually show chordoequina compression. And that's repeated across all these national studies. And that urinary incontinence, or CESR, is a very late feature. So by the time that presents, or if we wait for that as a presenting symptom to define the diagnosis, it's already too late. So the challenge is diagnosing CES incomplete. So how do we do that? We need objective evidence of chordoequina damage. And of course, it's the old aphorism, if you don't put your finger in it, you put your foot in it. So alteration in anal tone, reduced perianal sensation, or absence of vulnerable atrial have all been our traditional definitions of some degree of chordoequina compromise. And of course, they are all embedded in the NICE CKS red flags. But I have to say to you that there's poor reliability and specificity. So even patients with bilateral perianal numbness and some degree of altered anal tone, the chances of chordoequina syndrome are in fact quite low. Alternatively, many patients with proven chordoequina compression on MRI scan do not have that objective evidence. So, and in fact, the most valuable sign is probably absence of voluntary anal contraction, but that's a late sign once again. So how can we actually increase the sensitivity? So, and that's where the bladder scan comes in. These are very cheap and largely and very available, and they're non-invasive and very reproducible. So the the problem is thus is that patients with CESI are likely to have large pre-void bladder volumes. They have incomplete voidings and a large post-void residual volume. And that is the definition of Cleaver-Macfarlane's CESI. And once you have a figure on which to base that of a PVR, it allows some degree of risk stratification. So the take-home figure for today is 200 mils. So if a PVR of 200 mils, the odds ratio for CS is 20 times that of patients with less than 200 mils. And you can see that use of a bladder scan PVR volume of 200 mils, if you look at table 2 there, is far and away more sensitive and has far greater positive and negative predictive value than all the signs that we come to and traditionally recognize as indicative of CES. So in terms of navigating the jungle, I'll offer you a traffic light survival guide. So in the case of suspected cord equina syndrome, you must perform a full and thorough clinical assessment. And I would say this from the perspective of one who does a lot of clinical negligence in this field, document everything. The bladder scan is, in our unit, a central core of the assessment process. And if that bladder scan shows a volume of greater than 200 mils, that is our trigger for an urgent priority MRI scan, which supersedes anything else that's on the list bar force majeure. If you don't have access to an out of hours or urgent MRI scan, then discussion with your local spine unit allows a far more forthright discussion once you have that objective measure. But in any case, once the results of the scan are available, then it is an urgent transfer that's mandated, and your SLA with your local ambulance service should reflect that prioritization so that patients get to surgery in a timely manner. If the volume is less than 200 mils, then arguably that patient at that stage at least has normal executive function of the bladder. Ergo, one can argue they do not have cord equina syndrome and therefore can legitimately, in my view, be treated as per local radicular pathway. But again, it is done on a case-by-case basis and clinical judgment applies. Can you discharge the patient? Yes, that, in my view, it is, provided that there are appropriate safeguards of safety netting, there are follow-up arrangements, and the patient is given written advice about red flags, and that is documented, and there's a contact number, and that follow-up occurs. So with all that, then I hope then it will allow you and your staff and your departments to treat cord equina syndrome with far more confidence and also some degree of robustness and safety than otherwise is the case. These are some references that we can share with you. I'll be very happy to take any questions. Thank you very much.
Thank you very much, Mr. Grevitt. That was very concise and clear. We would be taking questions towards the end of the session, so please keep your questions coming on the discussion and the chat forum. The next talk is on spinal trauma and fractures by Mr. Sashin Ahuja. Mr. Ahuja has been a consultant spinal surgeon at Cardiff University Hospital since 2003. He is also actively involved in training and education, runs number of cadaveric and interactive courses, and is the lead for Centre's accredited fellowship program. He is very well published. Sashin has worked on numerous executive boards and is the current chair for UK Spine Society Board, past president for British Association of Spinal Surgeons, past chair for AO Spine UK Council, co-chair for Spine ODEP, and Beyond Compliance. He is an expert advisor to various national bodies as well. So over to Sashin Ahuja for spinal trauma.
Thank you very much, Ashish, and thank you very much to BIOS for inviting us to speak about some of these tricky conditions which are time critical that most of our colleagues face and we face as well. So I thought when Ashish and I were talking about this, we thought it would be good to go through certain simple basic things that we could cover. And these are something that are covered in our training program as critical CBDs as well. So I'm not going to go into too much detail. I'll just concentrate on a couple of things. Spinal trauma itself is a huge topic. I could be here talking about it for days, but let's stick to something very basic and simple So we know it could be caused by low energy trauma, which is falling from a standing height, which we see a lot of. Perhaps we saw a lot of it during the lockdown with people doing a lot of DIY and everything, falling off sheds, falling off this, the other. And of course, we've got this, the high energy trauma that we tend to see, who come in not only with spinal fractures, with multiple other injuries as well. And on the left, you can see the bridge, which is just outside the Heath Hospital, where a lot of people like to jump off, and that can cause problems as well. And that brings a very important point that we're not just dealing with trauma. There are a lot of psychological aspects as well that we need to deal with. So talking about psychological aspects, so the two most important things that we're trying to look at is a mechanical problem, right, like any other fracture. But unfortunately, in the spine, it is a neurological problem, which is an issue that we have to protect because we've got to protect the spinal cord. So it's not just the mechanics that we're looking at, where the fracture and how we manage the fracture, but it's how we protect the spinal cord and help it recover if it's been injured. So the important question that comes up all the time is the fracture stable or unstable? And I say this all the time, even the porter in the hospital wants to know whether this fracture is stable or not. Why? Because the patient's going to be transferred from A to B, and when the patient's going to be transferred, you need to identify, is this fracture safe to be moved around? Or is it unstable that we got to take all sorts of precautions? And you may have heard about multiple different concepts and theories that are put forth to decide whether a fracture is stable or not. Because at the end of the day, the concern is that an injury, which may just look like a mechanical injury, could end up with a neurological injury, which can cause a devastating long-term impact on the patient. So what happens is the concept goes that if you look at the spine and you split it up into two as the anterior column and the posterior column, so anything in front of the posterior longitudinal ligament is the anterior column, and anything behind that is the posterior column. And if both the columns are injured, then very likely, or actually, the spine is unstable. Yes, we talk about three columns. I'll come to some case examples to talk about that, but this is the very basic thing that we could take on board. So in your assessment or your examination and your investigation, you find that on the CT, the patient has got a fracture of the vertebral body, and you examine the patient in your secondary survey, you roll them over, you feel a gap between the spinous process. Very likely there is a posterior ligamentous injury. It's a two-column injury. It's very likely unstable. So we're talking about the mechanics. We're looking at the spinal alignment. So any of these structures, I don't need to go through the details of it, could be injured, or any of this could be injured inside the spinal column, i.e. the spinal cord itself, which could affect function with sensory and motor function, which can cause problems. So what are we trying to look at? So this is sometimes what we see. We see this on a CT. We see this on an MRI. You can see that there is a significant injury at the C5-6 level with a significant injury to the spinal cord. And this is how it's ended up. But don't forget that this is how it would have been at the extreme of movement, so which caused that damage to the spinal cord. So you've got to remember that. So we are just seeing the resting phase. The damage had happened at the time of impact. And that's a very important thing to try to understand the pathomechanics. What happened to that area? What happened to the spinal column? What happened to the spinal cord? So what are we trying to do, right? We're trying to protect the spinal cord. So throughout this process, I don't need to go through the ABCs. We protect the spinal cord because that is the priority. You protect the spinal cord. A diagnosis can be made later. So you treat all the important injuries first. You take care of the airway, the breathing, the circulation. So from a primary survey point of view, that is what we need to do. And even in the secondary survey, you're taking care of life-threatening injuries. Once we've done that, then we move on to looking at how we manage the spine, right? Although the spine is not that important in the initial bit, but we've got to protect it. As long as you're protected, you're fine. And this is something that I would recommend for your trainees. And if there are trainees listening in and dialing in, this is a very, very important tool. It improves communication. It makes it very easy to assess a patient. Like I take it as an idiot's guide. I use it as well, even now after so many years. And I've got no qualms in claiming that. So what are we looking at? So we have these sort of injuries. And you may look at that and go, oops, there is a fracture in the thoracolumbar junction. It is likely to be unstable. Can we do anything about it? Do I need to pick up the phone at 2 o'clock in the morning and refer to the spinal center? They'll say there's no neurological issues, it looks stable potentially or maybe unstable, but the decision we can make in due course. So this is possibly an unstable injury. You do a standing x-ray. If on the standing x-ray, like in a brace, ideally, that's what I would do. I know if you worked in oswistry, you may say if they've got good trunk control, you can stand them up. Perhaps my sphincters are not that big enough yet to cope with that. So I would put a brace, get them standing up, get an x-ray done, and look at the alignment. At the thoracolumbar junction, the spine is straight between T10 to L2. There is no angulation. If there is angulation more than 30, is when we start thinking about surgical intervention, because that could be considered as mechanical instability. But this was deemed stable, as most burst fractures are, and you could treat them with a brace. And you can see we treated it with a brace, and you can see in due course, it's all healed up, it's united like any other fracture. So like any fracture, you just have to splint it. Once you splint it, it heals, as long as there is no mechanical instability and no neurological problems. But you could have, but the good thing is that, important thing is that you have to monitor this. But you can't just put somebody in a brace and say, come back in 6 weeks. You may find something really goes pear-shaped and you'll be in trouble. So you're better off monitoring them at a regular interval. So conservative treatment needs close monitoring. Like in this situation, you can see it is gradually collapsing, but the collapse is acceptable, is in a normal range. On the other hand, you may see something like this, where there is a thoracolumbar fracture. Look at the back, look at the gap between the spinous processes. Unfortunately, my pointer doesn't work, but you can see at the fracture level, at that spinous process and the spinous process above, look at the gap between that. The gap is increased. It suggests that there is an anterior and a posterior injury. This is unstable. This you will have to fix. You can't leave this because it will collapse further and potentially cause some attrition on the spinal cord. On the other hand, you see situations like this where nowadays patients get CTs, and you get a patient with such an arthritic neck in an elderly patient. And because of the arthritic areas, it is stiff. And so the mobile segments are vulnerable because the stiff segments don't let the spine move. And that segment in the middle, which is mobile, the spine will move and cause problems. So that may look stable to us. We can see a slight subluxation at that level between 5, 6, right? But whether it's degenerate or traumatic, we don't know. Look at the facet joints, look at the posterior elements if there is any fracture. But you can do an x-ray and you can see what's happening. That is grossly unstable. That needs stabilization, right? This is another gentleman who had a fall from a 30-foot height whilst he was caving, and he's got a thoracolumbar injury. That is mechanically unstable. He's got neurological problems, and he's got neurological injury as well. So going back, it's a bony injury, it's a spinal cord injury. This needs to be treated urgently. Now, the timing is important. How soon would you intervene? Now, it is very emotive that go in straight away, take the pressure off, everything will come back. Yes, it's easy to say that, but is that the evidence? No, the evidence suggests that the impact is at the time. Now, what you're trying to do is prevent a secondary injury. And if you monitor the patient, you would like to operate on them as quickly as you can, not in the middle of the night, that may not be necessary, but if they've got progressive neurology, then that needs to be taken care of urgently. Like this patient initially had neurology, and then as they were monitoring it, a few hours later, we were called up saying, this is going off, this patient was transferred straight away. So in a situation like this, you would do an MRI. So the indication for MRIs would be neurological injury or any soft tissue injury that you suspect, including the posterior ligament complex. And in this, you can see that there is compression on the spinal cord. Patient's neurologically is affected. That neurology needs to be addressed. It's mechanically unstable. This needs decompression and stabilization. And this would be better served from an anterior surgery where you take the vertebra out, take the pressure off the spinal cord, and stabilize the spine, right? And that way you've taken the pressure off, you've given the spinal cord to recover, okay? And it does recover, but nobody can predict because it's up to the spinal cord depending on how badly it's damaged. Wish we could do something. Most of our patients who have neurological deficit would improve, but unfortunately so far, we haven't cracked the holy grail yet, although there are lots of different research projects going on to answer that question. Or you could have a situation like this. This is a young lady who was involved in a car accident. Car went into a ravine at high speed. You can see she's got a fracture dislocation at the thoracolumbar junction. She came in complete late at night. By the time she came to us about 10, 11 o'clock at night, taking her to theatre that night, would that be sensible? Emotively, yes. Evidence-wise, no. Yes, she went to theatre the following, you can see the MR, which shows significant compression, significant impact on the spinal cord. She was taken to theatre the following morning, and we just did a posterior stabilization and ligamento-taxis just to realign the spine. And you could do a CT post-op. You can see the canals being adequately opened up. There is enough room for the spinal cord, and you don't actually need to go and decompress. She was in ASIA A, where she was complete. She had no sensory function, no motor function below that level, unfortunately. The other one which I would like to highlight is patients who've got ankylosed spine. So this is a patient with ankylosing spondylitis, looks very benign, complaining of neck pain, had a fall. He was shaving, fell backwards, hit his head against the shower cubicle, was complaining of neck pain, went into the hospital, was seen in the local hospital, and was assessed, and then was, because he had neck pain, he was put in a collar. So please don't do that, right? They're ankylosed. The spine needs to be in line, not in the way position that you wanted. And what's happened is this patient's been hyperextended. A neurologically intact patient became neurologically compromised. So a mechanical issue was converted into a neurological issue. So please remember this. This is a very, very important thing that we have to remember in patients that we have to deal with. Thank you.
Thank you very much, Sashin. The next talk is on an extensive topic of spinal infections and spinal metastases by Mr. Jayesh Trivedi. Mr. Jayesh Trivedi is a consultant spinal surgeon at Oswestry and Alderhay Children's Hospital at Liverpool. He is the head of scoliosis surgeries at this hospital, and his interests include congenital and early onset scoliosis. Mr. Trivedi has been a member of executive committee at the British Scoliosis Society. He's been involved in training of several fellows nationally and internationally. He is author of several peer-reviewed journal articles and book chapters. So over to you, Jay Trivedi.
Thank you, Ashish. Good morning, ladies and gentlemen. Thank you very much for your kind invitation to this very fantastic meeting. We're going to talk about the management of spinal metastases and infections from a generic point of view. Over the last decade or so, there has been a significant increase in the longevity of patients with cancer, largely due to advances in oncological treatment. This longevity, however, comes at a price, and there is an increased incidence of metastatic spinal cord compression in these patients. The spine is the most common site of involvement in these patients owing to its very abundant blood supply and the unique epidural venous system, the so-called Paxson's venous plexus, which tends to be valveless, allowing for cancer cells to freely move between organs and the spine. The most commonly affected tumor in our practice is multiple myeloma, and all the others can theoretically metastasize to the spine as well. The clinical presentation is dominated by two symptoms, pain and neurological deficit. The pain may be secondary to severe instability caused by collapse of the vertebra and destruction of the vertebral column, leading to instability. And it can also be a manifestation of compression of nerve tissues such as nerve roots and even the spinal cord. The neurology, of course, is a direct consequence of the epidural extension of the tumor, as well as the collapse and retropulsion of these bony fragments into the spinal canal. And here's a typical example of a 45-year-old with a known cancer within the thyroid. And you can see the involvement of the cervical spine at the C7 level with extension of the tumor mass into the spinal cord, causing quite serious compression of the spinal cord. Here's another example of a 65-year-old lady with breast cancer showing significant deformity in the lumbar spine associated with destruction of the L3 vertebra. This lady presented with severe quadriceps weakness to the point that she was unable to stand, and you can see the destruction caused by the tumor in this patient. So the main indication for surgery remains the two symptoms that we discussed about: significant pain and neurological deficit, or the potential for neurological deficit. The pain is typical pain of a red flag symptom, which is incessant, unremitting, and made worse by weight bearing, as opposed to degenerative back pain, which tends to get better in time. The pain from metastases continues to progress. Other less relevant indications for surgery include biopsy and in a situation where the tumor is not really sensitive to other treatment. The surgical algorithm is dictated by 3 factors, and it's almost logical. You have patient, spinal, and tumor factors. As far as the patient is concerned, the most important factor is the performance index of the patient. This is the so-called Karnofsky index. We know in cancer treatment that a person with a high performance index is more likely to have a prolonged survival and therefore is more likely to do well with your spinal surgery. The extent of neurology is also important when we plan surgical treatment in these patients. If the patient is completely paraplegic with loss of bowel and bladder control, then pretty much the horse has bolted the stable and there is little scope that surgery is going to recover neurology. On the other hand, incomplete neurology or impending deficit are very strong indications for spinal surgery in these patients. Broadly, it comes down to this: is the patient going to survive for more than 6 months or less than 6 months? And in this respect, we need to be a little bit cautious of our oncological friends, as they are almost always very optimistic of their survival. So it would be a good assessment in these patients to see if they are really going to make that figure. Spinal factors that are important in our decision-making obviously involve the extent of involvement in these patients. If the spine is riddled with metastases, then I'm less likely to subject the patient to any kind of heroic surgery. And the other factor that is important is this just a pain phenomenon, or is this pain in the presence of neurology? If it is just pain, then only stabilization of the spine may be indicated, whereas if it is instability along with neurological deficit, then you almost always have to decompress the spinal canal. The extent and direction of compression will dictate which approach you take to the spine. Is it anterior? Is it posterior? And therefore, anterior or posterior surgery may be indicated respectively. Tumor factors: some tumors just generally have a bad prognosis. Lung, for instance, upper GI tumors, metastases from these tumors is almost always associated with a poor prognosis, and it's difficult to push the boat out all the time for these patients. Whereas breast, thyroid, prostate are good tumors to attend to because the survival is more prolonged in these patients. And obviously, the sensitivity to oncological treatment forms the basis of your spinal treatment. Renal tumors, as we know, are naturally resistant to radiotherapy. And in this situation, spinal decompression and stabilization may offer the only option to the patient. When it comes to surgery, you may have open traditional surgery, which may be anterior or posterior, dictated by where the compression is. Or it may be minimally invasive surgery dictated by either the injection of cement into the affected vertebra to restore stability, or minimally invasive fixation of the spine that you can undertake. Here's a typical example of a renal cell carcinoma, again in the cervical spine, causing cord compression in a young person. And as you can see from the previous slide, it was a solitary involvement and therefore aggressive treatment in the form of resection of the vertebral column at the affected level, and stabilization was an option. Here's another example. This is a 55-year-old with renal cell cancer causing compression of the conus medullaris. And you can see the CT scans revealing a very large tumor mass in the right kidney. This patient underwent an anterior stabilization and decompression of the spine through a thoracoabdominal approach. And at the same sitting, we were able to resect the kidney tumor as well. So we could attack both the primary as well as the secondary affection of the spine. Minimally invasive surgery now becoming increasingly more common, and I certainly tend to use it more and more often. It comes with the advantages of quicker rehabilitation and less blood loss in these patients. and the possibility of these patients returning to adjuvant therapy like chemotherapy and radiotherapy a lot sooner. And here's an example of a 55-year-old, again with breast cancer involving the lower thoracic spine with extension of the tumor mass into the epidural space. In these situations, and you can see the extension of the tumor into the spinal canal compressing or on the verge of compressing the spinal cord. In these situations, we undertake a percutaneous fixation of the spine and then only open up the relevant area with a small incision to decompress the spinal cord. And in these situations, the patient can return to their treatment a lot sooner. So here's an algorithm that tends to help me decide how I'm going to approach these patients. Broadly, if you have a patient with known known cancer and suspected of having spinal metastases, you would divide them into two groups, one without neurological deficit, the other one with neurological deficit. Within that group, if the patient has complete loss of motor power and loss of bowel bladder function, then an MRI scan whenever possible and a stabilization of the spine if needed without the urgency of decompression immediately. Whereas if the patient has an incomplete neurological deficit, the recommendation is to get the MRI scan as soon as possible with a view to early surgery in these patients. If the patient is a good surgical candidate, then you will undertake a formal decompression and stabilization of the spine. If, on the other hand, the patient has poor performance index, elderly patient, comorbidities, and the tumor is radiosensitive, then you may go down the route of adjuvant therapy in these patients rather than subjecting them to surgery. On the other hand, if there is no neurological deficit and it's predominantly a question of pain, then an MRI scan whenever possible within the week, hopefully. If this reveals instability, then you may fix the patient either through an MIS approach or an open stabilization surgery, and then follow that up with adjuvant therapy in the form of radiotherapy or chemotherapy. And this is broadly the algorithm that I tend to follow in clinical practice. Outcomes, by and large, this is our Oswestry series of over 200 patients that we published in JBJS. By the time the patient presents to you with metastatic cord compression, the vast majority of them would not be expected to have a median survival of more than 12 months. Surgical treatment versus non-surgical treatment. In our series, we found that the surgical patients lived for longer and had a better quality of life. And when it comes down to tumor type, as you can see, multiple myeloma, breast, and prostate are the kind of tumors that you would wish to go for, whereas lung and upper GI don't tend to do as well. So that was a broad overview of metastatic cord compression and how I approach them, mainly with regards to patient, tumor, and spinal factors, and the algorithm that we follow. Spinal infections, again, another emergency. Broadly speaking, they present in two forms. Spondylodiscitis, which is very similar to osteomyelitis affecting long bones, caused by hematogenous spread, usually through the arterial blood supply, and epidural abscesses, which usually present with neurological deficit. The management algorithm, the organisms responsible, the vast majority are pyogenic, Staphylococcus aureus being the most dominant organism, although TB is making a resurgence largely because of increase in immunosuppressive conditions like HIV, cancer treatment, and even diabetes. Parasitic infections in our part of the world are generally rare. The algorithm in management of these spinal infections is first based on establishing a diagnosis. In this situation, you do the usual blood test. A word of warning here, very often you will find that if the infection is confined to the vertebral column without any epidural abscesses, then very often your CRP and WBC count may not be elevated. The only time the CRP may go up is when there is an epidural abscess. So the mainstay of diagnosis remains MRI scan. And in these situations, if the MRI scan confirms your diagnosis of spinal infection, then you will go on to the management algorithm that I will show subsequently. If the MRI scan is not very conclusive and you're still suspecting a diagnosis of infection, then perhaps a bone scan or a specific bone scan, such as a white cell label scan, may be useful in establishing the diagnosis. And once you have a situation where the diagnosis of infection has been established, you can then broadly divide these patients into two groups: those with neurological deficits, usually caused by epidural abscesses or instability, or those without neurological deficit. If there is no neurological deficit, then a CT-guided biopsy to try and culture the organism responsible is worthwhile, and then targeted antibiotic therapy towards the organism that is isolated. Usually, it means 6 weeks of intense treatment, and I tend to titrate that against the clinical features as well as hematological investigations if your CRP has been elevated. Generally speaking, it may require at least 3 weeks of IV antibiotics followed by 3 weeks of oral antibiotics if the organism is sensitive to flucloxacillin. If, on the other hand, there is a neurological deficit or a threat of a neurological deficit by causing spinal instability, then surgical debridement and stabilization will allow you to harvest samples for culture, and then again, you would treat these patients with appropriate antibiotic therapy. So hopefully that has given you an overview of metastases and spinal infections. Thank you very much for your kind invitation.
Thank you very much, Jay. We may not have much time for questions. We may run 1 or 2 questions. So I have with me Mr. Shah Halim from ROH Birmingham. He would like to ask 1 or 2 questions. If we can get the panel on the screen, please.
Good morning, Mike. This is a question for you. It's always a pleasure to hear you speak. I just wanted to ask you about that patient, a middle-aged patient with bilateral leg pain, urinary symptoms, and a post-war residual of about 250 mils, but with a disc that's small to medium. What would you do for such a patient?
That's a great question, and I suppose it's having that Montgomery compliant discussion with the patient. So if you have that, and it to some extent depends what your MRI scan shows. If it doesn't show critical compression of the chorda equina, and the patient's will is that the radiculotomy has gone on long enough, then it's reasonable to proceed. But if, on balance, that patient, after listening to you, feels that they would prefer to see how things evolve, in other words, that if there is follow-up in terms of further post-voids that he'd rather not, then you can go down that route as well. So, at least the bladder scan allows you to do that risk stratification, because it has implications in terms of if they are greater than 200 mils, at least you expedite that scan and can have that conversation at an early stage rather than perhaps allowing that patient to fall through the net. And in a roundabout kind of way, I hope that answers your question.
Because I'm aware a lot of surgical units, the neurosurgical ones especially, will proceed with a discectomy in that situation based on the urinary symptoms.
Yes. So if in that situation, if a patient has sort of marginal PVR but a big disc on the MRI scan, I think that most of us would be inclined to give that steer to the patient. But imagine, if you will, the patient who has an increased PVR greater, but perhaps only, say, 30% canal occlusion. Now, that's a very different thing, and that's where that risk stratification comes in. And without bladder scanning, we can't have these conversations with our patients, and that's the plea I'm making, really. It allows us to have those conversations.
Thank you. Time for one more? Is that it? Yeah.
I think that's great. Thank you very much for all the delegates and questions and discussion and talks. We shall now move on to the next session, how not to do a knee replacement, and I shall hand over to the moderators in that session. Thank you.
Thank you.
Good morning and welcome to the next session on knee replacement surgery. And the topic today is on how not to do a total knee replacement. Majority of the times and in most meetings, we are taught on how to actually improve ourselves as far as knee replacement is concerned, but today is going to be different. So knee replacement is, my slides are not knee replacement is today a well-accepted management for osteoarthritic knees. We've seen good long-term results. Most issues have been addressed. We've overall got better understanding. We do younger, more active people. And when you look at the data, today 250.2 patients per 100,000 of the population get knee replacements in Switzerland, as opposed to 3.5 per 100,000 population in Mexico. And we expect that about 3 million of them will be done by 2030. And getting it right first time is becoming increasingly important. We understand the mechanisms of failure, and I've listed them just for the sake of completion. And that's why it's probably becoming even more important to know how not to do a total knee replacement so that we can get the best results. My name is Gautam Chakrabarty, and I'm a consultant orthopedic surgeon from Huddersfield. And I have been given the privilege by BIOS to actually conduct this moderator. And for this, I've got two masters and a grandmaster from across the world who are going to present the UK view, the Indian view, and a very senior view, and time permitting, we'll have some clinical cases as well. So from left to right, the UK view will be presented by Mr. Vijay, the Indian view by Hemant Wakankar, and the Grandmaster, Tim Wilton, will give us absolute pearls of wisdom. Vijay is a colleague of mine from West Yorkshire, a phenomenal colleague who specializes in lower limb arthroplasty and is presently leading the Leeds Teaching Hospitals Trust and the West Yorkshire and Harrogate group of hospitals as well. For the sake of convenience and to avoid technical problems, I'm going to introduce all three of them at the same time. Hemant Wakankar is from Pune, India. He has got a CV so long that I found it difficult to even condense it into 5 lines. And these are his 5 lines. But the most important bit is 18,000 knee replacements and hip replacements. And that, you will all agree, is a phenomenal number. And therefore, there are lots to learn from him. And finally, our Grandmaster, Tim Wilton. Who doesn't know him in the United Kingdom? He is presently our boss in the NGR, so be good to him. He's been the past president of the BOA, and I had the pleasure of working with him when he was the president of BASC whilst I was the secretary. And I can't thank all three of them enough for giving up their valuable time and energy and effort in participating in this seminar. So Vijay, it's over to you now.
Gautam, thank you for that introduction. I hope you can see my my screen there. So my name is Vijay. I'm an arthroplasty surgeon in Leeds, and thank you for the invite to talk on how not to do a knee replacement. And as you say, knee replacements are becoming, we're getting better at them, and it's undoubtedly the case that since we started doing knee replacements, the results have improved. But all you have to do is have a look at the latest publication from PROMS and compare the results of knee replacements to hip replacements to see that there's still a long way to go before our knee results are as good as our hip results. So on the top graphs there, what you can see is that around 50% of people who have a hip replacement report their outcomes to be excellent, whereas that figure is more like 30% in knee replacements. And before I go and talk about how not to do a knee replacement, which is the surgical part of the procedure, I think it's really important to to realize that it's not just about the surgery. And I'm a strong believer that one of the reasons why knee results aren't as good as hip results is that we're not very clear still on who should not be offered a total knee replacement in the first place. And I think we've got to get that right before all our results improve. And the second important excuse me, the second important factor is how not to rehabilitate these patients once they have their knee replacements. And I think if we get those two things right, we will solve a lot of the problems of knee replacements. Having said that, this is about the surgical side of things. And what I'm going to do is just take you through a journey of the things that we can get wrong, and we do often get wrong when we do knee replacement surgery. And I see knee replacements as well as hip replacements as a bit like a game of chess. Every step that you take can have consequences 2, 3, 4 steps down the line, and you have to have a sight and thought about all of these things before you make any of your steps. And that starts right the way from the approach to the knee itself. So when we're making our incision, it's really important that you get that in the right place. And if there are any previous incisions, you've got to beware of the lateral most incision. Don't go medial to a lateral incision. That's how you run into trouble with wound healing. Don't raise flaps. I think this is really important, because a flap that you raise above or superficial to the extensor mechanism is a pocket for hematoma to collect, and you can run into trouble with wound leakage, wounds not healing up, and infection. So keep it simple. Go through the skin straight onto the extensor mechanism and don't raise a flap. And exposure is exposure. It is not a part of the releases that you may have to do during surgery. And I don't think that there's any place for doing the extensive releases that we used to see, where people went all the way around to the back of the tibia to expose the knee. Don't go beyond about 9 o'clock as you look at the tibia from top down. By doing that, you will have adequate exposure of most knees in the primary situation. Having got into the knee, the first thing that most of us do is do the femur. Now, when you're doing the distal cut and you insert your intramedullary rod into the femur, we all think about how much bone we're going to cut from the distal femur. And what we're trying to do is resurface that femur to its pre-disease state. And by and large, you cut 9 or 10 millimeters. One of the things that I always challenge my trainees with is, and I don't know the answer, well, I do know the answer to this, I hope. It's 9 or 10 millimeters from what? And that's a really key question. It's 9 or 10 millimeters from the subchondral bone of an arthritic knee. And if you're measuring from an osteophyte or from a large defect, that 9 or 10 millimeters will not be enough or will be too much. Now, of the two, what I find is that not cutting enough is by far the commonest scenario that you have. And if you don't cut enough, then you will run into trouble later on during the procedure. And I will touch on that in a minute. What I find useful at this point is that in most knees, most knees that we do are varus knees. In most knees, what I would like to have is a bony bridge across the medial and lateral femoral condyles. If I've got that, by and large, I will have cut just about right bone to put a knee in that will function well. We then move on to what I call the most dangerous instrument in the trays that we get given, and this is the sizing guide for our femoral component. I call it the most dangerous instrument because I think this is where most people get things wrong. It does two things. It sets the rotation of the femoral component, and it sizes how big the femoral component will be. Usually, we take around a 3 millimeter external rotation compared to the posterior condylar axis. And in most knees, again, this is absolutely fine. In terms of the sizing, I always look at the size that this instrument tells me, and then I put the femoral trial of that size against the cut surface to make sure that I'm not going to overhang on the medial and lateral side, because I think this causes a lot of problems in people. And with modern implants, particularly with the narrow sizes available with most implants, this is less of a problem, but I urge you to have a look at the implant and make sure that you're not overhanging when you measure it. And there's one specific thing that often causes problems, and that's in valgus knees. So if you put your sizing guide against the posterior condyles and you measure the implant that you're going to use, you then have to dial in a bit of external rotation, extra bit of external rotation in valgus knees where the lateral femoral condyle may be deficient. Now, as soon as you do that, the implant size can go up by 1 and sometimes 2 sizes. If this is the case, be really careful about the positioning and the sizing of the implant, and don't take what the sizing jig tells you as gospel. You do have to look at every aspect of the femoral implant before you move on to make your cuts. And one quick tip as to whether you've got your femoral implant rotation correct is to look at the cut surface from the anterior part of the femur. You should have this kind of shape, the so-called grand piano shape, as opposed to a bow tie. If you've got a grand piano, then you have got the appropriate amount of external rotation for that implant. When I come to do the tibia as the next step, I always have a quick look at the X-ray before I start cutting the tibia. I look at how much lateral tibial plateau there is above the fibular head and the rough shape of what I need to cut to get the perpendicular axis to the mechanical axis of the tibia. And usually you have this appearance with a larger lateral plateau excision than a medial. And by and large, if you do that, you will have the correct amount of bone excised and the correct alignment for the knee. We then, having made our cuts, we move on to the trialing of the knee that we have just created. If it's not right during the trial, it will not be right afterwards. So do not think that by cementing your implants in, anything that was wrong during the trial will all of a sudden by magic correct itself. And if it's not right, you have to stand back and think. You've got to think about the cuts that you've made. You've got to think about the soft tissues around the knee. And one common mistake that happens is that if you are tight in extension or flexion or both, the immediate reaction is to cut more tibia. Now, I urge you to look at these two pictures here. You can see that the tibia is in play both in flexion and in extension. And therefore, by taking more tibia off, you will affect both your extension and your flexion gaps. Whereas the femur takes part in extension on the distal surface and in flexion on the posterior surface. And by correcting either one of these two parts of your femoral cut, you will affect the flexion and the extension gaps differentially. Don't be lazy. Don't just go for the tibia and cut more tibia off, because that's not always the right thing to do. And by doing that, you will have achieved a balanced knee that works and moves in the way that it should. So in summary, I hope I've talked about how to approach the knee, how to get your cuts right, how you should check, and you should correct anything that's not right appropriately. Thank you.
Thanks, Vaisi. Excellent as always. Beautiful tips. And whilst Hemant is loading up his, sharing up his screen, what we will do is try and take some questions at the end, time permitting. So Hemant, over to you.
Lovely. Thank you. Thanks, Gautam, for the nice introduction. And thanks, Amit, as well, for introducing me to BIOS. This is my first participation. Now, in the next 5 minutes or so, I'm Yeah, thank you, Gautam. Thanks for the kind introduction. And it's my privilege to participate in this wonderful meeting. Thanks, Amit, as well, for introducing me to BIOS. My brief is to talk on some of the aspects of total knee arthroplasty, and especially with the view of what not to do. So without much ado, Mr. Vaisi has already covered many aspects of it. So let me move on. I think intra-op complications, ought to be diagnosed during surgery itself. You don't want to see the manifestation and the disastrous consequences that one may have. And it is quite critical that, one assesses every aspect and every step of the surgery. I consider total knee arthroplasty to be a series of, say, 200 plus steps, and it's possible to get every one of them wrong. And I'm just going to, consider some of them. Here is a disastrous consequence. This patient visited me 3 weeks after having the surgery done elsewhere. And you can see the patient is already, had Tourniquet palsy, compartment syndrome, and possibly infection as well. We don't want to have that as a consequence for sure. I'm going to touch upon only 3 aspects in my talk here. One is the use of Tourniquet. Second is the extensor mechanism disruption, especially with respect to the patellar tendon peel. And the third, and that can really be a disaster, can be a medial collateral ligament disruption. So, we ought to consider prevention aspects as well as management if you have any issues. Now, it's perfectly possible to do a knee replacement, knee arthroplasty, without use of Tourniquet, and especially if a patient is morbidly obese, if somebody has absent peripheral pulses, or you see on a lateral X-ray the calcified femoral popliteal artery, as you can see on the picture here, I would certainly avoid using a Tourniquet. It's possible to fracture the vessel, especially if it shows calcification in the thigh area. And somebody who has a history of DVT or peripheral vascular disease, somebody who has a history of malignancy, I would not use a Tourniquet. And believe me, it's perfectly easy and possible to do a Tourniquet. Many surgeons have this mental block about not using a Tourniquet. So that's perfectly possible. The next is the extensor disruption. And there are some patients who are extremely complex with respect to the exposure itself. Patients who are stiff or have ankylosed knees, who have patella baja, or especially with previous history like high tibial osteotomy. These patients have a difficult exposure. Patella doesn't evert, patella doesn't even sublux very easily. And that does put excessive stress on the patellar tendon insertion on the tibial tuberosity. And one has to be aware, one has to really anticipate that you may have trouble in this. And if you have really excessive tension, then you have to use an extensile approach like a rectus snip, or in some cases of very bad high tibial osteotomy, you need to use a tibial tubercle osteotomy as well. And you need to train yourselves towards these difficult approaches as well. You don't want to see these in a postoperative view where you can see the patella is all flying up, the tendon is disrupted. One way to actually, make surgeon aware of the patellar tendon peel off from the tibial tuberosity is using a tibial tuberosity pin. Mind you, this pin does not actually physically prevent the tendon from peeling off, but it at least makes the surgeon aware of the particular tendon that can potentially peel off. Because the surgeon is looking at different techniques of surgery. Suddenly at the end of the surgery, you may find the particular tendon has peeled off, either partially or fully. As you can see here, is the particular tendon has peeled off partially. And one really has to reconstruct this using either anchors or using osseous non-absorbable sutures, maybe a fiber wire, and really get this strength back on. So that is, I think it's very important. And the last I'm going to talk about is the intraoperative medial collateral ligament injuries. You don't want to see this picture postoperatively, especially as the patient stands up. There are 4 ways I believe you can injure MCL during surgery, and all 4 are perfectly possible. The first one is a stiff knee that is with a fixed varus. And if you have an over-enthusiastic trainee or a registrar who forcibly manipulates this knee into flexion under anesthesia, then this medial collateral ligament does peel off and does rupture. And suddenly you will find that the knee is flexing very easily. In fact, he may tell you that, oh, knee is now started flexing. It wasn't flexing before surgery. You got to look for the medial collateral disruption. And you should not even try to forcibly anteriorly sublux the knee without adequate medial tibial release, especially true in a very stiff knee. The prevention is obviously avoid forcible flexion, avoid forcible subluxation, and one needs to really do adequate medial release. Second is MCL laceration during posterior medial femoral condyle cuts. And one has to protect the medial collateral ligament when one is cutting the posterior condyles. As you can see here, I got my 15mm Homan in the axilla of the medial collateral ligament, and that is the way I protect my medial collateral ligament. I use 2 blades during surgery. One is a 25mm that I use for distal femur and proximal tibia, and second one is 15mm one that I use for posterior condyle, chamfers, and box. You also have to take care while excising the medial osteophytes from the femoral side. The osteotome has to be parallel to the medial collateral ligament, because if you put it obliquely, you can accidentally damage the medial collateral ligament. The third is during laceration during the tibial cut. And I use, again, 1 Homan on the medial side, protecting the medial collateral. And in fact, I use 4 Homans when I'm doing my tibial cut. And the other 3 are obviously protecting the other important structures, and the middle one protecting the medial collateral ligament. So that, I think, is quite important, especially if one is starting off and one has to look at the length of the blade as well. Sometimes staff nurse may give you an extra long blade, and without realizing, you may just inadvertently go posteriorly and injure the vessels as well. Sometimes one has to do a reduction osteotomy, as you can see here, and as one is doing that, one has to protect the medial collateral ligament as well. That is one of the areas as well when you can easily injure the medial collateral ligament. And fourth is MCL pie crusting. Now, this is a technique that was described by Bellamans, and it's quite popular to get 1 or 2 millimeters of medial release at the end of all your routine conventional releases. This is an extreme, usually for extreme case. And one has to avoid using a number 11 or a 15 blade for MCL pie crusting, because believe me, in just 2 or 3 punctures, you can actually completely lacerate the medial collateral ligament. So instead, one has to use the 18 gauge needle. This is the inside out technique that I'm demonstrating here. But my favorite is actually outside in technique with 18 gauge needle for pie crusting of MCL to get 1 or 2 or 3 millimeters on the medial collateral side. And one actually has to count the number of punctures. I use about 16 to 18 maximum along the length of the entire length of the medial collateral ligament. So the take-home message is one has to be really proactive about MCL protection. I use Homan retractors, and saw plate thickness also has to be critical, and width is also quite important. How to diagnose medial collateral ligament injury? You have sudden laxity or increase in the gaps, and whenever you find that during surgery, especially for a very tight knee that was to start with, and you have sudden laxity or increase in the gaps, you have to check for integrity of medial collateral ligament. And the management of medial collateral ligament rupture is that you really have to complete the surgery using PS implant. That's my preference. Or if you have available, you can consider a constrained implant. The MCL has to be repaired with a non-absorbable suture, either ethibond or a fiber wire, and has to protect postoperatively with a brace. Consider a constrained process if it is available. Thank you.
Thanks, Hemant. Again, a comprehensive, wonderful presentation. As always, I'm going to thank you. So we now move on to the Grandmaster to tell us the final few tricks before, and hopefully we can squeeze in at least one case. So over to our Grandmaster, Tim Wilton. Thank you, Tim. I'm expecting no less than your normal fantastic presentations.
Well, thanks very much, Gautam. Thanks again to Amit for inviting me. I'm going to try and give you a senior view. I can't really deny being senior any longer. I hope that you're seeing my screen. These are my disclosures. So why are knee replacements failing? Well, in 2013, Lombardi and colleagues said this was why. Wear is no longer a leading cause of failure. Early mechanisms of failure are primarily technical errors, i.e. it's our fault. And these are the main modes of failure in their paper. And I think that we can say that these are the three most important, and certainly those three are the most important around the world, including our own registry and Australia. And loosening is clearly a very important cause of revision. But this should surely be amenable to improving our technique. Certainly alignment may be critical, cementing technique is important, and kinematic mismatch could induce loosening. So what about bone preparation? Well, if you want to do cementless fixation, precision cuts are really required, and bone debris is positively helpful. But the surface of the prosthesis is critical. If you want to do cemented fixation, perhaps precision is less critical. Cleaning the surface of the bone is really paramount, and a textured surface for the implant is required to get the cement to attach to it. And this has been a mistake in some of the recent implants, such as the Attune, where the first attempt at a tibial component had to be redesigned because it didn't really stick to the cement adequately. So here you see variable bone quality, and actually, although cemented and cementless is an issue, this is a problem for both cement and cementless. And in practice, we find that cementless have a higher revision rate, generally speaking, but this would not be a good scenario for either. Penetration of the cement, if you're going to cement, which most of us will, is really important. And this can be achieved by direct pressure with repeated thumb application onto dried cement after sucking away all of the blood. But cement penetration of over 3 millimeters into the bone improves the loosening rate, and that was proven many years ago by Walker and colleagues. Pulsed jet lavage is really important. This is a really nice tibia which you can clean well. They're not always as easy as that. The sclerotic bone, if you do have it, like on the previous slide, can't allow interdigitation with the cement, and the sclerotic surface is not improved by lavage either. So keyholes are critical in this circumstance, and the strength of keying relates to the width of the cement in the keyhole, not to its length. So we mustn't drill long, thin cement keying holes. We must drill short, fat ones. And certainly all cementing onto any residual sclerotic tibial surface is doomed to cause radiolucency almost immediately. Should we cement the stem? Well, Ritt and Freeman did an RSA study years ago and said that you must cement the plateau, but cementing the stem makes little difference. But they were using a stem which is at least twice as long as those that we currently use, and it was designed to rest against the lateral cortex of the tibia. So that was really probably quite irrelevant to our current practice. Certainly, in vitro studies have shown that it is very important, and if using a titanium alloy tibial component, which I now do and have for a long time, these virtually never loosen if you cement carefully and if you cement the stem as well. So the most common place to find osteolysis at revision is behind the femur and between the femur and the posterior condyle of the femur, often a place which is ignored at the time of the original surgery. So a simple remedy for that is to drill holes there, do pulsed lavage with the knee really flexed, and then apply cement and pressurize it to the condyles before you put the component on. What about coronal alignment? Well, we'll come back to that in the discussion, but I do think that the alignment should allow weight bearing to go through the center of the knee if you can manage it. Should you do 5 degrees valgus or some other, or should you tailor it? We'll again come back to that. But the knee, I think, should be fully balanced throughout the full range of flexion. You can tilt the tibial component to try to release the tension on the medial ligament if you feel that that's important, but this does put the knee into slightly more varus, and I think 2 to 3 degrees is a maximum for that. It's been shown in this paper from Japan that total knees flex significantly less well if you are leaving them with any coronal imbalance, and that's regardless of these other factors which we know affect flexion. How to get better flexion? Well, remove the posterior impingement. If there are osteophytes where the arrow is, take them away, otherwise the tibia will bump into them. Should you use a PS implant? I'll come back to that. But certainly, if you're doing your offcuts, as people showed earlier, you need to measure the offcuts. I measure the offcuts here, and I can show you that this is slightly tight at the back of the tibia on the right, and this means that I've left it slightly tight, and the PCL strain will be increased by that, and the knee will be tight. Should you use a PS or CR? If you're using a PS because you think it gives you more stability, then think again. This paper showed that if you look carefully, you see more mid-flexion laxity if you use a PS knee than if you use a CR one. Also more with a PS knee is a higher revision rate, shown here in blue. And if you really want a high revision rate, you don't resurface the patella and you still use a PS knee, and that gives the red line here. As far as infection is concerned, clean air theatres have been shown to be helpful. IV antibiotic prophylaxis is helpful. Antibiotic-loaded cement is helpful. And any of these three above have been, 2 of these 3 above have been shown to be better than one alone. So really, why not do all 3 things? Discipline is important. Theatre discipline, by all means, use a laminar flow theatre. I think that's a sensible thing to do. You can use space suits. Better probably the body exhaust suits than the hoods that blow air into the wound. But above all, keep the instruments inside the area. Don't let them stray outside, otherwise you wreck the whole thing, as you can do by leaving the doors open. Surgical discipline is equally important. Here you see on the left-hand side something which has not been done according to the instructions that we've already heard from our previous speakers, that this skin has been heavily undermined, and on the right-hand side, another one, there it's actually died. Why? Because if you have to raise a flap, which I agree one should try not to do, but if you have to, you need to do it deep to the deep superficial layer of fascia. Otherwise, if you do it here, you're cutting all of the end arteries to the blood, to the skin. So in conclusion, currently, there are definite ways to improve range of motion and function by surgical technique. There are techniques which may improve patient satisfaction, independent of the implant used. There's a good reason to believe cementing technique is important. Infection rate is related to theatres, to discipline, and to technique. And the place of compromising alignment to achieve soft tissue balance is uncertain. So how can you screw up? Well, you can ignore those well-established principles. You can adopt the newest implants which as yet have no follow-up data. You can be heavy-handed with the surgery, and you can assume that your instruments or computer or robot know what they're doing and don't need to be checked at every stage of the operation. Thank you for your attention.
Well, Tim, thank you very much. I expected another masterclass. And in fact, it has been 3 masterclasses. Absolutely fantastic. So first of all, what I'd like to do, I am going to see whether we can squeeze in one case, and we are running really short of time. So I shall try and see whether I can share my screen and see whether I can squeeze in one case. That's if I can get to that. I can't seem to be able to. share my screen at the moment because it's opening up on something else. I shall try again. Have you got any questions in the meanwhile? Are there any questions in the chat, Martin? Because I can't see any questions. So to summarize, primary osteoarthritic knee, is that the easiest knee to do, or is it the 30-degree valgus where people should start? And your views on use of the computer and the robots, well, the robots now. Tim, we'll go with you.
You want me to answer?
Yes,
my
please.
views on a robot. I think that the place of robots is currently not established. I think that a robot and or computer-assisted surgery of whatever kind is very useful. And I think that the way in which it's useful is the same way in which all other types of instrumentation are useful. I think that if you use the mechanical instruments well and carefully, which involves repeatedly checking and checking that everything you do is actually achieved, then you can get very good results. And I think that instruments and computers and robots may help you to learn what can go wrong and how it can go wrong. But one of the ways that computer-assisted surgery and robots work is that when they do something, they then check that what they've intended to do has been achieved. And sometimes we find that surgeons who are using mechanical instruments don't do that. And in my opinion, that's one of the major reasons why sometimes you see less good results. If I say that I want to cut 9 millimeters off the medial side, off the lateral side, and 4 millimeters off the medial side, and I do my cuts, then I measure those cuts to see whether they've been the same size that I'm trying to achieve. And I think at every stage of the operation, you should be doing that.
Thank you, Tim. I've managed to get, hopefully we can see the screen. Can we see this screen?
Yeah, we can.
Yes.
Okay, Hemant, 51-year-old right knee pain in the Western world, to make life easy.
Right. Well, it's quite a significant medial tibial defect there. And if you take a long leg scanogram, you would certainly see that he's got at least 20 degrees of varus, if not more. And I believe this would be a fixed varus. So one has to really be prepared for complete medial release, and even a constrained prosthesis as a backup option has to be kept available here.
Okay.
I don't, when I do my tibial cut in such scenarios, I just take my lateral tibial plateau as the landmark, and whatever defect I'm going to be left with on the medial side has to be built up. And if there is a significant defect in the medial tibial plateau, one may need to add a stem on the tibia. And if one has to release the medial collateral ligament fully to get the balancing right, then one may have to consider a constrained option as well. I mean, I assume that you have the lateral film and, the scanogram done as well. So in a scanogram, you would look at your long legs films.
Yeah, and not always is it possible. So in my hospital, it's very difficult because out of 2 buildings, only one can provide that. Vaisi, typical Yorkshire knee, this. Nice chubby legs. But the fat is nowhere else except around the knee.
Yeah.
Anything different?
No, not at all. I in a 51-year-old, I might be tempted to see whether I can bone graft that defect by using the lateral tibial plateau rather than using a metal augment.
Okay.
But yeah, I think he will need a stem. Yeah. I'm not sure that he'll need extensive releases. He's got large osteophytes, and by the time you've removed a lot of those femoral osteophytes, I think you may find that that you may not need to do an extensive release on this guy.
Tim, anything else to add? And I'll show you the post-op X-ray.
I think I would use a metal block. I'm not very happy with using bone grafting in this circumstance, but you could use bone grafting. But whichever you do use, I think it's absolutely important, A, not to go down to the level of the bottom of that defect with your lateral cut, and B, to remove the cortical or corticized bone that will be underneath the femur on that medial side, so that whatever you've put in there instead, it can be properly secured with cement. And finally, that was very loosely slung in by Vesi, yes, put a stem in it. It will possibly collapse into varus if you don't put a stem in it.
Okay, I've got instructions to bring the session to an end, so I'll quickly show you the post-op X-ray. That is the post-op X-ray. Any howlers in that, or are everybody happy?
Looks pretty.
Looks good. I don't like your staples, but yes.
I think it looks very good. I think I probably wouldn't have put it in quite such valgus, because if I didn't, then I wouldn't have to do so much medial release.
Okay. This brings 40 minutes is just to run away. It leaves me to thank all three of you for a massive, massive thank you at a very personal level for all three of you. And I know I've hounded you all a lot trying to get your presentations right and everything else. Massive thank you. Massive thank you on behalf of the organizing committee from Wales and Amit, whom all three of you know very well, and on behalf of the entire BIOS executive. Thank you very much, and have a good day. Gentlemen, I will speak to you personally be outside this meeting. Thank you again.
Thank you.
Thank you.
Good day. Good day. Bye-bye.
can imagine a world where I can be connected with a patient, I'm in Oregon and they're in New Jersey, I can know through cloud-based information, biometrically what's been happening to them, help me to understand their problem better, well, now you're talking about the future of orthopedics. The problem that we have now is, frankly, not a lot of us know what to do with the data once we collect it. So it's great that we're collecting it, but it's not pushing anything really forward.
If it could just do all the busy work of taking all those data points out of that chart and putting them on a page in front of me that made sense, that would be great. Who knows the amount of problems we could see and solve by having better data solutions.
And that's where ZB Edge comes in.
One of the really powerful things about ZB Edge is it is an ecosystem. It's ever improving and ever growing. With the combination of Rose and my mobility data, I'll be able to have an artificial intelligence recommendation from our previous history to give the patient their best possible outcome.
I think as technology has progressed, we can use that information to help the patients.
It addresses the entire range of communication.
And it empowers the surgeon to be able to focus on the patient in front of them.
You watch somebody go from being in pain and then seeing them out of pain and seeing that weight lifted from them, man, you just can't put a price on that.
Zimmer Biomet is writing the future of orthopedic technology.
The journey to becoming an orthopedic surgeon takes drive, dedication, and a relentless focus on excellence.
It's been filled with education, residency, fellowship, and building my practice.
Now, my days are filled. I need a way to stay connected to why I do this.
It's always been about helping patients change their lives. They come to me, scared their pain will keep them from living a full life. They come unsure about their possibilities and anxious about their future.
They come with a championship career on the line. I need something that engages my patients at the beginning of their surgical journey and supports us each step of the way.
Something that delivers an experience outside the operating room that matches the excellence we deliver inside it.
Something that keeps my patients engaged in their care and allows my team to track their progress each step of the way. Something that keeps my patients informed, giving them the right information at just the right time.
I need something that lets me keep a personal connection with my patients, no matter where they are. Something that's with them when they go home, preparing and encouraging them for what's next. A tool that makes following up easy and efficient.
Something that makes their exercise plan convenient. And their day-to-day progress measurable. It should make tracking outcomes easy.
I need something that identifies patients who need extra help and asks standard follow-up questions so my team doesn't have to.
Something that can integrate data from other technologies to help me up my game. And it should be one platform, because I need technology that works for me instead of me for it.
So I can focus where I need to focus, while knowing my patients will get the best care experience possible, whether they live down the road
or in a different time zone. Something that delivers an experience and connection that helps us hold on to why we do what we do.
Good morning, ladies and gentlemen. It's an honor and privilege to be introducing Dr. B. Shivashankar, or Shiva as is popularly known across the orthopedic fraternity. He's an old friend and is the current Indian Orthopaedic Association president. I've known him for a number of years. Shiva passed his medical school from Karnataka Medical College in Hubli, followed by doing his postgraduate and finished his MS in 1992. I've actually learned something new about Shiva, that he trained and was expert in doing arthroplasties, but I certainly know him as one of the stalwarts of nailings. And if there's any issues or concerns about the nailing of especially the lower limb fractures, then he's the guy to go to. He currently practices in Sholapur, and he's delivered numerous lectures. He has his own technique, especially with difficult nailings or removal of broken implants. Today's talk is on 10 commandments of hip nailing, and I would urge every orthopedic surgeon who does any nailing to pay attention to this talk, as there are some vital tips. Thank you, Shiva, for giving up your Saturday morning to come and talk to us. Thank you.
Hello, everybody. At the outset, I thank President of BIOS, my friend, Dr. Bijayendra Singh, President-elect, Professor Amit Tolat, and Secretary, Dr. Sunil Garg. Let me share my screen. This is my presidential theme, Atmanirbhar Orthopaedics, self-sufficient, Indian at heart, global in competence. The topic I have selected for this meeting is 10 commandments to predict successful outcome with the intramedullary hip implants. Recently, I wrote an editorial for Indian Journal of Orthopaedics on the same topic. This is a very busy slide. Let me take each point one after the other. I'll go to the first point last. The foremost important thing is good anterior reduction, which is very, very important, because anterior cortex is the one which we can see. Posterior cortex is badly communicated, we cannot see. So anterior cortical reduction is very, very important. This is the Siam picture, which shows the anterior cortex, but you cannot see the posterior cortex. Anterior cortex breaks less, like a tibial condyle, it splits, whereas the posterior cortex is like the lateral tibial condyle, which gets comminuted. So reducing posterior cortex is difficult. If you reduce the anterior cortex, it's like the first button of your shirt. The last button or the posterior cortex will also come in alignment properly. Here in this case, you can see the reduction is not proper. When you reduce the fracture, there should be 100% overlap in this fashion. Even if there is a loss of 25% reduction, there is 25% reduction in the posterior cortex also. That is what has happened in this case. This is a very old slide of 2007. While I was operating a very displaced fracture, I reduced the anterior cortex by pushing percutaneously with the Steinmann pin. Once the reduction was obtained, I fixed the fracture with the K-wire, then made an entry for the nail. So I have been using this technique for the last 15 odd years, and without it has given me beautiful results. This is an X-ray with a displaced lateral picture. I'm inserting intrafocally a Steinmann pin, manipulating, and once the reduction is obtained, fixing with two K-wires which are very anteriorly placed so that they will not come in the way of the nail or the neck screw. Then once the fracture is fixed, without the worry of going into varus, we can adduct the limb, which makes the life of the surgeon easy for passing the nail. So much of adduction is possible in these cases. I even fix undisplaced fracture also with K-wire, because if you don't fix the fracture, when we use the centering awl, superiorly the fracture opens into varus. This article of 2015 by Tang talks about the displaced fractures neck, where they use a Steinmann pin to fix the fracture, which have been using for more than 15 years. Probably from 2003 or 4 I am using. This is in 2005, I did the demonstration surgery at Aurangabad, where I used the technique of fixing the fracture with 2 wires before I made an entry. These are the 2 K-wires I'm fixing before I had made an entry. This was an undisplaced fracture. Even an undisplaced fracture like this is at the end of the surgery. I used this technique. The next one is good medial reduction. In a subtrochanteric fracture, where the compression process are going through medial aspect, we should reduce it beautifully. I don't mind fixing them with wires in this fashion. For intertrochanteric fracture, this article talks about negative, neutral, and positive cortical support. It is very, very important to understand. This is a negative cortical support with the beak going into the distal middle canal. This is a neutral cortical support, and this is a positive cortical support where the beak is coming out of the distal middle canal. We should try to get either the neutral or the positive cortical support. Some clinical pictures of the X-rays: negative cortical support, neutral cortical support, and a positive cortical support. Positive cortical support should be not only in AP but also in lateral. This is a beautiful positive cortical support in AP, but if you analyze the lateral picture, you can see that there is intussusception of the neck within the distal middle canal that will lead to failure like this. So that is the reason why positive cortical support or at least neutral cortical support should be there even in lateral view also, not just in AP. If there is a avulsion of the lesser trochanter, one should try to get additional 5 to 10 degrees of valgus. Otherwise, though here it is a neutral cortical support, you can see that the beak has slipped into the distal middle canal. This was an old case of 2010. One of my friend was operating. I was not happy when I saw this picture when I joined him. Beak had gone into the middle canal. I just used a bone hook, pulled the neck out, and the beak I got reduced beautifully and inserted a nail. As you can see, this is a very badly comminuted fracture, just fixed properly with 2 screws with the head and neck. I didn't address any of the other comminution. At 4 months, you can see nice consolidation around the implant in this fracture. This is a 75 AD with a valgus reduction. You can see positive cortical support at 14 months. Beautifully, the fracture has consolidated without any problem. The next one is entry. Entry has to be proper. Though carefully middle the nail, we take the entry from the tip of the trochanter, but the bone is weak on the outer side. We inadvertently try to ream the lateral cortex in this fashion. So that will lead to varus position of the implant or the fracture going to varus, as you can see in this animation. That should be avoided by taking a proper entry. Passing the nail to the fracture site, just because there is a intertrochanteric fracture at the entry, we should not pass the nail without properly reaming and making a space for that. Otherwise, this implant acts as a spacer and that will distract the fracture surfaces. So always one should make a proper canal for the nail before passing the nail. Even in elderly osteoporotic fractures, I use this 10 millimeter curved awl to take out 10 millimeter of bone. Then I ream with a centering awl. This is a 94-year-old lady. Recently, I operated this patient. And you can see I reduced the fracture, fixed with K-wires, then taken entry much more medially. And I'm using this cheese cutter or end cutting instrument and taking a 10 millimeter of bone. Then after taking out 10 millimeter of bone, then I have passed the guide wire and reaming with a 15 millimeter centering awl, because the nail I use has a proximal diameter of 15 millimeter. So making an entry for the nail or the space for the nail by properly reaming, even in osteoporotic fracture, is very, very important. Never shovel the nail through the fracture site. So this is the same lady walking comfortably with such a beautiful reduction and nice placement of the implant, as you can see on the X-rays. The 6th point is position of the screw. In AP, it should be in the center or slightly inferior to the center. In lateral, it should be posterior or slightly posterior. The next point is tip apex distance. Since I advocate 2 screw system, as well as I use the inferior screw as kissing the calcar as possible. So if I measure the TAD from fovea centralis, it will be more. So one should measure from the calc TAD, which is the extrapolation of the screw. If I measure the calc TAD, it will be acceptable. In a 2 screw system, both the screws should be at the same horizontal level. If they are one is longer and one is shorter, or both are equal, then they will lead to trouble. why they should be at the same horizontal level. Both should take the load simultaneously so that they can slide simultaneously. This article by Julia Henschel talks about different screw lengths and how they work. This is an in vitro study done where they have come to a conclusion that smooth sliding and least varus malformation happens if both the screws are at the same horizontal level. So this is an example of both screws at the same horizontal level. When the hip is loaded, the vector of the forces passes through the neck, head and neck, through the neck screws, and the screw will slide out without any stress within the nail. If there is a inferior screw shorter and superior screw is longer, and what happens is the superior screw takes the load totally, and the vector forces will be more of varus malformation forces. This is especially very common, especially if there is a medial void of the lesser trochanter avulsion and the inferior screw is not having a good subchondral purchase. What happens is, due to varus force, the inferior screw slides out, and this superior screw taking the whole load causes the jamming of the screw within the nail, so it won't slide out and it starts penetrating inside, leading to Z effect. So this is very, very important to have both screws at the same level. The next point is fracture should be very well compressed so that the screw heads which is touching the lateral cortex will remain at that site even after the fracture unites, as you can see in this case. How I do is, I release the foot end traction and compress superior screw and inferior screw alternatively till I am satisfied that the fracture is compressed properly. So this compression is possible with having a head screw system only. None of the newer implants, such a beautiful compression can be obtained. This is an immediate posterior X-ray, and this is at 4 months. You can see the screw heads are remaining in the same position at the end of the union. This is very, very important because whatever the fracture was requiring to be compressed, I have done it on table. The head of the screw should have support of the bone. This is very, very important. The reason why I'm telling is, I was in Jaipur from 5th to 8th March for the mini IOCon. During that time, one patient was admitted in my own setup and it was operated on 6th March by my assistant. The OT assistant sent me requirement for ordering the screw where he had mentioned 105 millimeter neck screw. That indicates that in India, for a person or a patient of less than 6 feet tall, 105 millimeter neck screw is not at all required. So immediately I wrote back to Dr. Sachin Kulkarni, my assistant. Today's operated case, my guess is foot end traction is not released before fully tightening the screw. Once I see the posterior X-ray, let's discuss, I wrote. And 8th March, he shared me the picture. As you can see, the screw heads are not touching the lateral cortex. This is just because the fracture was distracted when the screw was tightened. Unfortunately, this patient also had a negative cortical support in the lateral view. This patient is bound to have a problem subsequently. As expected, at 2.5 months follow-up, you can see the neck screw has broken. The neck screw has broken, and also there is too much of sliding out of the neck screw, which is making difficult for the patient to sleep on that side. I feel that head of the screw should have a support of the lateral wall. If there is no support like this, what happens is the screw can toggle, and this toggling within the lateral wall leads to loss of purchase of the threads of the screw, and the screw walks off. That is the reason why transaurical fracture has a high failure rate, only treated with a partly threaded cancellous screw. That's why nowadays we replace few of the partly threaded cancellous screw with a fully threaded screw, or even we replace either with a Powell screw or a horizontal screw to prevent unwanted collapse to happen in this fracture. This is very, very important. If the lateral wall is badly comminuted, none of the newer implant can be used to support, or which can be used in these type of fractures, whereas a PFN with the head in the neck screw can be used. The nail itself can act as a lateral wall, and against the nail you can compress the head and neck and get a beautiful reduction, as you can see in this patient. Another patient, a 85-year-old male with a severe osteoporotic thin cortex. I have intentionally cleared the lateral wall, you can see, and the head of the screw is touching against the and resting against the nail. Patient was made to walk without a problem in the immediate postoperative period. At 10 weeks, you can see when the patient has come for follow-up, the screw heads are still touching the nail, and this is compensating for the deficit lateral wall. At 85-year-old, at this age, this patient was not expecting to survive, walk and sit. As you can see, the clinically, he was very, very thankful and he was crying. And I got this permission to show this picture to you all. Another 80-year-old lady with a badly comminuted lateral wall. Again, in the same technique I have used the nail itself as the lateral wall, and the screw heads are touching against the nail against which I have compressed the head and neck. And this is at 1.5 months, and this is at 4 years follow-up. You can see the nail, the implant is holding beautifully, and the lateral wall comminuted has been managed beautifully. This is an interesting case. There is a problem with the medial avulsion of the lesser trochanter, as well as there is comminution in the lateral wall. I was doing this demonstration surgery at Sancheti Hospital in Pune for Pune trauma course. I used, as said earlier, I have done extra valgus reduction so that the beak will never enter into the distal middle canal. And also I have used the head of the screw against the nail, and this has compensated for the lateral wall. And at 4 weeks itself, just a month, you can see Dr. Atul Patil, professor and the unit chief of the trauma, sent me this picture showing nice consultation in this patient. So this is a newer implant, where by pushing the sleeve or by tightening and pulling the screw, you can complete the fracture, and to retain the set screw within the nail and lock the sliding mechanism. But what happens is that sliding mechanism will not remain like that because there is no head for the screw. So this is, I have beautifully compressed on table, and I have inserted the head, the set screw. But if you see immediate postoperative X-ray, there is gap at the fracture site because the back end of the screw, there is no head, and it can slide, go within the hole in the bone, unless there is a stopper like this. Having a head screw is also very, very important. Only with a screw which is having a head, you can manage this badly comminuted lateral wall. And this is only possible with a PFN with a head, which is available in India. Unfortunately, I know due to patent issues, you and Western people, including America, you don't have an access to such implants. None of the newer implants have a head. And that is the reason why if there is a problem with the lateral wall, these implants require additional support and additional management. So whereas with a PFN, even if there is a badly comminuted lateral wall, one can manage. The 9th point is nail at the entry side should be slightly out, otherwise it can migrate medially, as you can see, or it can toggle, lead to failure of the implant. This can be built up by end cap of different size. In a headless screw, which I normally don't use or advocate to use, one has to keep the back end of the screw slightly out so that they can slide out. If it is inside, they will get jammed and penetration chances are very, very high. So this has happened with me only. I was using a ZNN type of nail where after compression, after releasing the traction, when the post-operative picture is taken, you can see the back end of the screw has gone inside, and this patient really had some trouble in the subsequent period. Why the back end of the screw should be out? Because it can slide out when the fracture collapses, because you cannot compress this fracture with this type of implant beautifully as with a PFN with a head. So with this, if it is inside the lateral cortex, it can get jammed. It will not slide out, leading to penetration. So this is an example. One of my friend, Professor Joydeep Das from Gurdwan Medical College, shared me. He was concerned, a 65-year-old lady where he had used a PFN-A, it had crossed the safety limit within the head, and he asked me what to do. Then I wrote him back saying that since the back end of the helical blade is outside, so don't worry, there is good chances that it will penetrate outside. It will slide outside. And as expected, this is on 5th September he showed 6 weeks post-operative, the screws have slided out without any penetration, and happy Teacher's Day. So one should learn to predict the outcome by knowing the deficiency in your surgery or having understood all these points. Last one is good implant. In India, we have spurious companies which manufacture many implants of substandard quality. Here you can see the interlocking is near the tip. Here you can see there is no tapering of the nail which is required. Even the screw heads are not proper. A good PFN will have a tapering end so that the stress distribution happens. The distal locking is done about 1.5 inch away so that stress distribution happens. And there is good metal around the neck screw so that the nail will not bend or break at that side. Here you can see a thinner nail with a thick screws. It has broken in due course of time. So having a good implant of known company is also very, very important. Finally, to conclude, good outcome if all the 10 points which we are discussed are taken care during surgery. This is an 86-year-old male. This is an 86-year-old male. On 26th of July, this patient had come to me, and this patient was operated at Baramati. He was an uncle of an orthopedic surgeon, Dr. Vinay Shah. And you can see there is a combination as well as thin lateral wall. Because of the lesser trochanter was avulsed, I got an additional extra valgus in this patient. This is the 2 months. You can see good consolidation. The greater trochanter was also broken, but it was fairly in position, so I didn't do anything. Yesterday, when I went to Baramati for doing another surgery in another 82-year-old patient, this patient came to felicitate me. I took this opportunity to take an X-ray. You can see beautifully this has consolidated, and the neck shaft angle has almost the normal like the opposite side. This is on the picture with the patient felicitating me with the orthopedic surgeon Dr. Vikram Dobade and orthopedic surgeon Dr. Vinay Shah at Baramati on 8th of July. So this is the same patient walking unsupported. So he walks outside with thick hand, but he is able to walk in the house without any support. Right leg has been operated in this patient. This patient already I have shown elderly 93-year-old lady, beautifully reduced fracture. All the 10 points have been taken care. The patient is walking comfortably without any problem. So one should learn to predict the outcome by knowing all these points. So that is what I wanted to share with you all. Once again, I thank Professor Dr. Bijayendra Singh for this opportunity given to me for sharing my experience.
Thank you, Shiva. That was a fantastic delivery of a lecture on the very common problem, which even now we face on a day-to-day basis. I'm sure trainees and even consultants would have gained much from it. So thank you for giving us your time, Shiva. I look forward to meeting you soon. I will now pass on over to Ms. Christina Rees for the next session. Thank you.
Thank you, Professor Singh. It's a massive honour and a privilege to be with you today to present these awards. It was my very good fortune 15 years ago to be referred to Mr. Amit Chandratraya with my self-inflicted knee problems after a lifetime of playing all types of sport. Amit and I became friends, and his treatment improved my quality of life considerably. Through Amit, I learned of the tremendous work of the British Indian Orthopaedics Society. I was so proud to host an event for BIOS in Parliament in pre-COVID times, and I hope that I may host another BIOS event in Parliament when restrictions permit. And now to the awards. It's my pleasure to read the citation for the first Lifetime Achievement Award. Mr. Amit Sinha was born in a remote village in Bihar in India, where his father, a newly qualified surgeon in the mid-50s, was posted. It's been a long journey from this village to beautiful North Wales. He graduated from Ranchi Medical School and completed his orthopaedics training from the Prince of Wales Medical School, Patna. After graduation, he took the plunge like his dad to work in primary health centre in a remote village in Rohtas in Bihar. Coming to the UK was a difficult time for him, a real culture shock. He completed his training and exams and then joined as a consultant orthopedic surgeon in Rhyl in 1999. His past 22 years have been a sheer joy working in North Wales. He was a specialist training committee member, a regional advisor for trauma and orthopedics, a MRCS examiner, and FRCS Intercollegiate Fellowship examiner. He was chairman of the Welsh Orthopaedic National Sub-Advisory Committee, member of the Welsh Board of the Royal College of Surgeons, and served as an ex officio member of the British Orthopaedic Association. It was an honour for him to be the president of the Welsh Orthopaedic Society from 2015 to 2017. He has been associated with the Indian Orthopaedic Society UK since 2005. He organised the successful annual conference in 2009 and went on to become the president of the society in 2010, a post he has held for 3 years. He cherishes this post better than any other post he has held. He has always been there to advise members of the society and guide them. He remains very proud of the contributions he has made to the foundation of the now British Indian Orthopaedic Society. Amit is married to Manjula and have 2 wonderful children. His son is a GP in Warrington and daughter a paediatric specialist trainee in Liverpool. Amit is now retired from the NHS. He also spends considerable time with his Rotary Club charitable activities. Ladies and gentlemen, the BIOS Lifetime Achievement Award to Mr. Amit Singha.
Thank you. Thank you very much, Christina. It's an absolute honor coming from you. Let me first congratulate the Welsh team here, led by Amit Chandratriya and Keshav Singhal, for organizing such a wonderful conference. I've enjoyed this thoroughly. And coming to this award, thank you, my friends. Thank you very much. Thank you, BIOS, for this recognition. This award has filled me with joy and pride. I remember the day in 2008, we were at the BIOS UK annual conference at Liverpool. And Mr. Madhu and Murthy really surprised me when they asked me, Amit, will you organize the next conference in North Wales? And I said, so, yes, of course I will. And from then on, I have never looked back. Thank you, Mr. Madhu, and thank you, Murthy. I salute my predecessors who had already laid the foundations of the society. I can proudly say that with the efforts of our team, with Venu, Anand, Gautam, Vikas, and every committee member, the society managed to spread its wings. I have now the opportunity to congratulate the following presidents and their teams. You have made it possible for the society to fly and earn that well-deserved respect. For BIOS, I will always be there. Thank you, Vijay, for your friendship, and congratulations, Amit Tolat, for taking over. I'm so pleased to hear from him about restarting the BOTA fellowships. Murthy actually initiated it, and I ran it for some years, and let's do it again. This award is an absolute treasure. It will always remain close to my heart. But before I close, most importantly, I must thank my wife, Manjula, for her support and encouragement. Thank you, friends. God bless everyone, and thanks again. Bye-bye.
Thank you. Thank you so much for those wonderful words. Thank you.
Thank you, Christina.
Thank you. I'm delighted to read the citation for the second Lifetime Achievement Award. Mr. Srirama Murthy Golapudi hails from Vishakhapatnam on the east coast of India, now the newly designated capital of the state of Andhra Pradesh. He studied medicine at Andhra Medical College, obtained his MS Orth, and worked as assistant professor in orthopaedics before moving to the UK in 1980. He worked at the Mid Yorkshire NHS Trust, Wakefield, and retired after 23 years as a consultant. As a founder member of the Indian Orthopaedic Society UK, he worked closely with and joined in the visionary efforts of Mr. Bijal Mudu, its founder president, as the fledgling organization navigated myriad teething problems and tackled some entrenched prejudices. He helped in revamping the BIOS UK website. He ardently believed in the society being a bridge between British and Indian orthopaedic surgeons, and he worked hard by constantly engaging in dialogue with the BOA hierarchy. He believed the educational role of the society as being foremost of its functions. The annual Indo-British Travelling Fellowships best illustrate this aspect of the society, and he made sure that these ran smoothly. At one stage in 2007, the sponsorships dried up from the UK medical device companies due to UCOMED regulations, and he managed to get replacement sponsorship by Lord Paul's Caparo Industries at short notice to tide over the crisis. He chaired the Constitution Committee and in 2015 worked alongside the members of the committee, brought out a much enlarged and detailed constitution in keeping with the expansion of the society. He always believed that our society should be an inclusive one, and to celebrate their core Indian connection, they are essentially a body of British surgeons of Indian origin. To this end, his proposal to change the name to British Indian Orthopaedic Society was implemented at the Leicester Conference in 2016. He and Lakshmi, his wife of 46 years, have 2 daughters and 3 grandchildren. In his retirement, he took up learning to play the piano and is currently compiling a travelogue based on the extensive travels he undertook, particularly over the last 15 years. Ladies and gentlemen, the BIOS Lifetime Achievement Award to Mr. Murthy Golapudi.
Thank you very much, Ms. Rees. Diolch. I hope I got the spelling right. May I also thank you, Ms. Rees, for presenting this award to me. In fact, I was gobsmacked when Mr. Professor Vijay Singh rang me a few weeks ago, stating that the committee has decided to honor me with this award. And I thought, do I really deserve this honor? But nonetheless, I'm ever so grateful. And I thank Professor Singh, Professor Amit Thalat, Mr. Sunil Garg, and the rest of the executive team of BIOS for their kindness. And I accept this honor with great pride and humility. Well, it's been a fantastic journey for me, having had the privilege of serving this organization right from its inception. Along the way, it's been my honor to have worked with brilliant teams before, during, and after my presidency. I've taken the cue from our visionary founder, Mr. Bijal Mudu, and I set about my tasks, and I was immensely benefited by the wisdom offered by my 2 predecessor presidents, Mr. Srinivasan and Mr. Suresh Rao. And I was also supported by the founder secretary, Mr. Babhulkar, and of course by Mr. Ravi Koka. I am beyond happy to see our society grow over years, and such a joy to find our organization so well respected for its stellar educational endeavors. BIOS is now at the very heart of British orthopaedics, and our ever-growing membership is a testament to that fact, aided in no small measure by the efforts of successive teams of BIOS led by immensely talented leaders, such as we just heard Mr. Amisina, one of them. BIOS should be so proud of its achievements so far. I have no doubt that our society will continue this splendid work and, most importantly, attract younger membership to ensure its future, and will continue its unique status as a bridge between Indian and British orthopedics. I have only one regret today, that due to these current uncertain times, it meant that we cannot have face-to-face meeting, and thus, Ms. Rees, I'm deprived of a personal visit to your beautiful Wales and its splendid capital, Cardiff.
Thank you. Thank you. Thank you, Murthy.
Thank you. I would like to thank Amit Chandrapriya and his organizing team and BIOS team for presenting this most wonderful meeting, which I've been following closely. My grateful thanks are also due to all the executive teams that preceded and followed my tenure as president. And in particular, I need to mention two names, Venu Kaurthap and Anand, who have been my teammates during my tenure for their vast help. Finally, just as Amit Sinha, I have to thank my loving wife, Lakshmi, who has been a source of great strength and inspiration to me all through and all times. Thank you very much indeed. Thank you.
Thank you. Thank you, Murthy. And your pronunciation of Dear was perfect. And as you can see, I've got an Iron Bevan on the wall behind me.
Yes.
Always an inspiration. Thank you. Congratulations. I'm delighted to read the citation for the BIOS Research Recognition Award given to Mr. Kodali Prasad. Kodali Siva Rama Krishna Prasad from Prince Charles Hospital, Merthyr Tydfil. He's an acclaimed researcher, editor, and peer reviewer in the international arena of trauma and orthopedic surgery via application of clinical practice and research, which enriches both in pursuit of excellence. He was educated in Guntur George Coronation Higher School, Secondary School, Throrumela, and graduated from Guntur Medical College, Andhra Pradesh. He was the recipient of the Special Merit Scholarship for Top Scholars from 1966 to 1972. He joined the NHS in 1978 and has been a staff-grade orthopedic surgeon in Prince Charles Hospital since 1994. He is the first and only international assistant editor and the only editorial board member from the UK and India for Foot and Ankle International, and the only international associate editor for clinical orthopedics and related research from both the UK and India. He is regarded as a consultant top reviewer for JBJS and a peer reviewer for various leading orthopedic journals on either side of the Atlantic, including CORE, Bone and Joint Journal, and Bone and Joint Research. He has a unique achievement of being selected 3 times as an elite reviewer for JBJS, with consequent inclusion in JBJS editorial board masthead. He is credited with prolific presentations and publications in peer-reviewed journals. He has won several awards, including Best Design Award collaboratively, BIOS 2017, Making a Difference Award and Above and Beyond Award 2019 by Cumtath University Health Board, Gloria of India, Hind Ratan and Sword of Honour, New Delhi, Mahatma Gandhi Samman by Baroness Burma, the House of Lords. He has been associated with IOS UK and BIOS for a long, long time. Ladies and gentlemen, the BIOS Research Recognition Award for Academic Endeavour and Distinction to Mr. Kodali Prasad.
Thank you.
Thank you.
Well done.
Thank you.
Well done.
Thanks a lot. Thank you. Thank you.
Do you want to say a few words?
Yeah, please.
You can sit down, maybe. You can sit down.
Thank you. Thank you for kind words, Ms. Rees, and I thank from the bottom of my heart BIOS for unexpectedly giving this award. This is indeed a pleasure to receive this award, and this is unique, probably from what I know in the history of BIOS. I thank all my family members and BIOS team for the intention and my previous contribution without any hesitation from all my family members for my progress. I owe it to all. Thanks a lot. Thank you.
Hi, thank you very much. Thank you, Christina, for your time on this Saturday. And I'm sorry to make you pronounce difficult orthopedic words, but thank you very much for that. Congratulations to all the recipients of the awards. There's a slight change in the program today. The First Minister of Wales is unable to make his commitment, but he has deputized the Minister of Health and Social Services, Baroness Eluned Morgan, to give a talk on his behalf. We will now run the introduction by Mr. Ajay Sharma for the Health Minister. So it's over to Ajay Sharma. Thank you very much.
It gives me great pleasure in introducing Baroness Eluned Morgan, Member of the Senate and Minister for Health and Social Services of Wales. Baroness Morgan was born and brought up in Cardiff. She won a scholarship to the United World College of the Atlantic and gained a degree in European Studies from the University of Hull. Baroness Morgan earned her stripes early on, being elected as the youngest member of the European Parliament at the age of 27. She was only the 5th woman to be elected to a full-time political post in the history of Wales. Baroness Morgan brings with her immense and diverse experience. She represented Wales for the Labour Party from 1994 to 2009. In this role, she was the Labour spokesperson on industry, science, and energy. Way before green energy became mainstream, she authored the Green Paper on Energy on behalf of European Parliament and led the Parliament's discussions on Electricity Directive and the issue of fuel poverty. Baroness Morgan then served as the Shadow Minister for Wales in the House of Lords and as the Shadow Minister for Foreign Affairs. She was elected to the Welsh Assembly in 2016 and appointed Minister for Welsh Language and Lifelong Learning the following year. In 2018, she became the Minister for International Relations and Welsh Language. Just over 6 weeks back, she was asked to serve her nation in the most challenging of times as the Minister for Health and Social Services. Friends, you would agree with me that Wales is lucky to have in Baroness Morgan a very experienced, capable, and a people-centric minister. We, the British Indian Orthopaedic Society, wish her great success and assure her of our commitment to support her government's initiatives in the coming days. Over to Baroness Morgan.
Well, thank you very much. Thank you very much for welcoming me to this conference, and congratulations on hosting such an incredible event. I had a look at your agenda, and it seemed very, very rich indeed. And I'm sorry if some of you are hearing me twice during this conference, but I would like to start by giving apologies on behalf of the First Minister. I know he was really, really keen to be with you today and is very sorry that he has been unable to attend. So please accept those apologies on his behalf, and I hope you won't mind if I deputise on his behalf. But it is a huge pleasure to welcome you even virtually to Cardiff. I'm actually speaking to you from St David's in Pembrokeshire, but from the conference outline, I know that you've already had very varied and stimulating discussions, and I'm very pleased to see that you're planning to have a Welsh perspective on orthopaedics from Owain Ennis, who is one of our most experienced consultants working in Wales. And I've always been a huge admirer of the work undertaken by the British Indian Orthopaedic Society to promote exchange of knowledge and culture across our different health systems. And we're particularly pleased, of course, and proud in Wales because Aneurin Bevan was a Welshman. It was his inspiration that established the NHS. And of course, we are celebrating, I think it's 73 years of the NHS this week. So this two-day conference hosted in Cardiff follows in the same rich vein that you have in the past, and I hope you will have a successful few days. I think it's no overstatement to say that these last 15 months have been some of the most difficult and challenging many of us have known. And I want to open my remarks today with a very simple message of thanks for all of the dedication and the skill and flexibility you've shown over that time. And despite the challenges we've faced, we've collectively achieved an incredible amount in supporting patients through such a difficult and unique time. And I know that our clinical community has truly excelled and shown the very best of Wales. And in particular, it's shown creativity and innovation to ensure that patients get the best possible care under some of the most testing and challenging of circumstances. Now, in Wales, we value hugely the contribution of all of our health and social care professionals. And I want our links as a health community in Wales with our members to strengthen over the coming years. And in particular, I want those links to grow as a way of helping us all together to think about the shared health challenges we all face. I know that professionally, the pandemic has impacted significantly on all surgical services, and orthopaedic services in particular have been hit hard. It's a challenge for all those involved in delivering care to think carefully about how we support the significant number of people now waiting for treatment as a result of the pandemic. And I know that it keeps me awake at night thinking about the pain that so many of our fellow human beings are suffering during this really difficult time as they await those treatments. Now, there's no easy answers, but it's the dialogue, the professional engagement, and the two-way exchange promoted by events such as these that help us to think and work our way through the challenges we face. Now, the uncertainty of when services will return to normal has continued as we've moved through the various cycles and strains of the virus. We all know that we still have some way to go before life and the vital services we all rely on return to full capacity. Now, I recognise the challenges placed on you as practitioners. The impact the pandemic has had not only on essential and emergency elective care, but also on specialist training to future consultant staff and support trainees has been impacted. So I want to give you a really clear message today. There are, we know, no easy answers to the challenges we face. But in Wales, we are committed to ensuring that in thinking through the challenges of providing high quality orthopaedic care for the future, we do that in a spirit of partnership, collaboration, and of respect. And in thinking through many of those challenges, we'll need more of that innovation and creativity that many of you have already shown over the last 14 months. It's a challenge that we know is not confined to healthcare. Now, as many of you will know from your direct experiences, COVID has had a profound impact on the way all public services, including our NHS, have been delivered over this past year. The pandemic has forced us all to think in new ways about the way many vital services are designed and delivered, orthopaedics included. And we've all seen a much faster application and rollout of new digital technologies, which have generated a growth in the number of online and teleconsultations. Some of these things have been necessary and temporary changes to get us through the pandemic, but others will no doubt be thinking we make a new and will make a permanent part of the way we do healthcare in Wales in future. We must use this pandemic, I hope, to think carefully and deeply about how we provide services for the future. I know I've urged my officials since my very recent appointment not to waste this crisis. Let's think creatively, let's think differently. And I know that you've all thought deeply about these issues. And I'm sure, and I'm aware that many of the changes you and your colleagues in Wales have made over these last months, and I hope that some of them will be carried forward into the future. The virtual triage of fracture has reduced the need to bring every patient into hospital to be seen in an outpatient department. The use of patient-reported outcome measures after surgery have allowed virtual checkups to take place. Online physiotherapy and rehabilitation has changed in a new and innovative ways. And part of my message today is to say that I welcome a wider conversation about the role of these and other changes in the way we go about supporting a sustainable and effective NHS for the future. As a Welsh Government, we've said many times that we have no monopoly on good ideas, and we look forward to hearing your reflections and observations on these changes. And that conversation itself rooted in very Welsh values, values of social justice and of fairness. Not being able to offer vital orthopaedic services over the last year has no doubt impacted those who have lived with limited mobility, perhaps for some time. Uncertainty over when they can be treated has no doubt been a difficult and painful experience. And that's precisely why at the recent election, we proposed the biggest and most comprehensive plan for NHS recovery Wales has ever seen, because tackling it is itself a matter of social justice. And I want us all to work alongside and with those who've lived through the experience of waiting for treatment, to use their knowledge and understanding to ensure that we develop services that can genuinely improve care across Wales, harnessing the experience and the skill of staff to rebuild a first-class service. I know that the difficulties in managing waiting times for orthopaedics in the UK and within Wales existed prior to COVID. We know that some clinics were not able to operate during lockdown or had to operate on a reduced level. We know that operations were cancelled. We know that support services such as physiotherapy and radiology were diverted away from orthopaedics in order to support the COVID response. Now, this has inevitably resulted in backlogs of care and has been why the Welsh Government has committed an additional 100 million over the next year to support elective recovery. It will take us time to work through the waiting list that is built up, but we'll do so by using and building on all of those new ideas that have been developed. We'll continue to use new intelligent pathways and new innovations to improve not only services, but also the wider experience of patients. And I know this isn't going to be easy. You will have heard from colleagues in the Welsh Orthopaedic Society yesterday of the challenges we face. The Welsh Government and the NHS Wales are working with the Society through the Welsh Orthopaedic Planned Care Board to develop a clinical vision and strategy for orthopaedics. I expect this to support the development of a truly multidisciplinary workforce that equals the clinical demand. That will ensure that all patients within Wales have equality of access to routine and specialist surgical care. That care is provided in facilities and within systems that support both staff and patients. We need to be brave as a country and look to redesign how we deliver orthopaedics. Part of this will require the Welsh Government and NHS Wales to take creative and innovative decisions moving forward. Decisions that we can support not only the health and well-being of our population, but to make sure that that contribution to fairness and social justice that I've just talked about is also seen through. I know that the coming months and years will be challenging, but I have every confidence that we can develop a long-term vision for orthopaedics that is bold, that is practical, and which above all delivers the care the population of Wales needs and deserves. I want to thank everyone today for their truly remarkable efforts this last year, both within Wales and within the wider British Isles. Your work has truly been heroic and it's been valued, and we thank you. Diolch yn fawr iawn I chi gyd. Thank you very much, and thank you for the invitation to come and speak today.
Thank you very much, Baroness Morgan, for your kind words. And we are very encouraged to know that you as leaders understand the minute details of the challenges which the current NHS is undergoing. And we pledge to help our people with the best we can offer. As you said, the world has seen unprecedented times over the last 12 months, and the British Indian Orthopaedic Society would like to observe a 1-minute silence for the worldwide victims of COVID, and we would like you to join us in that. Thank you all. We can now bring this session to a close. We will rejoin after lunch for the best of the best podium sessions. But in the lunch breakout sessions, please do not forget that we have 2 fantastic parallel sessions running on the braces and a stemless joint replacement by Arthrix. So whilst you're having your lunch, you can enjoy those 2 sessions. Thank you all, and we'll see you at 10 past.
Welcome everybody to this breakout session sponsored by Joint Operations and BREG. Today we're going to be covering the aspects of unloading bracing and giving you an overview of the biomechanics related to the unloading bracing range and the important factors to consider when looking at them for your patients. A bit of background, Joint Operations, in case you aren't aware, are a company still relatively in their infancy, founded in 2015. We're a joint preservation company focused around how we can preserve all elements of the joint. We look at allograft, we look at cartilage, alignment and meniscus, as well as a range of non-surgical options. And most recently, we've taken on the BREG portfolio, and that's what we'll be going through today. So who are BREG? BREG are a company founded over 30 years ago in the US. They're actually one of the market leaders in bracing and cold therapy in America. And we're lucky enough to have that full range of products available to us in the UK today. So I'm going to hand over to Monica, who is one of the education consultants for BREG that's based throughout Europe. And Monica is also a physiotherapist, and she works in a really busy practice over in Poland. So over to you, Monica.
Hello, welcome everybody. My name is Monica Seibert. I'm a physiotherapist whose great passion for more than 20 years is orthotics. I have been working for BREG as a medical education consultant for the past 5 years and use their products in my very busy physiotherapy clinic in Poland. Today, I would like to share some information about offloading braces. Why brace? Not everyone believes in OA braces, although there are many studies which confirm their effectiveness and highlight their benefits. Fewer arthritis symptoms, a lack of pain, reduction in the use of pain medications, ability to perform daily activities or increase walking distance. All these features are a real hope, especially for patients who for various reasons are not currently suitable for surgical intervention. When OA braces may be ineffective, mostly when they are fitted incorrectly or when the brace choice is wrong. OA braces can work in push or pull technology. Both systems are equally effective. However, the specific features of the affected knee will be a final determinant of the right choice. That's why it is important to know that pushing braces offload the compartment on the opposite side to the hinge, and pulling braces offload the compartment on the side where the hinge is located. Hinge in pushing braces always has direct contact with the knee, while hinge in a pulling braces may never touch the knee. The bigger offloading force, the larger the distance between the knee and hinge will be. On the X-rays, we can see the same knee, but in 4 different braces. The effectiveness of all 4 braces were quite similar. However, the comfort level was different, and the patient felt most secure in the dual upright brace. The reason of that choice was also ligament instability. OA braces can be static or dynamic. Dynamic braces, video on the right, provide increased force only in the moment of medical need, so in the last 30 degrees of extension. Static braces, which you can see on the video on the left, provide a constant force that stays unchanged no matter on knee angle. Pulling braces are a little bit better for people who do not tolerate any pressure on their knees, or for the ones who have significantly valgus knees. Pushing hinge on that type of legs may simply force a different walking gait as a response for a risk of hitting the other knee. OA braces can have one or two uprights, and it is extremely important to choose the correct brace based on patient's needs. For deficient knees with OA and ligament instabilities, or for patients who perform high-impact sport activities, dual braces will be always the right choice, as they not only offload the affected compartment, but also stabilize the knee in all anatomical planes. And please keep in mind that OA braces can also be dynamic or static. There are some restrictions we need to follow when choosing a brace. The angle of deformity is always crucial when deciding what type of a brace to choose. Patients with varus valgus deformity over 15 to 18 degrees won't be able to wear dual upright braces. Too big pressure on a tibia and a brace tendency to rotate and slide down are the biggest risk in such situations. On the left picture, we can see a patient with varus knees who, because of ligament instabilities, was fitted with dual upright braces. Picture on the right shows the patient who has significant varus deformity and really bad instability. Unfortunately, the varus angle in this situation was too big to fit this patient in a dual upright brace. It is always good to see a joint opening on the affected side caused by an OA brace, but it's crucial to remember that it is that lack of pain, not an X-ray, is the way we follow. Quite often, it won't be possible to see joint separation on X-ray, what doesn't mean that OA brace is ineffective. A main goal of OA braces is to reduce pressure on one of compartment. This always translates into pain relief. No pain means longer walking distance. This means more daily activities, and this leads to patients' and doctors' satisfaction. OA braces can be so efficient in reducing pressure that they often support regenerative medicine procedures and present great results in conjunction with hyaluronic acid. Quantum OA brace. This is a brace with scientifically proven effectiveness. The recently published study shows very promising results. Look at the picture on the right. This is a 3D analysis showing subject varus valgus change without the brace on the left side and with the brace on the right side. After evaluating all 20 subjects in this study while wearing and not wearing the breakaway brace, it was found that all subjects experienced a positive change in joint space. In other words, the breakaway brace is clearly performing as anticipated, ultimately leading to a decrease in patient pain and an improvement in functionality. As I have mentioned before, we do not need to always see joint separation to achieve good outcomes. As we can see on the X-rays, the correct brace may slightly improve the alignment and significantly reduce the pain. Each brace fitter in terms to choose the correct brace should take into consideration lots of aspects: knee alignment, doctor's information, X-ray or MRI, activity type or level, treatment plan, additional knee deficiencies, ankle alignment, skin condition, flexion contractors, and leg shape and proportions. The more information we have, the better conservative treatment we give. As clinicians, we often are asked how many degrees this brace may correct. The point is, only osteotomy can correct, and the brace task is to offload, not to correct. How strong the offloading force can be? Well, as high as can be tolerated without discomfort. Additionally, the offloading force is a resultant force created by a brace angle and a leg angle. So this force also depends on patient's tolerance on pressure points or strap tension. While fitting a brace, we need to take into consideration a lot of factors, but most importantly, we cannot cause any discomfort or put too much pressure, as the patient simply won't wear uncomfortable brace at all. It is quite important to admit that if the knee has flexion contractures, the effectiveness of an OA brace will be always much lower. So to be sure that the certain type of a brace was a good choice, few goals have to be achieved. The pain is gone or reduced, confidence is improved, patient can walk longer distances, knee feels supported, and activity level increases. If all is checked, then we know that our OA brace works. Summarizing, we need to consider lots of aspects when choosing an OA brace to achieve our goals. Wrong brace application, a wrong brace choice will make the brace ineffective or even can put our patient at risk. And this is very important to remember. Thank you very much for your attention.
Symbios is the foremost opinion in the design and manufacture of custom hips, with over 30,000 implantations Europe-wide and 20-year published clinical results which are supported by the most robust National Joint Registry data. Symbios is your clinical partner in finding accurate reconstructive implant solutions for the most active, high-demand patients, with or without complicating hip dysplasia.
Hi, good evening, ladies and gentlemen. Welcome to the first post-lunch session of the BIOSCon 2021. I hope you have had a nice and healthy lunch. So I would say that this session is very cleverly timetabled, and I really congratulate Amit and his team because it actually meets the most important challenge of a post-lunch session. That is, it has got all the ingredients to actually meet the challenge of postprandial somnolence, or what we call sleeping after lunch. So you can see it has got a series of podium presentations by very distinguished speakers, and it crosses a range of topics, which I'm sure will intrigue you, keep you awake, and also generate a lot of questions. So all these questions can be put on the live chat, and the presenters will then answer these questions on the live chat. So now we go on to a series of podium presentations, and we will start with the first podium presentation. So can we go on to the first podium presentation, please, Martin?
My name is Rishi Agarwal, and I'm going to talk about the results of our study, which is a comparison of HA-coated screw versus titanium triangular dowels for sacroiliac joint fusion. This was a prospective study performed in University Hospital of Wales in Cardiff. Back pain will occur in about 90% of adults at some point in their life, and sacroiliac joint is attributed to about 15 to 22% of all back pains. The initial treatment for sacroiliac joint related pain is analgesia, physio, and an image-guided injection if analgesia and physio fail. SIJ stabilization is also recommended by NICE for refractory SI joint pain, which does not get relieved after all conservative methods have been tried. This is the protocol that we use for SIJ-related pain. In the interest of time, I won't go through all of it, but this essentially says that we try conservative methods first, and then before deciding whether the patient needs surgery or no, the go-to investigation is a CT-guided injection. And if patients have relief following the CT-guided injection, and then the pain comes back, then they're offered surgery. The aim of this study was to compare HA-coated screws versus titanium triangular dowels for sacroiliac joint fusion. This was a prospective study, and data was collected after taking patient consent. From 2013 to 2015, we used HA-coated screws for 40 patients, out of which 33 completed follow-up. And from 2016 to 2018, we used titanium triangular dowels for 73 patients, out of which 61 completed follow-up. Outcome measures were used preoperatively and postoperative. The outcome measures used were Oswestry Disability Index, Majid Pelvic Score, which is currently the only score available for pelvic-related pain, SF36 score, and EQ5D5L. There was a stepwise statistical analysis done. The first step was to check whether the data was normally distributed or not using the Shapiro-Wilcox test. The second step was to compare preoperative age, sex, and PROMs. Here, we did not find any significant difference in all preoperative parameters, which essentially said that both groups were comparable. The next step was to compare post-operative outcome measures, and the fourth step was a small subgroup analysis. This table shows us the post-operative outcome measures and essentially tells us that all the outcome measures were better, significantly better in the patients where a titanium triangular dowel was used. Radiological analysis showed that 63% of the patients where HA-coated screw was used had lysis around the sacral part of the screw as compared to only 9% in the titanium triangular dowel. The risk of having lysis with HA-coated screw was 6.5 times higher when compared to a titanium triangular dowel. A subgroup analysis showed that the post-operative outcome measures were significantly low in patients who had lysis around the screw. In 4 of these patients with lysis around the screw, removal was attempted. However, removal was successful in only 1 patient. In this patient, after removal of the screw, 2 additional titanium triangular dowels were inserted and the patient's symptoms did improve. The other 3 patients had to be referred to the chronic pain team for analgesia management. In conclusion, we would say that sacroiliac joint stabilization leads to better patient-reported outcome when a titanium triangular dowel is used. The risk of having lysis is more when HA-coated screws are used, and patients with lysis have worse outcome than those without lysis. We would recommend the use of titanium triangular dowel over HA-coated screws for sacroiliac joint stabilization following the results of this prospective study. We have no conflict of interests, and thank you for your time.
Thank you, Rishi, actually, for putting some clarity on which is a better method of to fuse the sacroiliac joints. Now we go to the second presentation, which is the global cost study, and this is by Mr. Anshul Sopti, and he's going to talk about the global impact of COVID-19 on surgeon and team members, which is essentially the frontline staff. So can we go to Anshul's presentation, please?
My name is Anshul Sopti, and I'm presenting on the global impact of COVID-19 on surgeons and team members, which is the global cost study. Thanking all the lead coordinators, principal investigators, steering committee members, and the collaborators. The global impact of COVID-19 on surgeon and team members was conducted by the OrthoGlobe Collaborative and endorsed by the Royal College of Surgeons COVID Research Group. The aim was to describe the impact of COVID-19 pandemic on physical, mental, financial, and family well-being of surgeons and allied professionals across the world, and assess the support provided by their institutions in accordance with the BMA guidelines. An online survey was distributed through medical organizations, social media platforms, and collaboratives, and the other collaborators over a 5-month period from the 15th of July to the 15th of December 2020. The study found that the 64% of the respondents had found difficulty gaining access to PPE. 29.8% had not received adequate training on its use. 32% had become physically ill since the start of the pandemic, 59.9% of which were due to COVID-19 symptoms. 29% saw a decrease in salary, and 35.2% saw a decrease in time spent with family. Between a time of 2 weeks since the start of the pandemic and after, there was a significant increase in the mean scores of depression and anxiety based on the patient health questionnaire and general anxiety disorder assessment. Both of these were statistically significant. In terms of support, only 36% had easy access to occupational health, 44% to pastoral or mental health services, 58.5% were able to take regular breaks, 16.5% of the respondents had access to 24-hour rest facilities, and 14.2% to 24-hour food and drink facilities. A multivariate analysis looking into the effect of country HDI on access to supportive measures showed participants from a country with a low human development index was significantly less likely to have access to PPE or to occupational health services and mental health services, including 24-hour food facilities. But however, they were more likely to have support from managers and access to sick leave when needed, compared to a very high HDI country. In conclusion, this work has highlighted a need and ways in which we can improve conditions for the healthcare workers. This will inevitably have a positive effect on the care received by patients. Myself and the steering committee thank all our collaborators from all over the world for spreading the survey as widely possible. And you can see here where the participants are from. And I thank you for listening to this presentation.
Thank you, Anshul. I mean, it's really an eye-opener, and the effect on the frontline staff of COVID-19, hopefully this has a positive effect in the future, your study. So we go to the next podium presentation, which is, is it important for us to be aware of the syndromes associated with scoliosis? And I invite Dr. Sriram Harish Srinivasan to do the presentation. Over to Sriram.
Hello everyone, I'm Sanjay Naradamurthy. I'd like to thank the organizers for giving us this opportunity to present our review article. I'd like to thank our main author Sriram Harish Srinivasan, our senior author Mr. Girish Swami, also our co-author Amit Jagdish Bishnoi. So let's start with our review article. Is it important for us to be aware of syndromes associated with scoliosis? Is it? Let's look into it. Syndromic scoliosis represents a wide range of systemic anomalies associated with scoliosis. So when a patient presents with syndromic scoliosis, the treating clinician has the challenge of thinking beyond the scoliotic curve, as the underlying pathology is multisystemic. So insight into the associated anomalies would help in formulating a clear management plan. We believe that it is important for a clinician to have in-depth knowledge of the associated anomalies in order to treat the patient in best possible manner. Despite a lot of research is going on with scoliosis, little has been reported on syndromic scoliosis as a whole. So our aim of this review is to identify the systemic anomalies associated with syndromic scoliosis. In order to identify these syndromes, we did a literature review on the electronic databases using the keywords scoliosis syndrome genetic. We included prospective, retrospective studies, and also we excluded the case reports which had patients fewer than 4 patients. So following the search, this yielded a lot of articles, 112 articles from Medline, 46 from CINAHL, and 79 from Embase. By following the exclusion criteria, we delineated a total of 30 articles from Medline, 12 from CINAHL, 18 from Embase. When we looked at all of these articles, we identified a total of 41 syndromes to be associated with scoliosis, and also the most common level at which this scoliosis occurred was lumbosacral level. So we tried to group the most common anomalies specific to the systems. So coming to the central nervous system, mental retardation, seizures, ataxia were most commonly associated anomalies with this system, whereas ventricular septal defect, atrial septal defect, transposition of great arteries were most commonly associated cardiovascular anomalies. Coming to the gastrointestinal system anomalies, biliary atresia, anal atresia, and GERD, whereas strabismus, nystagmus, congenital cataract were most commonly associated ophthalmic anomalies. Neuromuscular system was the most commonly affected system, almost in every syndrome. So the most common anomalies were hypotonia, vertebral rib anomalies, muscle weakness, delayed skeletal maturity, whereas pulmonary hypoplasia, transesophageal fistula, diaphragmatic hernia were commonly associated respiratory system anomalies. Coming to the genitourinary system anomalies, undescended testis, renal agencies, and urinary outflow obstruction were most commonly associated anomalies. So by having a clear overview of the most commonly associated anomalies with syndromic scoliosis, the clinician can be confident in formulating the treatment plan, and also the treatment plan must be multidisciplinary. Let's look into it. So when I say multidisciplinary, the team should involve spinal surgeons, anesthetists, pediatricians, geneticists, and allied health professionals. It is vital for the best care of patients when the multidisciplinary approach is involved. So from our literature review, it's apparent that little has been reported and a lot of research is needed in this domain. Also, one most interesting thing which we identified when looking at these syndromes was the level of scoliotic curve reflects the associated anomalies, as like thoracic curve is more closely linked to cardiovascular anomalies, whereas lumbosacral curve is more closely linked to genitourinary anomalies. We hope that this review article provides a clear overview of the syndrome systemic associations of scoliosis and thus facilitates and helps in formulating a management plan. Thank you very much for your patience, and we would like to welcome any questions. Thank you.
Thank you actually for really highlighting the importance of differentiating syndromic from non-syndromic scoliosis. We go now to the next presentation, which is essentially a meta-analysis study where you're basically looking at the urodynamic post-residual urine volume in the Cauda equina syndrome assessment. What is the post-residual volume, which is considered a red flag? This is by Mr. Joseph Boctor. Over to Mr. Boctor.
This is Joseph Boctor, Orthopedic Registrar in University Hospital of Wales, and today I'll speak to you about urodynamic post-residual urine volume value in Cauda equina syndrome assessment, which is a meta-analysis and systematic review study. Authors declare no conflict of interest. Cauda equina syndrome is a rare but a serious condition that, if missed at initial presentation, can lead to serious morbidity and disability. Early diagnosis is crucial for a favorable outcome. There are red flags like bilateral lost sensation of both lower limbs, lost anal tone and sensation, but all of them are subjective either to the patient's own words or to the examiner assessment. There is also urodynamic study, which is known as post-residual urine volume or PVR, which is commonly used now as a screening tool. However, it's not clear yet what is the cutoff volume of PVR that at which we would worry that there is a high possibility of Cauda equina syndrome. The aim of this study is to do meta-analysis and systematic review of literature that included PVR as a predictive screening tool in Cauda equina syndrome and to identify the most sensitive and specific PVR for Cauda equina syndrome. A comprehensive literature search was done in PubMed, Medline, and MPAS, including the mesh terms Cauda equina, bladder scan, post-void residual, and search terms assessment, diagnosis, and predict. We included all paper which had bladder scan as diagnostic parameter with a clear numeric value, followed by MRI to confirm or exclude the presence of Cauda equina syndrome. We excluded non-English studies and studies which didn't have a clear cutoff point of PVR. Our question was, can bladder scan predict Cauda equina syndrome? If yes, what is the cutoff point of PVR with the highest sensitivity and specificity? A statistical analysis was done using META DTA online software in which data from all studies collected and analyzed. The risk of bias was done according to quality in prognosis studies or QUIP tool and divided into low, moderate, or high. Looking at the Prisma chart, initially we identified 1,955 studies. After removing of duplicate, we had only 806 studies. After reading the abstracts, we only found 124 articles that would be eligible for full text assessment. After full text assessment, we only found 7 studies that suitable for meta-analysis. And these are the studies with the oldest at 2009 and newest at 2020. And this is risk of bias using QUIP tool dividing into low, moderate, or high. The total number of cases in these studies was 938 patients. The number of cases suitable for meta-analysis was 714. Cauda equina syndrome was confirmed in 107 and excluded in 607. Bladder scan diagnosed 86 out of the 107 and excluded 426 out of the 607. We divided the cutoff point for PVR into 2 clear categories. Is it more than 100 or more than 200? More than 100 had a sensitivity of 64% and a specificity of 59%. However, PVR more than 200 had much higher sensitivity, reaching 83%, and specificity of 93.5%. In conclusion, PVR is an essential tool in Cauda equina syndrome assessment. We recommend the PVR more than 200 ml at the screening cutoff point. If associated with other clinical red flags, urgent MRI would be necessary. The limitation that we had only 7 studies, 2 of them were prospective, there was no randomized controlled trials, and inadequate patient demographics. We recommend a prospective multi-center study with detailed patient's demographic comparing PVR of more than 100 versus more than 200 to be confirmed or excluded by MRI scan. These are the reference we had in this study. Thank you.
Thank you, Dr. Bakhtar, for actually doing this meta-analysis and putting a number to what we consider as a PVR, which is a red flag for cardiac assessment. That's very useful. We go to the final, last but not the least study, which is the mean 5-year follow-up results of a facet replacement device in the treatment of lumbar spinal stenosis and degenerative spondylolisthesis by Mr. Shahnawaz Halim. Over to Shahnawaz.
Morning, friends. It's a pleasure to discuss the mean 5-year follow-up results of a facet replacement device in the management of lumbar spinal stenosis and degenerative spondylolisthesis. Patients requiring decompression instrumentation normally have spinal stenosis, a degenerative slip or a spondylolisthesis, or have moderate to severe lumbar articulopathy. But in the younger age group, patients require some form of intervention, but may not necessarily full fusion, which has its own complications in the form of adjacent segment degeneration and others. These patients generally form a typical patient population where they have bilateral extreme sciatica radiating to the bottom of the feet, they have severe pain, they need to stop after walking some distance, and in this patient's case about 50 meters, and they require something to be done. Her x-rays on the right side show a grade 1 slip at L4-5, and the axials of the MRI scan show moderate to severe spinal stenosis. She underwent a TOPS flexible stabilization, and these are her results, where she's able to mobilize very comfortably. She has no restrictions on patient activities. She does not have to wait for a biological fusion to take place and can go back to being normal as soon as possible. And what is this implant? The TOPS device is a pedicle screw-based device with a titanium construct, which is interlocking PCU or polycarbonate urethane articulating core. This allows all forms of movement, just like the normal back movements, and prevents extreme levels of extension or flexion. In short, it replaces the facet in its activities. This device has been in the use in the past, but has been redesigned in 2011 to become 30% smaller, and has been used for the last 5 years in Europe with good results. You may have heard of the Dynesis, which also was flexible stabilization, but the difference is that it connected pedicles of 2 different vertebrae, whereas the TOPS connects pedicles of the same vertebrae with a box device. So the rotational torque is much less, which means that there's less chance of screw loosening because of the design. This has been tested clinically and in vitro, and it establishes near normal range of movement, optimizing screw-bone interface, and prevents adjacent segment disease with robust mechanical strength. What is the benefit of this arthroplasty system? It provides near normal motion in all forms of rotation, even after wide decompression, and that is very protective for adjacent segment disease, which is very common a few years after full fusion and can cause further pain and disability to the patient. The Southampton experience of a prospective single study is what I'd like to discuss today, and the indications were moderate to severe stenosis with a possible grade 1 slip, exclusion criteria being previous fusion surgery, greater than grade 1 slips, and any bone metabolic disease. This study was approved by the Regional Ethics Committee. Patients were initially evaluated with weight-bearing AP and lateral X-rays, MRI scans of lumbar spine, VAS scores, ODIs, SF36, and the Zurich claudication questionnaire. The questionnaires were conducted pre-op, 6 months, 3 months, 6 months, 1 year, 2 years, and at latest follow-up. We had 10 patients in our study, of which 8 were female, average age being 59.6 years, average BMI 28, all Caucasian, and the current follow-up was 60 months. We had 2 individual tears, of which 1 required a washout. There was no revisions, no loss to follow-up, and 1 patient's baseline scores were lost, but the follow-up was excellent. The VAS scores of the back showed an improvement from 71 to 16 at 60 months, 73 of the left leg to 3 at 60 months on mean. VAS of the right leg shows an improvement from 47 to 11. ODI, again, significant improvement from 52 to 8.4. And short form 36 Physical showed an improvement from 27.9 to 79.8. And the SF36 mental showed an improvement from 48.7 to 85.3. This is an example case report. A 70-year-old with severe back pain and leg pain showing a grade 1 slip at L4-5 with the lateral and PA views. This is the post-op views of a lateral and an AP showing the TOPS implant in place. And these are flexion extension views showing that there's movement still taking place at the stabilized segment with good relief of pain and leg pain for the patient with increased mobilization. The advantages of a posterior arthroplasty are it treats the latest pathology without fusion. It replaces the function of all structures removed during decompression, recreating normal motion with no screw loosening, withstanding shear loads. This has a simple revision strategy where, if the patient needs to go into fusion, the box can be removed and rods can be placed in its place, and it shows excellent clinical outcomes. Thank you very much for your attention.
So we come to the end of this session. I thank all the speakers for their views on a wide range of topics. I thank the organizers for giving me the opportunity to moderate this session. And I thank Amit and the Cardiff team for a fantastic job of the conference so far. Hope to see you face to face next time.
Hi, good afternoon. Welcome to this session on hip fracture update. I'm Kitish Mahanti. I'm a trauma surgeon working here at the University Hospital Wales in Cardiff. We know hip fractures are common, the kind of bread and butter of our practice. We can't get away from them. When I started as a consultant in 2005, the reported incidence was around 43,000 in the UK. Last year, it's grown up to 74,000. So we all probably appreciate and realize that in any age group, hip fractures are life-changing injuries. So it's our duty of care that we should do our best for our patients. Are we doing it? That's the question. We all know how to treat hip fractures, I'm sure. But the objective of this session is to update our knowledge, and also we need to kind of learn about emerging trends and new research. So let's go ahead. This is my first case, a 42-year-old female, high energy crash, no other injuries, is only an isolated fracture. I think we all will agree that needs fixation. But when should we fix them? How do we reduce it? How do we fix it? There's so many questions that pop in. And remember, 3 to 4% incidence, so every DGH is expected to get 10 to 15 of these a year. So to discuss all these facets of this fascinating injury, I would welcome Mr. Bob Handley. Mr. Handley works out of Oxford. He is one of our senior most consultants in orthopedic trauma. He is currently the president of British Orthopaedic Association, but I'll tell and elaborate on that a bit later. I think let's go straight into it. Welcome, and over to you, Bob.
Good afternoon. Thanks very much, Kitish. It's a pleasure to almost be there with you, but I'll do my best from a distance. So the topic that you've introduced and that I'm going to talk about is high energy or young hip fractures. And so I think that it's worth considering as to why they're different from other hip fractures, the regular NOF that we see. And we need to be honest with ourselves when we look at these things. And I think they're people like us. They're more often, well, I'm growing out of that us age now, but for you, they're the people that look similar to yourself. They're younger and they've got an injury that you can empathize with more. You're likely to follow them up, whereas the vast majority of hip fracture patients in the UK that are dealt with in the regular NOF group, the older patient, we never follow up again, and we have very little personal idea as to how they're doing. We do know that the younger patient's going to have greater demand, so they're likely to put whatever construct we implant in them to a greater test. Their life expectancy is greater, and so that makes us much more wary about using an arthroplasty because we're not so sure about the long-term consequences of that in somebody who may have completely otherwise healthy joints. The life expectancy being greater means there's more chance of it failing. But we've got the great opportunity of what we believe is good bone, so we can do our good carpentry job on a sound specimen rather than the older osteoporotic bone. So what is fate, and what can I control? Well, if you look at the injury factors, there are the things that the initial displacement, the anatomy of the fracture or its fracture location, whether there's comminution of the fracture, and in particular about the anatomy, people talk about the Powell's angle, of which a little bit more later. The technical factors that we've got, what can I control as a surgeon? I can decide to do the operation at a particular time. I can achieve a better quality of reduction. I can choose to decompress the capsule. And I have a choice as to what fixation construct I'm going to use. So we'll look at some of these aspects. And I'm very grateful to Nitish because he allowed me to steal a presentation of his, and I've taken bits out of it and just magnified some of them. I put this one in because time of emergency surgery, and this is from Mark Swinkowski in 1984. And the two reasons for putting it in are firstly the figures that are there, that you see that he had a zero non-union rate with his early surgery. But more importantly, for the way in which I wish to consider this, is I think we learn an awful lot by the people that we've worked with. Whether we like it or not, we tend to follow things and copy the people that we've respected. And I was Mark's fellow. I was Swinkowski's fellow when I was in Seattle. And so a lot of my practice was shaped by what he said. And so early fracture treatment I thought was important. And when the later evidence came along that it probably didn't make that difference, I took a little bit of convincing about that. But it would seem to be the case that there is not a huge advantage in early surgery, and it's probably better if you operate on it in the cool light of day and you deal with it with an experienced team rather than rushing it in the middle of the night. So, no association between timing of fracture and AVN, and delay of more than 24 hours may increase the risk of non-union, but I don't think most of us would be talking about delaying more than 24 hours. It would be whether we go beyond the night of presentation. Capsular decompression. Well, that was something else that Mark was interested in, because the reason I went out to Seattle in the first place was to look at laser Doppler flowmetry in bone. And he'd looked at the blood flow in rabbits in various instances, and capsular decompression he thought was an important aspect of it. And the figures, so if we look at displaced fractures, numbers that developed AVN in those that had decompression and those that didn't, there's a higher incidence in the displaced fractures. And so that there is a notion that may be important, but subsequent evidence has not really proven that to any great degree. And so it's not a regular thing that the majority of people do for itself. They may do it as part of another procedure. Screw placement. Well, what we can learn from the older patients and what we shouldn't reproduce in the younger patients is if you're using screws, don't start their entry point below the lesser trochanter. That's associated with a high incidence of subsequent fracture propagated through what may be multiple fracture points, because if you've got 3 screws in there, there's almost certainly more entry points that you've had to go at in trying to get the adequate position. And so don't start too low. So what type of fractures do you get, and are some suitable for screws? Well, I show this because in Oxford, we do see high energy or young hip fractures, but the high energy tends most frequently to be a direct application of that energy. And this is a typical Oxford winter cyclist, a 39-year-old who slipped on an icy road, and you can see that they've got, from the CT, it's valgus impacted. So although it's a little displaced, the blow has come on this skinny patient right over the lesser trochanter, greater trochanter, as they've slipped and not got their toes out of the cleats, and they've impacted it. They're fixed in situ. That's not reduced, as you can see. They're fixed in situ, and subsequently have healed very nicely and is back cycling. And one of the patients that we did this on came in the following winter, and he'd taken a different bend and done exactly the same to his opposite hip. He hadn't learned his lesson. We fixed it the same way, and he did well twice. So talk about the Powell's angle. So Powell's, he commented on the association between the more vertical orientation of the fracture and a poorer outcome. And this tends to be associated with shearing forces at the fracture site rather than impaction or angulation. And shearing is bad for fracture healing because it means the strain environment is the same across the whole fracture plane. So you can't get spot welding or healing just where it's optimum. It fails across the whole plane. And in PALS 3, screw fixation, as I showed with the impacted fracture that I had, is not nearly so appropriate. It doesn't stop the shearing force to anything like the same extent. And so fixation with a fixed angle device, such as a 2-hole DHS, is more appropriate if you're just going to use that fixation in isolation. And so you can see that there is disagreement still as to how you might do this. This was from a paper in 2017, and in it had an OTA survey of their surgeons attending as to what they would use for a PALS 3 fracture. And the majority, 47%, said a fixed angle device. And that is what tends to be shown of the simple devices to be the better method. However, if you use the analogy of another fracture where you have worry about shearing, to stop the shearing in this fracture that you're all familiar with fixing, you put an anti-glide plate at the apex of the fracture. And that is quite possible with a hip fracture too. So in this instance, as well as the screws that have been placed, just as with that tibial plateau, capturing the apex of that of the fragment is an anti-glide plate. And this does seem to be a more stable way of fixing these fractures. And in the paper that Yi put together, where they had 28 younger patients, they had 89% unite without femoral neck shortening. And as you're aware, in the younger age group, one of the things you want to do is preserve the overall anatomy of the hip, just as you would do when you're putting a total hip replacement in. So it may be that this adjunctive plate is a better way of approaching it. They put theirs in through a Smith-Peterson approach, which they also used to reduce the fracture. Which brings me on to quality of reduction. And this would seem to be the most important thing. Now, going back to Swinkowski, when I worked with him, he let me reduce the fractures closed, and I would do that, but then he made me open it, and then I saw that my close reduction didn't look nearly as good as it did on the image intensifier. So I've tended to be an advocate of open reduction in a younger patient, because I don't believe that I can adequately reduce the fracture closed or assess the reduction. That also now gives you the opportunity, if you've done an open reduction through a Smith-Peterson, to put that adjunctive plate on there. So I think quality of the reduction is vital. And if you do have an inadequacy in your reduction, make sure it's not varus. So open or closed, I think I've said that now. My tendency is to go to open. The evidence for that is not that great, but you don't see enough to gain significant experience yourself. So you tend to do what you're comfortable with. And so I do an open reduction. And this is just to show why you want to get it right the first time. As you know, girth is the other string to my bow. Get it right the first time, then you don't end up having to do this. Having to do osteotomies, correct the fracture plane, and do this, which can heal, but in a young person is not a situation you want to be leaving yourself open to. So in summary, don't operate in fractures in the middle of the night. It's not necessary. If you're not entirely happy with a closed reduction, open it. Screws are good for horizontal fracture lines or in practice fracture lines, but a fixed angle device is stronger for a PALS 3. But now I think that you may use screws with an anti-glide plate on there. But quality of reduction is critical. Avoid varus. Thanks very much.
That was very instructional and enlightening, as expected. So I haven't got any questions at the moment on the chat box, so we'll probably save that for the later. Let's move on to my next slide. Could I have my next slide, please? Sorry. So we're going to another age group. This lady is 74, mobilizes independently. There's no cognitive impairment, no medical comorbidity. I think all of us agree that, again, this patient needs an operation. Are we fixing it or are we replacing it? If you're replacing it, are we doing a hemiarthroplasty or a total hip replacement? Where our National Institute of Clinical Excellence, or NICE, would probably, has already advised us or guided us that we should consider doing total hip replacement in this fitter individuals with the criteria that I've already said. So are we overdoing it? We were criticized as trauma surgeons that apparently only 1/3 of the people who fitted this criteria had hip replacement over the last few years. But there is some new research, and it's my pleasure and honor to welcome Professor Mohit Bhandari all the way from Canada. Mohit is currently the professor and academic chair of McMaster University, and he is a world-renowned orthopedic trauma researcher. He's written thousands of papers, and his hallmark is to carry out multinational, multi-center randomized controlled trial. It can't get better than that. Mohit has done intense research on hip fractures recently, and we would love to hear his views about management of this elderly patient with hip fractures. Over to you, Mohit, and welcome.
Once again, thank you so much. And I look forward to sharing with you, if I can, just where we are with respect to this key issue. Now, there are probably more than 5 publications that I could speak to, but these are fairly important ones. And I also had the privilege of working and continue to work with Mark Swinkowski, as Dr. Hanley also mentioned his interactions. There is a review in New England Journal of Medicine that he and I wrote in 2017. It's one of the reviews worth, I think, reading, and only because it helped me and him summarize some of the evidence in this area. But I will focus on a few key areas, and I will put a little emphasis on a few large randomized trials and a meta-analysis of trials. But here, my friends, is the simple truth. Hip fractures have a high mortality rate. They have a high rate of morbidity. They have a profound impairment of independence. And the truth is, we still have not sorted out the revision issue. So there are even, if we look at studies that have come out over 20 years ago, the revision rates haven't necessarily improved substantially. If you look at this simple graphic that looks at mortality versus the quality of the studies and the studies over time, if you look at the 1980s, 1990s, and into the 2000s, we actually saw that mortality after hip fracture wasn't decreasing. It seemed to be, if at anything, increasing. So we have work to be done. I think we could also argue that while we have had lots of research, the optimal approaches to fixing and replacing fractures still remain absolute. In terms of the absolute choice is somewhat inconclusive. Now, we have algorithms, and I'll share with you where I think the evidence is taking us. But also ask yourself this: in what other field would we have tolerated high surgical failure rates, except for 50 years in the management of this particular injury? But let's fast forward to where we are today. Have we identified the ideal implant? Now, this research came out some years ago. This is some work that was done with a number of individuals who ultimately ended up working together on some trials. But the first comparison was, do we fix or do we replace the elderly femoral neck fracture? And when we looked at revision surgery, it appeared that replacement reduced the risk of revision by a substantial margin compared to internal fixation. So when in this frail elderly population, there did seem to be an advantage to arthroplasty. Those who were having revision surgery were having non-unions, and as well you saw evidence of avascular necrosis. Those having arthroplasty weren't complication-free. In fact, with total hip replacement, you can see here just under a 7% risk of early dislocation. I want you to remember this now. This 7% risk was based on dislocations over 20 years ago. And we'll see if the updated evidence helps us. But the question still remains, in those patients, if arthroplasty is a preferred treatment, what do we do? What is it? Is it a total hip arthroplasty or a hemiarthroplasty? So this brings me to the health trial. This was the hip fracture alternatives of total hip arthroplasty versus hemiarthroplasty. This was published not that long ago. And many surgeons, many countries, and many clinical sites and simple question. It was to determine the effect of total hips versus hemiarthroplasty on unplanned secondary procedures within a 2-year period. You can look at the general inclusion criteria, but these were low energy fractures in which adults were ambulatory prior to the fracture, and these were displaced femoral neck fractures. We included just over 1,400 patients, and we had fairly good follow-up at 2 years. Now, the typical patient, I suspect, is not unknown to many of you who are treating these patients. Female gender, 70 years of age or older, independent ambulatory at the time of the fracture, sustaining a subcapital displaced fracture. When we looked at the overall primary endpoint with respect to revision within 2 years, you can see the numbers are near identical. And in fact, there was no difference overall between a total hip arthroplasty and a hemiarthroplasty in that 2-year period. In fact, when we looked at mortality, no difference. When we looked at differences in function, and this was an important one because we had believed that function would be dramatically improved with total hip arthroplasty in that early period. In fact, we did not find a clinically important difference in function. If anything, we found that the total hip replacement in that patient population was clearly a larger, more serious procedure and also led to more serious adverse events. So among patients with displaced femoral neck fractures, the incidence of secondary procedures over 24 months did not differ. And in fact, there was a clinically unimportant improvement of function and quality of life at 2 years with a potential increase in serious adverse events. So you can see in that 2-year period, there didn't seem to be a particular advantage to a total hip arthroplasty. But what about going further than 2 years? Going out to 5 years, for example. There were many who said, the health trial didn't follow patients long enough. Well, we followed up in the Journal of Bone and Joint Surgery with a meta-analysis of 16 randomized trials looking at a similar topic. Keep in mind, though, that of the 3,000 patients, over half of them were just based on our health trial. So it was a large driver of the overall results. Once again, when we looked at all the data, there was no difference in revision up to 5 years, but we also again found from a pooled meta-analysis of trials, no clinically important difference in functional outcomes, and only a small difference in operative time that would be favoring the hemiarthroplasty. So again, based on moderate certainty evidence, we found no conclusive rationale for total hip arthroplasty over hemiarthroplasty in that first 5-year period. Now, in ortho evidence, we looked at one more time period. What happens after 5 years? Maybe the advantage is a longer term advantage. And as you would anticipate, the advantage for total hip arthroplasty did appear to show its support in the longer term follow-up. So those patients who had had longer term follow-up with total hip replacement versus a hemiarthroplasty did in fact seem to have overall lower rates of revision and overall better outcomes. One point I will make, and this is becoming more and more of interest, has been the issue of in patients who are being treated with hemiarthroplasty or arthroplasty, should we be cementing the canal? And in fact, if we look at recent evidence, and this is just one example in JAMA, but there are numerous examples coming out that among patients with hip fractures treated with hemiarthroplasty in a large US healthcare system, uncemented fixation compared to cemented was associated with a statistically significant higher risk of aseptic revision. So there has been a big push towards thinking cementing and the concerns around uncemented prostheses leading to high revision, but also in recent studies, higher mortality rates in that early setting. Does that mean, though, that we shouldn't be fixing any of these fractures? Should we abandon fixing femoral neck fractures in this particular patient population? Well, there is arguments that, fixation is less blood loss, less OR time, possible decrease in mortality risk. And the truth is, even if we have high revision rates, we may also have a number of patients that will never need a reoperation. In fact, 2/3 of those. And truthfully, patients, when given the choice of retaining their femoral head and fixing it versus replacing it, seem to prefer that option. In a patient preferences study that was conducted, we identified that 56% of patients preferred internal fixation over arthroplasty due to the following issues. They had less invasiveness, less blood loss, shorter operating times as big drivers, and the perception that it's because it was a a smaller, less invasive procedure compared to an arthroplasty, that it would also help them with respect to mortality risk. Mark Swiankowski, as you've heard a few times, has had a strong recommendations for fixation, saying, well, we need a, quote, perfect reduction, hence his propensity to open fractures rather than close reduce them. He's talked lots about capsulotomy, the inferior screw, and the critical inferior and posterior screws. All of these have already been beautifully presented by Dr. Handley, so I won't go into that detail. But I will focus on one area that I think is important. When we fix these fractures, we have long accepted that, well, healing is the prime importance and shortening is of secondary importance. But as we think about patients in modern day, most patients do not accept limps and pain because of a shortened femoral neck that may otherwise be healed. So what can we be doing to limit that degree of shortening? And in fact, shortening and collapse, can have impact. Shortening is common, both in displaced and undisplaced fractures, as we've seen in our previous literature. And that led us to a trial called the FAITH trial, which was another large study of 81 centers across 8 studies, where we said, well, is there a better alternative to the multiple cancellous screw fixation approach to femoral neck fractures, both in the undisplaced and displaced fracture patterns? When we looked across these 366 surgeons who participated around the world, including sites in the UK as well as India, we had a couple of very simple findings. The sliding hip screws did pretty well overall when it came to management of displaced femoral neck fractures. Now, we're not saying that you should be treating all displaced femoral fractures with fixation, but should you decide based on individual patient characteristics that a fixation would be appropriate, considering a sliding hip screw would be a reasonable alternative. In fact, we found that sliding hip screws perform better in patients with displaced fractures with base of the neck, with the basicervical, as well as those patients with other risk factors for non-healing, such as smokers. So what is the road ahead? Well, evidence has still not yet identified optimal arthroplasty or internal fixation. We continue to get closer and we develop algorithms, but we have more work to do. Maybe it's about time. Maybe it's about how quickly we get patients to the operating room. We're doing studies just to sort that out. Rapid treatment in and of itself may be the answer. Biologics may also play an answer, although in the past we've had some difficulty getting biologics to demonstrate clinical efficacy. There's lots of opportunity for us to be considering in the future. But at the end of the day, friends, it is going to require all of us to work together through large collaborative trials. Thank you.
Thank you, Mohit. That was absolutely fascinating. And congratulations on this work that you're doing. In the UK, at least, we tend to cement all these elderly people. And I think gradually we are coming to the fact that we should offer hip replacement for fitter individuals who are going to live and enjoy life beyond 5 to 10 years. So but I think it will all get resolved with time. Thank you for your effort. There are some questions popping up in the chat box. I think I'll hold on to them, and if the panelists kindly hang on till the end, depending on the time, we'll discuss 1 or 2 important ones. So let's just move outside the capsule. This is that dreaded, unstable, extracapsular fracture we all get to see almost once or twice in a week. The posteromedial buttress is gone. So we know that sliding hip screw probably will not work here. Should we nail it? Or how do the patients do? How do they regain their function? Is there any other solution available where we can start prompt pain-free mobilization for this elderly group of patients? So to throw more light on these topics, it's my honor and delight to invite Mr. John Mukhopadhyay. John is a veteran AO teacher. He is the head of the department of Paras HMRI Hospital in Patna, India. So thank you, John, for joining us from such far away. He is also the chairman of the Research and Education Council of India, and he is a well-known trauma surgeon in that part of the world. Welcome, Jay. Over to you, John.
Thank you, Nitish, for this kind introduction. It's a pleasure to be here with all of you. I was in the last BIOS meeting that I attended was in Manchester, where I was invited as part of the Indian summer. So I'm going to talk about unstable trochanteric fractures. Basically, no conflict of interest regarding this presentation. And we're going to look at some of the problems associated with the fixation of these fractures and try to define the role of arthroplasty in them. The problem that we see very often with trochanteric fractures, although personally I still believe fixation is the first priority in most of these fractures, and the options could vary between a nail and maybe a sliding hip screw with a side plate or wiring of the trochanter. So this would be my usual practice for most unstable intertrochanteric fractures. However, there may be some fractures which would be better off with a primary arthroplasty. The second area is obviously with failed fixation. And here, I think the indications are a little clearer, and often an arthroplasty is indicated. The problem we see every now and then is, in spite of what method is used, whether it's a nail, a plate, a locking plate, a sliding hip screw, or a dynamic condylar screw, we see failures with these fractures only far too often. And often it may be evident in the initial fixation, but there are times when fractures look pretty reasonably fixed, but unfortunately fail pretty quickly after the initial fixation. And this is an example of a trochanteric fracture nailed, of course, with 2 screws, which may not be the best implant, but it failed within a period of short time of 6 weeks. The fracture had gone on to fail. So it's interesting. Obviously, many people have had this experience of failures. And Dr. Bruce from Leuven was one of the first people to actually publish on this. And they looked at 102 patients which they treated between 1980 and 1984. And this was before the sliding hip screw became very popular. And they found that they had very good results with it. They found the mortality to be no higher than internal fixation, which they had done in a corresponding group before they had started doing arthroplasty. They found the procedure was actually no more extensive. And they obviously found that the mechanical complications were much lower. However, with the DHS coming into its own in the later part of the 1980s, that became the first method of treating these fractures. And obviously then we went on to nails for the more unstable fractures. So, but in the last 10 or 12 years, there have been a lot of papers comparing the results of primary arthroplasty with either fixation with a nail or a DHS. And this is a study from France, which was quite a large study, which looked at 113 in the nailing group and 137 in the arthroplasty group. This was a multi-center study, but was not randomized. They included unstable fractures, 31A2.2 and 3, and 31A3.3 fractures in this. And these fractures and the patients were matched for age, sex, preoperative Parker scores, the fracture type, and medical comorbidities. And they found in the results that the 3-month mortality was identical in both groups. The mechanical complications were more common in the nailing group, while the functional results were better in the arthroplasty group. And so they concluded the present study validated hip arthroplasty for these patients. However, there was one difference in that the ones who had the arthroplasty were treated by more senior surgeons or more experienced surgeons than the group which was treated by internal fixation or nailing. There's another study which looked at complex unstable intertrochanteric fractures and compared the results of DHS or arthroplasty. And this is showed that in group A, which was compared to group B in terms of blood loss, duration of operation, there were no statistically significant differences. But group A, which was the fixation group, had a higher incidence of device-related complications. And when we looked at high-risk hip scores, they were better in group B, that was in the arthroplasty group. So again, in favor of arthroplasty for these unstable trochanteric fractures. And this is a study from Japan, a recent study, which looked at bipolar hemiarthroplasty for unstable intertrochanteric fractures. This was not a comparative study, but they actually looked at CT scans before deciding on which patients to go for arthroplasty. And they found a fairly good result with an excellent to good results of almost 60% of their patients in this group and no additional complications as compared to the fixations that they were doing earlier. Come to the Cochrane library. The meta-analysis in 2016 from the Cochrane Library showed that there was insufficient evidence from randomized trials to determine whether replacement arthroplasty had any advantage over internal fixation for extracapsular hip fractures, and further larger studies were required to really come to a good conclusion. So I think the issues that come with arthroplasty in these fractures are the fracture of the trochanter, the entry point, how do you decide length and version? When the calcar is gone, it becomes even more difficult. And of course, they have a high dislocation rate, so as was reported. We also have to be aware of the Kyle variant, where some fractures may have an extension onto the neck. And here's a classical example of a patient we just treated very early, very poor medical risk. And when we looked at the x-rays, it was a situation where we thought we might go for an arthroplasty. So we got a CT scan done. And if you look at this, you can see that the fracture actually extends right into the neck on the posterior part. And that was the head when we took it out that we retrieved in the procedure, and we went on and did hemiarthroplasty. Similar cases where the trochanter would also be totally avulsed in this situation, you would need to wire the trochanter back as well as do a hemiarthroplasty. And okay, in India, we still get patients presenting late. And if you have a very unstable situation with the patient presenting late and very osteoporotic bone, these might be situations. And again, if you look at this lateral x-ray, you can see the fracture extends pretty much close to the neck on this side. And so it would be a situation where we do an arthroplasty. So here, again, you can see what we use the supine position and a modified hard hinge approach. But in these fractures, we work through the fractures. And so we use this position when we look at the tibia and the two epicondyles. That's a good guide to our version. And that is how we control the version of the prosthesis. In this case, we used uncemmented long stem prosthesis because of the we wanted to extend the prosthesis lower down because the fracture extended quite low down. And then we was the post-operative result, wired the greater trochanter back on. So what about revision fixation after failed fixation or complications? I think this is still possible in many situations, but you would again have to consider arthroplasty where this is not possible. If you look at the acetabulum and if that is in a bad shape, you would decide on a total hip replacement. And of course, you have to look at patient factors and then decide whether a hemiarthroplasty like a bipolar would be enough or you would need to do a total hip replacement. So again, like I said, we tend to go the extra mile to preserve the hip where possible. This is a 65-year-old patient, and you'll just go through a series of x-rays. This was treated elsewhere, and you can see with the DHS, which wasn't appropriate in this particular fracture, and not surprisingly, it went on to fail. This implant was removed at 14 months, and she presented to us at 17 months. But again, here, because the joint was okay, and we had a reasonable amount of the trochanter and the proximal femur still there, we decided we would fix it. We used a DHS, we valgusized it, we used bone graft, and we also used a tension band wiring for the abductor mechanism. And you can see this lady with a little bit of medialization went on to heal and had a reasonably good function at 7 months post-op. However, there will be situations where you will have to do an arthroplasty, and this study from China looks at the state of the art of doing revision surgery for failed fixations. And they said you have to look at all these factors: the physiological age, the life expectancy, the bone quality, the hip joint function, and the functional levels in deciding on what you have to do. And of course, if you have a situation like this, where really the trochanteric fracture is beyond reconstruction, it's gone on to becoming almost like a neck fracture. But because the acetabulum or the joint is okay, we could do a bipolar hemiarthroplasty, but you do need to cement the trochanter, wire the trochanter back properly. And here's another situation where a long lock plate was used, went on to fail, also got infected, implant had to be removed. And then finally, when the infection had settled, we went ahead and did a long stem uncemented total hip with a cemented cup and a uncemented stem, because we wanted to bypass all the bone holes that were there due to the previous fixation. So I think you need to look at certain factors when you're doing it for failed fixations. You need to rule out infection. You have to consider removal of the hardware. You have to think about the previous incisions. And of course, you need to look at leg length discrepancy, the trochanteric comminution. Of course, the anatomy will be distorted, especially if they've been fixed before. And you have to also think about stress risers from the previous hardware. So I think primary arthroplasty has a role in some of these fractures, but it's not without its own problems. This I would never do a hemiarthroplasty for a fracture such as this, but hemiarthroplasty has become quite popular for these fractures in India. And this was done by a well-known, fairly high volume hip arthroplasty surgeons. It wasn't done by someone who was a novice at this. He got a reasonable fixation. The trochanter wire we could argue about that. But this elderly patient who was in his 90s went on to have a periprosthetic fracture. And this was a cemented hip. We had a real job trying to salvage this and do a long stem prosthesis to replace the earlier prosthesis. Also, this study from the Mayo Clinic, which looked at perioperative 30-day mortality after intertrochanteric fractures treated by internal fixation or arthroplasty. And they found that in the 1,873 operated fractures between 1969 and 1997, they had 4.8% 30-day mortality in the arthroplasty group and 4.5% in the fixation group. So not a whole lot of difference, but when they looked at it more closely, they had a significantly higher incidence of major intraoperative complications and the number of patients who died while they were still in hospital in the arthroplasty group. So you have to be aware of the complications when you decide on doing an arthroplasty. So the take-home message is I still think that most trochanteric fractures should be fixed. Look out for the Kyle variants. Rule out pathological fractures. That's something you always need to look out for in some of these elderly patients. I think CT scans are beginning to have a definite role in assessing these fractures more carefully. And for me, I would still reserve arthroplasty for failures of fixation and exceptional situations where fixation is likely to fail. Thank you very much. Stop sharing.
Thank you, John. Unfortunately, we're just about in time, so I'm not able to field any questions for the panel. Okay. I've looked at the question and will answer them. It's my duty to thank Mr. Bob Handley, Professor Mohit Bhandari, and Mr. John Upadhyay for sparing the Saturday for us and giving such fascinating overview on this common yet kind of difficult problem that we face day in and day out in our trauma practice. Thank you all. So this brings to an end to this session. Thank you. So the next session is the official address of the President of British Orthopaedic Association. It's my honor to invite Mr. Bob Handley back in. Mr. Handley, as a matter of formal introduction, grew up in London, trained in Sheffield, and then had fellowship, as he said, in Seattle, and has been a orthopedic trauma consultant in a consultant-led practice at Oxford Trauma Unit for the last 27 years. He has held various positions. He has been the past president of AO UK, of the Orthopaedic Trauma Society, and is currently, as you know, the president of the British Orthopaedic Association. He has been attached to the NICE and also heads the Getting It Right the First Time GUFT project. Mr. Handley is known to be a teacher, a philosopher, a thinker, and we all have kind of modeled after him and thought to him as our mentors. He has this awfully difficult time or task of leading the British orthopedic community through this challenging pandemic for the last 15 months or so. I'm sure he's got fascinating experience which he would like to share with us. Without further ado, Mr. Bob Handley, President of British Orthopaedic Association.
Thanks very much, Nitish, and good afternoon. It's odd to hear yourself introduced in that way and not be able to stand in front of an audience and speak and gauge a reaction. And it's difficult to know how to make a presidential address via Zoom. So do I present a relaxed figure hiding behind a PowerPoint presentation? I could have taken the camera out into the garden. It's it's quite sunny here now, strangely in Oxford. It was tipping it down a little while ago. Or do I try and do this like some party political broadcast staring into the camera? Well, I've chosen the latter. I'm going to do it as a party political broadcast looking at you face to face and hoping that there is some reaction. I am a BIA president, but not as you've known it in the past or not as I've known it in the past. I haven't had a single face-to-face meeting during my time with the BOA. So no council meetings, no committee meetings. I've not been anywhere as BOA president yet. This is as far as I've got to my study. I haven't left the UK at all during the last year. So I haven't done the normal go away and represent you all in foreign climes, both from the professional point of view and in a social perspective. In fact, the furthest I've got to is not far from where Kittish is now. I have been down to Swansea with Gerft. But despite these impediments, as you might imagine, there's quite a lot to report over the last year, and it hasn't been an uninteresting time, to put it mildly. I'm going to touch on three areas which I think are of relevance. One which isn't related to COVID at all, which is a diversity. Another one, COVID itself, and then pathways, which I think are developing and are consequential upon COVID. So to talk about diversity, it's a topic which had come up a lot over the last few years, both within and without the orthopaedic sphere. And I think within orthopaedics, it was seen to be a particular problem. There aren't many areas of diversity which are easy to measure. The easiest by far is to see how many women there are in a particular group. That statistic comes through. And in terms of the TNO, we didn't seem to be performing particularly well. And that might be for a variety of reasons, whether that's a desire of the individuals to pursue a career in TNO, or whether there are unnecessary impediments in the way of that pursuit. And I think you can see in some respects that in medicine we do quite well, because if you look at the first year of a medical school intake, it's genuinely pretty diverse. There's certainly, in terms of the male-female split, there are more women than men attending medical school now, and ethnically there's a very good mix. But that doesn't mean there aren't hidden areas of lack of diversity or discrimination. And so the educational background that people come from, their social class or such like, may have an impact that we're not able to easily measure or easily monitor. But within orthopaedics, there are some particular areas of issue. So if you speak with medical students when you get the opportunity and find out what they believe of the orthopaedic surgeon, they tend to have a stereotype of a rugby playing white male as being the most suitable candidate for a career in orthopaedics. And that genuinely still persists. If you talk to first year medical students, they will have got that into their mind from somewhere, whether that is parents, TV, peers, I don't know. And it becomes a chicken and egg, because if they don't then wish to pursue the career, they don't have the role models to change that. And I think that the best way to undermine those stereotypes is by having good role models. And there are definitely changes within our community, within the BOA. Last year, there are 4 elected posts to the council each year, and 3 of those were women, and they'll take up their posts in January of next year. But I think you can see how perceptions can be changed. And to draw analogies of other walks of life, I think is quite interesting. So if you take cricket, now I'm an avid test match special listener and have been since I was a kid, and it genuinely would have seemed odd and quite out of place in the past to have a woman commentating. But after a few years, it's now perfectly appropriate, perfectly reasonable, and I'm sure that must have changed the aspirations of women looking to where they're going to try and have their career, because they do see good role models. And I think that's our job, is to try and provide good role models. And if we're not able to provide them ourselves, to put other people into the limelight so that they can do it on our behalf. But even with that, you hear cricket providing another area where you know that there are things which are not good. So I don't know whether any of you will have listened to the great fast bowler Michael Holding's discussion on discrimination. And whilst there were many positives, there were a lot of bad things. And you realise that in society in general, there are things that we have to have our guard continually raised to try and protect ourselves and protect our communities. The BOA has a working group on diversity, and anyone who has ideas that wish to put into that group would be more than welcome. If we move on to looking at some aspects of COVID, the main one which is troubling us at the moment is how the recovery is going to work. And when we heard from the Welsh Minister of Health, that was what was discussed. And that will depend on a balance, as she pointed out, of the demand and the supply. Well, we reckon that the demand will be pretty much unchanged for orthopaedics. The main waiting lists that we have are for those people awaiting treatment of degenerative conditions. They're not likely to undegenerate with the passage of time. The patients who are awaiting total joints in particular tend to be of better health than their age-matched contemporaries in the general community, so they're not going to go away. And so we're going to need to meet that unmet demand over the next few years. And how are we going to meet that demand? What facility do we have? What resource do we have? And the major limitation is the workforce, whether that be hours in orthopedic surgery or anaesthetics or theatre workforce or whatever. And if you look at the workforce, you can look at it in three areas. Those who are entering it, those who are already within the workforce, are they going to work harder, work weekends, work nights, work 3-day sessions, etc.? And those who are going to exit it, is their retirement going to be brought forward or changed? And at the entrance end, the training is a real issue. Rob Gregory, who's, as you know, chair of the SAC, reckons that there's a good chance that about 25 to 30% of trainees will have to hold back on their CCT date because of lack of completion of training cases. And that's going to pose a huge burden if there are still the expected number of retirements, or God forbid, there are more retirements than would have been the norm. Superimposed on this is the expectation or the hope on the part of the NHS that we'll work harder. They would like people to work extra sessions, to work into the evening or to work at weekends. And it's not clear whether people are going to want to do that. It's also not clear whether people are going to want to see that there's a financial balance to doing that, because there's always in the background the issue relating to pensions and extra work. So one of the ways in which we're trying to approach this is over the next couple of months and before the Congress, we want to do a BOA survey to look at all of those aspects about entry into the career part of our profession, the work rate that people would be willing to accept, and plans on retirement, because we think that that's one of the bigger contributions that we can make on behalf of the profession to seeing whether we're going to be able to meet the unmet demand. Finally, to look at other reorganisations that are going on around us and how that might affect us. There is within England a significant reorganisation towards ICSs, so integrated care services. And there's a move towards pathways of treatment rather than individual episodes of treatment. And I suspect that one of the problems that poses for us, particularly in the trauma aspect of our work, is that a lot of our work is genuinely multidisciplinary. And yet we haven't moved on from the notion that there's only one person's name at the end of the bed. So you may carry the responsibility for the patient, but you don't have much authority to change that around you to implement that responsibility. And I think that in that world of multidisciplinary involvement, we need multidisciplinary authority as well, and multidisciplinary control. And that's going to be difficult to institute. But I think that working as a profession between the various groups, so between those of us that are surgically orientated, the anaesthetists and the allied health professionals, we genuinely need to share that authority and responsibility for the patient's benefit. Finally, I'd like to make an advert on behalf of the BOA. We're still planning to have a face-to-face Congress. With luck, there will be 2,500 delegates in Aberdeen. That's the anticipation at the moment, and there's support from the Scottish Government for that in one of their initiatives to try and get larger health-based events back and up and on their feet. So that doesn't include, that 2,500 doesn't include the support staff or representatives from companies or the like. That can be us, the surgeons and members. So I would very much like to see real people in a real place. So I look forward to meeting you in Aberdeen. And finally, thanks again for the invitation to attend and to speak at BIOS. It's a meeting that past BOA presidents have told me that they really enjoyed participating in, and particularly in attending, because it seems to be a family orientated as well as professionally orientated meeting, which I think is an excellent way to go about it. And perhaps I'll be able to see you face to face in another year. So thank you once again.
Thank you, Bob. May I please request the new president of BIOS, Professor Amit Tola, to say a few lines in response.
Hi, Bob. I'm very grateful to you on behalf of the Society for having given up your time on a Saturday afternoon to talk to us. It was very apt and appropriate. Inclusiveness is very close to our heart, and our society should be also moving in that direction. All the problems that we face on a day-to-day basis, I'm sure these things will hopefully even itself out with time. And yes, we missed you to come here because of this being a virtual meeting and the effect of the pandemic. But hopefully we will all meet up in Aberdeen and on a face-to-face basis. So thank you once again.
Thank you.
So these are tears that were often associated with ACL ruptures. We've got a probe there.
Yeah, the probe is there. There you go.
Great. Okay, so we're now in the lateral compartment here. James is putting a bit of a varus load onto the knee. So this is the tear we've created. So these are often associated with ACL ruptures. It's either a lateral meniscal root avulsion, but more commonly you find it tears all the way through. So you get a complete transection of the lateral meniscus in the posterior horn. And if these aren't repaired, it's essentially defunctioning the entire meniscus.
Yeah, we can show that. If I take the varus stress off, you can see the meniscus starts to extrude.
Just extrudes, yeah.
And Peter Myers talks about these, doesn't he? They're very, well, I see a few with the rugby players where they really just, yeah, the condyle comes off and transects the whole meniscus, doesn't it?
And I think if in a young active patient, if that occurs and it's not addressed, it will fairly rapidly trash the entire knee. So these are important lesions. I think medial meniscal root tears are always a bit more controversial because they're often associated with a bit of degeneration, but these traumatic ones are associated with ACL ruptures, can be difficult to treat. So you really want to know about these beforehand if you can. So a really good look at your scans, make sure you're happy with what tear patterns you've got, and plan for these as much as you can beforehand because they're a nightmare when they're a surprise on you in theatre. Okay, so what we're going to try and do for repair-wise for this one, we're going to be using the new device, the Nova Stitch Pro, and the plan here will be to put a stitch through the meniscus, out, across, and down through the other side, and then tie it over with a knot. We'll usually put one at the back, and then one at the front as well, to try and get those edges opposed. It gives you a nice circumferential stitch, and it's through the entirety of the meniscus without having to stitch it down into the capsule at the back of the knee. So to get easier access to this part, we're just going to swap portals, and we'll drive our Nova Stitch in from the front. Okay, so there's our ACL. So there's our tear here. So the first thing I always do when you do these is pop your hook in first, just to make sure you're happy with the alignment and you're going to be happy with where you're going to deploy. So we're going to aim for one stitch at the back going across, and then another one more anterior coming across this way. So whilst it's loaded up the Nova Stitch, for those that aren't familiar, it's an all-inside device. It pushes 2 throws from bottom to top, and you can feed the suture all the way around. It comes in 0 and 2-0, so generally for radial tears you're using the 2-0, and for the root repairs you probably want to go to a slightly stronger suture. In terms of the device, if you can see on the outside shot, we've got 2 or 3 handles. It's very ergonomic. The orange handle allows you to elevate and depress the jaw at the front. The grey handle deploys the lower jaw, which is attached to the suture container. And then to fire the stitch, you squeeze the orange and the black stitch, and that will deploy that suture. So really when you insert this, you just gently depress the orange handle. And you can see that brings the top jaw into a straighter position, which should allow it to enter the knee joint much easier. And you can really see the low profile nature of this device. When you let go, it follows the nice curvature of the femoral condyle and really allows you safely to place these stitches. So we can really easily get to both sides. So always before you start, make sure you can get to one side and the other. So we're going to be looking at where the black laser mark is where the needle will come out. We can get to that side, and we can also get to the other side as well. So once you're in and you're happy, we can deploy the lower jaw. So I'm just going to withdraw that so you can just see that occurring just there. Just going to wriggle that jaw underneath. There we go, so we should be able to get a good bite in there. We're going to fire that first stitch.
I've just got the thing.
There we go.
The cable caught between the thing.
Okay, you can see it's hit the black laser mark and gone forward, so you aren't at risk of damaging the femoral condyle. And we're just going to just release that. And you can actually do this second stitch without manoeuvring the repair device out of the knee. You can really get a nice firm bite at the back of the knee again. We can then deploy the second bite, and as we withdraw that, should hopefully have passed through. If you just grab.
And these tears have been really difficult to manage before because they're a radial tear. They're not a root tear. They're over a centimetre away from the root, and you know, inside out is challenging here. People have tried with fast fix, but you know that often bunches towards the capsule, doesn't it? And
so what we've done, you can see the single suture has gone up through one body, across the bottom, and up out the other one. So then we will just tie a stitch on the outside of the knee, and then drive that down. That will close the back up, and you often then have to put a second suture just anterior to that to get the front to close up as well. So there are lots of different types of stitches. Prior to today, I was going to say you only need to know one. Which is a very straightforward one. I've been told I've got to try a new one, so I've been taught a new stitch there. It's called the SMC. SMC. Shoulder surgeons love this kind of thing. We're less familiar as knee surgeons. So we're going to go with this SMC, and we can give you details about how to tie them on another date, but essentially, you're going to be looping over.
Very good.
And then we're going to feed the end of that through the triangle. And what this does, this creates a sliding knot, which then also self-locks. Okay, so just gently oppose those. And if I pull this down, that will feed that knot into the knee joint. You should just about see that come down. There we go. Okay, and just like before, what we tend to do at this stage, you've got your knot loader here. This loads on, and allows us to slide down. And it's about making sure we just get that knot down nice and tight. And again, as before with the ramp repair, you really want to make sure you get a nice reduction of your meniscus before tightening down any sutures in here.
So again, sounds just making sure he's not sliding that down against the condyle. There you go.
So we're just going to just push that down and just snug down the back. And you can see it's starting to push those two together. You can do this in a really controlled manner. So you're not relying on pulling tight, you're just putting enough tension on to bring the edges of that meniscus together. Okay, well, we're happy we've got one. Yep, so we're just going to just pull the other one by pulling on the opposite one. Feel, there you go, stop it locked, and that suture is now locked. You can just withdraw the first. And then we can load a second stitch on as well. It's gone quite small, that stitch there was. Okay. So just a straightforward stitch on the outside now. We can feed that down. And if you want to push past with this, you can. Really get a nice snug knot. And we can put a third one down. And usually that will be enough then to secure that knot down. Okay. So we can unload both, pop this back on. And again, as before, just protecting the condyle. There we go.
Very nice.
So that's our first stitch. Okay, that one feels better. And we'll just work our way across.
Often challenging in these cadaveric menisci to get these bites.
is an implant. And
so again, we're just going to use this slow pull, and again, you can see the limbs of that, the loop coming down on the inferior surface. There you are, and that creates that circumferential suture. Allows us to then.
So I'm going to hold that reduced mode. Do you want to just tie that knot then? Push down. And you can see the type of repair you get, one at the back, one at the front. And like I say, the free edge, you can always nibble that away, or you can put a second or third suture in there as well. But that gives you good control, good compression of that radial tear at the back. Very important to do.
Okay, that's great. Yeah.
Over to you, James.
Good. And Sanj, if you wanted to, you could put another one into there, couldn't you? I mean,
Absolutely.
You just keep moving this towards, and I think the more you would, it would just sit
It is, and
down.
it's a very small hole that punches through.
Yeah.
So it's a nice small suture. So you can put 2 or 3. You can put a circumferential one round from either side as well.
And you can see that on the inferior surface. I just try to guide the scope onto the. Just lift the meniscus up, and you can see those 2 sutures sitting on the inferior surface of the meniscus. Do you want to take the scope, Sanj, and just just to see those circumferential
good apposition
yeah.
underneath at the back as well. And
Yeah.
of course, this area will bleed and heal well. So probably in reality, I'd probably go for another stitch right at the front here.
Yeah.
And then you can also protect it by going all the way over here to all the way over here as well. But this tissue at the back, the lateral side, will always bleed and always want to try and heal. Just got to give it a stable.
Hi, good afternoon, everyone. I'm Rohit Rambani. I'm one of the orthopedic consultants at United Lincolnshire Hospital, and I'm an executive member of BIOS. I have the pleasure of inviting Professor Bijayendra Singh, popularly known as Vijay, for his presidential lecture. Professor Bijayendra Singh, we commonly call him Vijay, was born in Gorakhpur in UP. He did his primary and secondary education in Vadodara, Gujarat, and then he went to Maharaja Sayaji Rao University Hospital, where he did his MBBS and MS before moving to UK in 1998. He was retrained in Southeast England, and then went out to do his upper limb fellowship in Perth, Australia, and Kentucky in USA. He has been a consultant orthopedic surgeon since 2007, and he was appointed as a professor of orthopedics in 2014 and is a current program director of master programs at Canterbury Christ Church University. I have the pleasure of inviting Professor Bijayendra Singh for his presidential lecture. Thank you.
Good afternoon, friends. It's a great honor and privilege to stand in front of you here and deliver this presidential lecture. I'd like to thank the BIOS Executive Committee, especially great thanks to Amit for asking me to do this talk. This is an unusual one because we haven't done a BIOS presidential lecture generally. So I thought I could talk to you about the evolution of BIOS to see where we started from, where we are now, and where I hope the society will go forwards to. Slides, please. No, one back, please. So, as with any society, we had a pre-gestational period, and speaking to the founder members, when this became consultant in the late 80s and early 90s, there was a feeling that there should be something given back to their motherland. And the stalwarts under the leadership of Mr. B.N. Mudu, Mr. Murthy, Babu Piravali, Ravi Koka, and Srinivas Markaram got together and formed the society. At that stage, there was no formal name to the society. They first held the IOS meeting in Eastbourne on 15th of May 1999 with an annual fees of £10. This was supported by the BOA, and I'm so pleased that BOA has been partners with the iOS UK at the beginning and the BIOS as we stand now, and the then President Chris Colton and Mr. David Jones, who was the secretary and later on became the president in 2004, were supporting the idea of the Indian Orthopaedic Society. Some of you may remember this day. This was when the World Cup was held in England. And speaking to Mr. Murthy, he was quite annoyed that he missed the meeting and he went to see the India-South Africa match, and the rest is history, as they say. These are some of the pictures, rare pictures that we see with Mr. Mudu, Mr. Koka, in amongst the pictures that I can recognize. The name of the society was only formalized 4 years later in 2003, and it was called the Indian Orthopaedic Society. And the society was fairly advanced even at that stage when they had a website, which was under the IndianOrthopaedicsociety.org, and which was maintained by Mr. Markram and his family and his team for a number of years till we changed the name. At that time, the membership fees was £100 to join, which I'm pleased to say is still the case. At the beginning, there was an annual membership fees for £25, but this no longer is there. Interestingly, the membership at that time was under 50, and the potential was thought to be around 500. Where we stand now is currently over 500 with the potential of nearly 2,000. So we've still got some time to go. We've talked about having a journal for the society, and this is not new, as you can see, in 2003. And as Bob alluded earlier, part of the BIOS ethos has been to involve the family and have some social event. And generally, the executive committee meetings were held in the president or the secretary's house, with thanks to the family. Taking you through the progress, in 2004, it was noted that there was a tenfold increase in the membership numbers, and the attendees from 22 in Cumbria in 2000 increased to 36 in Manchester, 82 in Birmingham, and crossed 100 in Hartlepool in 2003. And that's where we are. I mean, we get to about 150, and I would love to get better and more involvement of the society members. Where are we today with the hybrid meeting? We got about 180 plus online via our website, 20 plus local attendees, and 800 plus via OrthoTV. So we have grown quite significantly. The Eastbourne meeting came back in 2004, and this is why it's remembered quite well, is that the caterers didn't turn up for the meeting, and Mrs. Koka, and this is fondly remembered by the older members of the society, Mrs. Koka cooked dinners for 101 members at the last minute. As the society progressed, there was thoughts about doing more for the membership, and the fellowship, the traveling fellowship we now run, including the senior and the junior fellowship with IOA. We also ran the BOTA fellowship, and I heard from the new president that we're going to restart this. We also have a number of state fellowships that runs. As the society grew, there was thought about doing an Indian summer, and I remember speaking to Mr. Mudu that he spoke to the BOA offices, and there was thoughts of getting Indian speakers, as he felt that the English-speaking countries were invited to the BOA, but although we formed a large contingent, the Indian diaspora and the Indian surgeons, there were not many Indian surgeons coming to the BOA. And that idea came to fruition in 2004 when we held the first Indian summer. And since 2006, we've held one every 3 years. And this year in Aberdeen, we have another session. And given the stature of the society and our role in education and bridging between Indian and British orthopedics, we have been given 2 90-minute sessions, one on infection, which is the theme of the conference, as well as keeping along the same lines, we'll have stalwarts from the British Orthopaedic Association and British Orthopaedics talk on painful joint after surgery. My association with BIOS has been for 12 years now. When I joined, there were about 200 members plus. And again, the membership drive has always been there. And I think as a society, most societies have this on. That was the first time the BOA and the IOA president were invited to the meeting. We had over 120 delegates in 2010. And that was the first time we ever had a conference booklet. And I'm looking forward to this year's as well. These are some of the pictures, and you can see some of the eminent members. This is an 11-year-old picture with the 4 presidents and the previous presidents in this picture. As the society grew, it was felt that the IOS name or the Indian Orthopaedic Society name didn't appear right. And as Mr. Murthy Golapudi mentioned in his award receipt, that we thought that we should change with the times, and the name of the society was changed to British Indian Orthopaedic Society to reflect the changes. And we've been recognized as a specialist society by the BOA for a few years now. What has the society achieved in the last 2 years under my presidentship is we've arranged webinar for core trainees, which have been well attended, over 80 on each webinar. We also did webinar for medical students on their request, which was very well received, and we plan to continue with this. We now have social media presence. Our YouTube channel has over 250 subscriptions, considering it's just about 12 months old. And we have over 4,000 viewings on the same. We also have a Facebook page, and we have a confirmed status as a specialist society with the BOA. We've signed up with an MOU with the OrthoTV channel, which will help promote the education across the globe. Where do I see the future go with the society? I think currently we have council divided into the exec and the EdCom groups. I certainly would like to see that every member is elected, i.e. like the BOA, where all the council members are done via election rather than some of them doing a selection. Membership drive has to continue. We need to encourage newer generation, especially second generation Indian orthopedic surgeons to become members. And the way to do that would be to encourage them to become members of the society at a younger age, perhaps consider giving it to the medical students. We need to look at extending the membership like a lot of the specialist society have done. So the allied health professional, i.e. the clinical specialists, the physios, and the rehab specialists. We must focus also on the medical students. And I've been lucky that during my tenure, we've been contacted by the medical students themselves, and we're looking to have a medical wing of the BIOS. We need to encourage juniors and trainees to be part of this, and that is the only way the society will make progress. We must encourage innovation, and to that aspect, I'm going to advise the incoming team to look at ways how do we support innovation, certainly in the younger age group members. I would like to congratulate Deepa Bose for being elected to the BOA Council, Vijay to the Best Council, and I've also just recently heard that Professor Harvinder Singh has also been elected to the Best Journal Council. Lastly, just to see the changes from 2010 to 2021, just put a question mark, where do I see myself in 2031? As I finish, I would like to thank my wife and my family to have stood around for these last years, as it has taken some time, and the President does get involved quite significantly, and without their support, I wouldn't be where I am. Thank you very much.
Hello, Vijay. This may come as a surprise to you. I think you have done a marvelous job over the last 2 years, and I'm very much aware that this is going to be your last presidential address. Particularly during this cloud of COVID, you've discovered the silver lining of our educational webinars, and we've gone worldwide across on this. So thank you very much for doing that. Above all, I think it's your pragmatic approach, it's your common sense and level-headedness, and the friendship in the Office Bearers Group. And on behalf of the society, I would like to present you with this Excellence Award for your time with us as President. Thank you very much.
Thank you.
And continue to be part of the society.
Thank you.
Friends, today we honor the memory of one of our great teachers, Chitranjan Arvind Talwalkar, who left us not so long ago. It is a great honor and privilege to say a few words about him. Ranjan, as he was known to his colleagues, and CAT, as he was fondly recalled by the residents, graduated in Mumbai at the KEM Hospital and followed in the footsteps of his illustrious father, A.K. Talwalkar. He trained with a wide variety of legendary surgeons, which included K.T. Dholakia, Ellen Vora, and his own father, A.K. Talwalkar. And after passing his MS exams, he proceeded to England and achieved the MCH Orth. On his return back, he became the HOD of the department at Nair Hospital, where he influenced so many of us. At that time, we were eager-eyed residents, and we picked up things like a sponge does. And he supported us through our careers. He made us realize that we probably needed to enhance our skills and, as Sir used to say, polish us up a little bit as we should by coming to England. And through this and beyond his tenure as the HOD, he sent so many of us across to the UK. A number of us have become now consultants in high places, and we owe him that. As he used to say, failure is not a crime, but low ambition is. CAT professionally excelled and advocated minimally invasive trauma surgery. This was not an established concept in those days. Particularly, it was the use of square nails in the forearm and the stacked V-nails in the tibia where he excelled. He received many accolades, and this included a gold medal during his surgical exams, and he remained a fearsome examiner for the MS ortho exams till his retirement. Above all, he was a kind and considerate individual who rarely lost his temper. With a remarkable sense of humor, the philosophy of a simple life was never far away from him, and his pragmatic approach was valued by all who knew him. At his core, he remained a true family man. He is survived by his wife, Shaila, of more than 50 years, and two sons, Nilesh and Sumedh, both accomplished orthopedic surgeons. He leaves a tremendous void in orthopedic surgery and will be sorely missed. I would like to thank Sumedh and Nilesh and the family for giving us the opportunity to do this in memory of Dr. C.A. Talwalkar. Thank you. I would now like to introduce Dr. Nishit Shah, who really needs no introduction himself. He is a very accomplished arthroscopist and sports medicine specialist at Ahmedabad in India, and since 1989, he has been exclusively practicing in this field. He has had international scholarships both at the Cleveland Clinic, and he was the first Indian to have been awarded the Traveling Fellowship of the Arthroscopy Association of North America. He has published more than 70 papers in his specialist fields of arthroscopy of the knee and sports medicine surgery. In particular, his special interests include the PCL and pediatric ligament injuries. He brings with him a wealth of experience. He is probably a pioneer arthroscopic surgeon of India, and I'm very grateful, and on behalf of the society, thank him for coming along to our conference to give us his speech. Thank you very much, Nishit. I would like to thank you on behalf of Bijayendra, who is to the left of me, and the society for this.
Thank you very much. I'm touched by the introduction. Shall we go ahead? Hello?
Are you?
Hello?
We can hear you, Nishit.
Yeah.
Yes, please
okay.
do.
Are you able to see my slides?
Yes, we can.
Okay.
Thank you.
So, friends, I bring greeting from Gujarat. the land of Asiatic lion and Narendra Modi, and of course from the city of Ahmedabad, where Mahatma Gandhi started his Free India movement. I am very much thankful to my friend Bijayendra Singh and team of BIOS for giving me chance to present my views on my journey of knee ligament injury management in India of last almost 30 years. I do not have anything to declare. Knee ligament injuries are not new. In 400 BC, Greeks have recorded it, and this is one of the relics at the temple, 600 years of temple at Ahmedabad, and you can see a hyperextension injury in these wrestlers. So this is not new in India. As told in my introduction, this was the first exclusive arthroscopy center in Gujarat. And at that time, there are only 4 exclusive arthroscopists in India. So our journey has been very, very exciting in developing arthroscopy. We have, of course, the cricket and many other games, but still we get a few patients from traditional games like Kusti and Kabaddi. And my city is the first heritage city of India. And if you understand that if you have a fall from such staircase, multiple ligament injuries are very common. Cycling during COVID and young age drivers like this gives us many pediatric ligament injuries to treat, and that is what I love to do. As compared to Western countries where MCL is more injured with ACL or PCL injury, we see more PLC injury because we have more road traffic accidents and sleeping of the bikes. So with my study, we have around 60% PLC injuries of different grades in our patients. We have many constraints, and one of them of city in a country of 1.3 billion, only 10% patients are having they have insurance. So we have to find out a way to do economical surgeries. Actually, the MRI, as there are too many MRIs in India, and they are misguiding to doctors and the patients. And still physiotherapists are number of physiotherapists is small as compared to the requirement. And that is why in 2008, I used to teach my patient to do resistive exercises like this. And because the follow-up has been difficult because of many reasons. And the biggest problem that I am facing is to convince the parents for pediatric ligament injury surgery, especially in the female child. We have used autographs for almost 30 years, and we are extremely happy with the outcome of it for both the surgeries. And my friends who are doing knee ligament reconstruction surgery will agree that we will not be using more than 10 autografts in one patient in a lifetime. And bone patella bone, you can always harvest a new bone graft. After clinical examination, good quality x-rays and stress views can get you lots of information. And it is my experience that MRI is not so reliable in chronic PCL and posterior corner injury. So we still rely on stress views. I am not going to discuss about the advantages and disadvantages of hamstring or quadriceps tendon graft. But one thing is certain that we have started using perennial longus graft in revision surgeries and dislocation knee, and we are very happy. I am very vigilant about the posterolateral corner laxity from early years of my knee ligament construction, because every Indian sits on the ground in cross-legged position, and if you leave behind this corner loose, then your ACL and PCL is definitely going to fail in long run. For me, still the bone patella bone is a gold standard in obese individuals, high-level athletes, and for revision surgery. And this was the only graft available in first 7 years of my practice. And I am happy that it is revived in Europe, especially in high-level athletes. And for us, it becomes very economical because I can use very simple implants in this bone patella bone surgery. And number of scientific publications have shown anterior knee pain as main problem, but surprisingly in our country and in Southeast Asia, we have not found out this to be true. And this is my patient of 23 years after the bone patella bone surgery, a very obese individual sitting on the ground every day for puja, still having no problem with his knee. And this was published by a Chennai group in 600 patients BPTB, 600 patients hamstring, and they said that there was no difference in pain, and actually the bone patellar bone did better in a longer run. This is our own publication at a follow-up of 8 years, a small number of patients of mixed religion, and there was no anterior knee pain. So even at this moment, my 15% patients, they receive bone patellar bone graft for ACL or PCL reconstruction. For last few years, there is a trend toward the ACL saving surgery like bear technique, and we are also trying to salvage the ACL or PCL with this, especially the ACL. It's a simple surgery where any suture passing device passes the two different color fiber sutures through the stump of the avulsed ACL, and this is taken on the lateral side and fixed to the lateral femoral condyle. If I'm not happy with the attachment on the lateral femoral condyle, I augment this with a very thin gracilis graft, this is how the X-ray looks like. And this is this is one of the patients after 9 months. Now it is 4 years after his surgery, full range of movement, very happy patient, and saved ACL. So this is a ACL femoral attachment, and here I detached the stretch ACL and did the surgery. This is our publication in 2018, where we published a series of 13 patients of femoral level and repair, and now we have 38 patients, fairly large series with us. I love to address PCL injury as it was introduced, and I have been doing PCL surgery since 1994. And this is the dashboard injury in India, which is very, very common. And when I see such knees, I do not have to touch the knees to understand that this is a grade 3 PCL, isolated PCL injury, or PCL injuries with multiple ligament injury. All the patient of PCL injury will come with anterior knee pain or anteromedial pain. Why? Because the tibia is subluxating backwards in the chronic PCL injury, and that is why the patella is all overloaded. These all patients will be always treated as a contumacia patellae without any relief. And in the late cases, there will be definitely a meniscus injury and articulocartilage damage to patella and femur. Diagnosis is easy. If I see any patient with abrasion, acute abrasion, I will think about a PCL injury in this patient. And for me, the anteromedial step of test of Harner is very much essential to know the gradation of the PCL injury. And of course, the stress views are still very useful for chronic PCL injuries. Acute PCL heals, there is no doubt about it. And that is why we keep such pairs ready in my hospital, where when the patient comes in acute stage, we either give in a brace or we put it in the plaster, and we keep it for 3 to 6 weeks. And many of these acute PCL injury heals. If the patient is affording, of course, I would love to use this Donjoy brace, because that gives me a very good post-operative or okay. For me, there are only 3 indications for acute PCL surgery. 1, PCL avulsion, tibial avulsion; 2, dislocation knee; and 3, lock buccal repair. And that is the time I do this acute PCL surgery. Otherwise, all the patients, this was one patient where I used to do a tension band wiring, and this was 15 years follow-up. This patient has a full range of movement after 3 months of tension band wiring for PCL. And of course, nowadays I do arthroscopic pull-out sutures for PCL injury. Chronic PCL deficient knees, patients, they come because they have difficulty in stair climbing, cannot sit cross-legged, and they are difficulty in using Indian toilet. And if you do not treat this patient, this is a 45 years old patient who came with 12 years old injury, medial compartment arthritis, and medial meniscus cyst, and medial meniscus degenerative tear. So you must address PCL as soon as possible. And how fast? This is the paper from Taiwan. They said that you must operate on a symptomatic PCL in one month. And I feel that in India, where everybody sits on the ground, we should address it as soon as possible. And now we do remnant preservation surgery. So it early healing, and it has a better for preservation without doubt. This is one of my first patient of PCL now. Around 28 years after surgery, bone patella bone graft, PCL, excellent result, and still the patient has not undergone any other surgery. Pediatric ligament injuries are quite common, ACL and PCL surgery, but I will not discuss about ACL injury. If a child is brought to you by the parents to you for repeated effusion and synovitis, think about PCL injury in these patients, and they are not able to complain a lot of things, but their problem is that they will have synovitis. We are very much afraid to offer any surgery in a chronic PCL pediatric injury because fear of epiphyseal injury, limb shortening, deformity after surgery. But I'm going to prove that this is not okay. So we must do either good conservative management in form of brace, or we must operate on these patients, because if you do not operate, they are always a high level athlete, and they will have meniscus tear, cartilage damage, and psychological problems. This is the first documented youngest PCL reconstruction in the world, which I did in 2008 on a child who was brought to me from 1500 kilometers after almost 9 months of her injury. We gave her a conservative trial of brace and everything for around 2 months, no result. So it was decided to do a PCL reconstruction. And of course, we use a maternal graft. You can see how we did the surgery. And this is her follow-up. Fortunately, she is in Ahmedabad with me, and so I can call her at any time. And now she is 16 years old, almost finished her growth, and there is no deformity of the limb, or there is no shortening, even in such a pre-pubescent individual. These are the two other patients where I did surgery with maternal allograft. And this young boy had a bilateral PCL reconstruction, one with mother's allograft, the other with his own autografts, bilateral. And their score is 100 now, because both of them are adults. And this is the patient and the mother. And now he's, after 15 years, he's completely all right after the pre-pubescent PCL reconstruction. And this was published in Kesta in 2016. And there is only one paper available in the world on prepubescent PCL reconstruction with maternal allograft. Of course, the ligament surgery has its own complication, and of course, the anterior knee pain in bone patella bone, but this was harvested for the opposite limb surgery. Of course, the cyclops and endobutton and infection. And we also had a popliteal artery injury in this young girl, but we could repair it. And after 4 years, she became absolutely all right. So friends, what I have learned is that in India, we have to address a posterolateral coronary injury very aggressively, and simple surgeries, they work. You don't have to do very fancy surgeries. Technique is important, precision is important, good post-operative rehabilitation is important. Implants doesn't matter. Enough autografts are available, so I do not understand what is the need of the allograft. ACL femoral avulsion must be reattached, and very, very encouraging midterm and now long-term results are available. ACL and PCL injuries in children are common, but they have different presentation as compared to adults. Ligament injury is ligament surgery can be done at any age group. No genetic counseling is needed if mother is going to give graft. A single short transphysial tunnel shows no growth problem, and ACL or PCL injury, initial conservative treatment works in both, especially in acute PCL injury and chronic ligament injury. You should not neglect because it is devastating for the knee joint. Thank you very much, and I feel that cycling is one of the best form of exercise that keeps the knees healthy. Thank you very much.
Nitish Bhai, that was fantastic. It's good to hear your talk on that. So on personally myself and on behalf of the BIOS, a big thank you for delivering this fantastic lecture. Thank you very much, and hope to see you soon.
Yes. Thank you. Thank you.
Thank you.
And now we're going to go on to Dr. Ashok Johari for his lecture about teaching and training. And we've got Mr. Atul Gaitonde doing his introduction. Thank you.
Good afternoon, everybody. I'm Atul Gaitonde, consultant trauma and orthopedic surgeon at Princess of Wales Hospital in Bridgend. It's my pleasure and privilege to introduce Dr. Ashok Johari, who's the most renowned pediatric orthopedic surgeon from India. I've been privileged to attend his clinics when he was a professor of orthopedics at JJ Hospital in Mumbai. He's the director pediatric orthopedics at Balabhai Nanavati Super Specialty Hospital in Mumbai, and he's the president of CCOT. He's the chief editor of the Journal of Pediatric Orthopedics from 2006 till date. He has held highly honorable posts in his long and distinguished career, including president of Indian Orthopaedic Association in 2010, and he was the founder secretary of Pediatric Orthopedic Society of India from 1994 to 2001, and its president from 2005 to 2011. The list can go on. So without any further ado, I invite Dr. Johari for his talk on education and training for the future, the role of orthopedic associations.
Warm greetings to everyone from CCOT, to everyone on this BIOS meeting. Now, BIOS is a society like many others, and the question asked of me is, what is the role of orthopedic associations in education and training for the future? Why orthopedic associations? Let's get down to the fundamentals. What has been the genesis of orthopedic associations? Man is a social animal, so brotherhood and mixing socially with other people who are alike us, then exchange of ideas and knowledge transfer, development of skills by means of, again, interaction, promotion of research. By all these means, better patient care and creating an impact for the specialty in the society has been a big role of the orthopedic associations. Hence, we have the oldest association is the American Orthopaedic Association, born in 1887, then the British Orthopaedic Association, and finally CCOT, born in 1929. Knowledge increased exponentially since associations were formed. This was because of inevitable progress of orthopedics and indisputable elevation of standards, increased subspecialization, and increased research and development. So associations were responsible for the increase in knowledge. Now, what have associations to do with education and training? Are they responsible? Associations exist for the benefit and needs of its members. Members' felt need is that for education and training, and member retention is important for associations. So associations are directly concerned with education and training. In the UK, you are lucky with the Royal Colleges being there and the NHS, which is also responsible for a large part of the education and training. But you are privileged, and this sort of arrangement does not exist elsewhere in the world. Now, a friend of mine by name DG, he told me that surgeries that came after my formal training were things like Elizaro, interlock nailing, locking plates, growth modulation, surgical dislocation of the hip, pedicular screw fixation, and vertebroplasties. And these required CMEs and practical training sessions, and various associations actually helped in this pursuit. Some skills are not taught during residency, but we need them frequently, like PowerPoint presentations, animations, and video editing. Non-orthopedic skills like accounting, wealth management, health management, leadership and teamwork, creativity are the examples where associations were helpful. So association members want to learn daily. They want continuous learning. They want to challenge yesterday's approaches. They want to innovate, want new approaches, want to do things in a better way. It's important to note that different members have different requirements for learning. They are at different levels of learning, and hence there are different formats of learning which may be applicable to them. Now, what are the different roles of the associations, orthopedic associations? Well, it's a facilitator. It is something which facilitates what the members want. Like, for example, knowledge transfer from the one who knows more to the one who knows less. Creation of knowledge by means of research in different formats again. Training, case discussions, skills training, etc. And finally, networking, where people are able to mix with each other to interact and try and get whatever knowledge and training they want. So the different roles of association are those of a facilitator, knowledge broker, knowledge creator, trainer, and networker. Let's see the role of associations in these different areas. So as knowledge brokers, associations create resources and different formats for knowledge transfer and education of its members, whether it is didactic or whether it is digital. Webinars, courses, and surgical techniques, other formats like forum for discussion and problems, example cases, books, journals, and newsletter. We encourage member participation, for example, by meet the authors and discussion on a particular paper. Appropriate knowledge is required, as I mentioned, for appropriate segments, and finally, certification. Now, education is something which is required 24/7 in this day and era, whether it is didactic, whether it is digital, or whether it is blended learning. There are unnecessary disruptions, and which call for innovation. Now, COVID is one example of this. So associations have to anticipate change. They have to be responsive to change. They have to proactively understand the needs of their members. For example, the digital revolution which has come about because of COVID and because of an absence of face-to-face meetings. Now, learning management system is an important repository which can hold a lot of knowledge and which can transfer knowledge. So continuous learning is possible with the learning management system. Self-paced learning at your own speed, world-class training is possible. Competency and performance can be certified, and a lot more can be done with a learning management system, which is a e-learning methodology. Now, associations are also knowledge creators by promoting research, webinars and courses on methodology, promoting multicentric and survey research, research grants and awards, and research mentorship, and meet the researcher forum. So associations can facilitate knowledge creation. Associations can also work as trainers by arranging skills training, live and cadaveric surgical courses, hand-on workshops, example sawbone workshops, surgical videos and interaction with the creators. So there can be a great discussion on surgical techniques. Surgical teams can be sent to remote and disaster-ridden areas whereby skills of the team members are enhanced. Again, certification of certain skill courses, artificial intelligence, virtual reality, and simulation technologies all can work to help enhance member skills. So an example of a simulation technology. Associations are also networkers by bringing members together and promoting interaction and exchange. Now, arranging for interaction with the key opinion leaders in the field, giving fellowships and different awards, facilitating mentorship and reverse mentorship from the young to the old, especially required for today's digital world. Having conferences and creating interaction, creating networking opportunities, inspiring members in different ways. Example, lifetime achievement awards, best papers, best research, etc. Now, industry interaction is also important, by which surgeons can get introduced to the new products, new innovations which are coming out, which can help their patients, and associations can create this interaction between industry and its members. So association plus industry and association minus industry. Now we know that industry needs interaction with surgeons. Associations can provide this interaction via conferences, lunch workshops, sponsored webinars, web advertising, mailing lists, etc. Digital marketing has made industry smarter. They can be on their own, so why have associations? However, with the return of face-to-face meetings, this trend is soon going to reverse. Industry impact will be felt only with face-to-face interactions with potential clients. So what are the challenges today for orthopedic association? Remaining relevant to its members. Member motivation is different, why people are in association. Well, they are motivated for different reasons. Educational motivations are different, hence different ages and learning spectrum need to be catered to. Different educational formats are important. The younger generation believes in micro learning, not for extended spells, but learning in shorter spells. We need to exploit digital learning. Association need to facilitate research, facilitate skills transfer and skill labs, and provide opportunities for networking and leadership. So this is the challenge for today, a lack of face-to-face meetings substituted by digital meetings. So again, there will be a wave when we'll get back to the face-to-face meetings. So the future in the end analysis, associations are required for future education and training of orthopedic surgeons. They play a big role. Associations will enhance education and training in a much better and broader way as compared to the industry. Associations have many other functions besides education and training, and hence membership is assured. So thank you very much for your attention.
Hello from Amsterdam. My name is Nick van Dijk and I'm presenting from home where I'm in quarantine due to a positive COVID test. So I apologize upfront for my throat. Here you see my affiliations and my disclosure. I'm the editor-in-chief of the Journal of Isocos and consultant for Episerve. What's the problem? The problem is a localized osteochondral defect, and the purpose of our treatment is twofold. It is to prevent osteoarthritis, but we know that the natural history is benign for the smaller lesions, which are typically 10 to 12 millimeter in size. The main reason for treatment is to resolve the patient's symptoms, and the main symptom of an osteochondral defect is deep ankle pain on walking. On the right, a schematic drawing of a knee joint, which is an incongruent joint, and the ankle joint on the left. 75% of the cartilage is water, so on compression, the water in an incongruent joint goes into the joint space, and on unloading, the water goes back into the cartilage. In a congruent joint, the water cannot go into the joint space, and this will result in less compression of the cartilage. In the pathologic situation, there is a way out in a congruent joint. It can go through the subchondral bone plate, the defect in the subchondral bone plate, into the subchondral bone. So on every step of walking, the water is compressed into the subchondral bone, leading to bone marrow edema on the T2 image of the MRI, and finally to cystic lesions, subchondral cystic lesions, which we see in congruent joints like the hip and the ankle, but not in incongruent joint like the knee. As when we look at treatments, then we see that the treatments that treat not only the cartilage but also the bone lead to the highest percentage of good, excellent results. Curetized bone marrow stimulation, oats, retrograde drilling, and fixation have the highest percentage of good, excellent results. So the size of the lesion matters. And here we see a typical size lesion on the left, which now turned post-operative, because on the right you see a CT scan 2 weeks post-operative on the same patient, and now this 9mm lesion turned into a critical size 50mm lesions. What does it mean? It means that the defect fills with fibrocartilage, which is not as firm as the adjacent hyaline cartilage. So the load will now be on the edge. So this concept of edge loading is very important to remember, not only for this type of treatment, but any type of treatment, osteochondral defect treatment. Remember this aspect of edge loading. And indeed, 1 year later, in the same patient, we now see a cystic lesion, and it's not under this area where the debridement has taken place. It is under this edge of the original cartilage, under the intact hyaline cartilage. So schematically, here we see a lesion of typically 10mm. We debride it. It fills with fibrocartilage through the stem cells. The subchondral bone plate is restored. And this is then the situation. And 90% of these patients have a good, excellent result, which lasts over time. However, in a larger size lesion, initially the same happens. It fills with stem cells, it fills with fibrocartilage. But now the load is on the edge of the defect, which might result in higher pressure, in tilting, and finally in subchondral cyst formation. If this continues, the tilting can get worse. You have more pressure also on the opposite side, maybe even on the medial or the lateral side, leading to cystic lesions also in those areas, and finally a destructed joint. So how can we prevent it? We can prevent it by providing a filling of this defect, which can take away the load on the edges. So for example, with a metal implant, it takes away the load of the edge of the defect and protects the healthy cartilage. That's how basically it works. And here we see an example of such an implant, which is placed at the level of the subchondral bone, which means that on top of the implant, the metal implant, we see hyaline cartilage, and this helps to protect the edges. It acts as a filler, as a spacer, to take away the load of the edge of the defect. This is a case in which the metal implant is placed a little too proud, and there we see fraying of the cartilage on the opposite side. So it's better to place it a little lower rather than place it too proud. We published in 2018 the results of a first-generation metal implant, 52 patients, 95% survival rate. The imperfections of this first-generation implant was that the osteotomy depended on the skills of the surgeon, and or you had to use image intensifier. There is only 12 sizes of this hemicap available, and it is difficult to measure exactly the contour and to check the contour of the talus because of the defect area. And if you cannot have a good view on an interpretation of the anatomy, then it's difficult to place it exactly right. The size of the screw is quite bulky, which is when you have to do a revision to an arthrodesis or a prosthesis, it is better to have a smaller stem or smaller screw. And there was no implant available for a lateral defect. The second generation metal implant, the AP Sealer, has this osteotomy guide, which is patient specific, which is very helpful. It is custom made for the patient based on MRI or CT. The guiding instrument is patient specific, which will result in a perfect fit. There is no large screw, but a small stem, and there is an implant available also for the lateral side. So the indication is a focal medial-lateral talar dome lesion of 12 millimeter or larger, which leads to symptoms. The preoperative planning is based on CT or MRI, and based on the CT and MRI, the guide are made, the guide for the osteotomy, and also the location of the lesion is determined exactly as you can see on the left, and the guiding instrument is made patient specific. So here are the instruments, the specific AP Sealer, the specific guide, the specific osteotomy guide, and here you see the relatively simple instruments. We have placed the patient-specific medial mallear osteotomy guide in this left ankle. Through the guide, we can make with the oscillating saw the perfect medial mallear osteotomy. After placing a Hintermann spreader, we can place the AP guide, the patient-specific AP guide, and through the AP guide we drill to the level 0.6 millimeter below the cartilage. Here we see the dummy, the AP Sealer dummy, and after placement we will see that the AP Sealer has a perfect fit, 0.6 millimeter below the surface. So, in summary, the pain comes from the bone, treat the bone. Remember the concept of edge loading. It's important for all treatments of osteochondral defects. Check alignment, we didn't discuss it, but if the alignment is not good, any treatment will fail, also the implant of an AP Sealer. And CT scan is the best for preoperative planning because the pain comes from the bone. And this finishes this presentation, and this finishes the this symposium, this APSurf symposium. I thank you for your attention.
Good afternoon and welcome back, friends. Thank you, Ashok. That was a fantastic talk on education. I hope people have gathered lots of information from there. I know it's a Zoom remote virtual meeting, so we can't be face-to-face, but I look forward to meeting you in Aberdeen. We now move on to our next session, which is on foot and ankle trauma session. we got Manish Bhatia, who's going to moderate the session with some interactive case discussion. Thank you. Over to you, Manish.
Thank you, Vijay. First of all, can I check if can everyone hear me and see my screen?
I can confirm we can hear you.
Thank you. Many thanks to BIOS for giving us this opportunity to talk about foot and ankle trauma. So we are going to, the aim is we are going to discuss a few cases. I have the pleasure, I have an esteemed faculty panel members with me here. Karthik Hariharan, or Harry, very good friend, and great educator, past president of BOFAS, and Rajesh Kakwani, again, fantastic educator and has served in the scientific and EdCom committees of BOFAS. They are here with me. Mandeep Dhillon unfortunately had some personal family matters, so he can't be with us. So we are going to kick off the session by putting the first case. And I'm going to, so this is a 38 years old female who sustained this injury when she was holidaying abroad. And these are her initial x-rays. So she, might be asking my colleagues how you would plan management. Rajesh, what would you recommend?
Okay, this is definitely one not to be given to the registrar to just fire in 2 syndesmotic screws. This is a very significant injury, and this has to be done. I personally prefer doing a CT scan for these to ascertain there's no intra-articular damage, and then do an open reduction. I protect the superficial peroneal nerve, open it anteriorly. Many times there is a AITFL, which is folded into the syndesmosis, which has to be fished out, anatomically reduce the syndesmosis, get the fibula length back to normal, and then put syndesmotic screws.
Okay, thank you. Yeah, so I'm not sure if a CT scan was done or not, but this is what was done. And these are the obviously intraoperative images. What are your thoughts, Rajesh, about that?
This looks okay. There's no tailor shift. The syndesmosis seems to be reduced, but this is only an AP view. The fibula may be slightly short. I may need to compare it to the opposite side, but overall, it looks to be nicely reduced.
Thank you. Now, this is her X-ray 4 months down the line. And we can see the fibular fracture has not healed. There was obviously communicated a spike. And there might be another view. We have another view. So obviously, this is what it is. So now this is the situation, 38-year-old female who sustained this injury 4 months back, and she's quite chubby. Harry, how are you going to tackle that?
Okay, if I can rewind a little bit, I think if you get this patient the evening, you have a registrar who's looking at it. There is the current vogue due to the lack of green pathway theatres, etc., to say, look, we can put this in a plaster and bring them to a fracture clinic in a week's time, and I think that is absolute no-no at this present moment. This, as you have rightly said, was a significant injury, and I think care needs to be taken to make sure there isn't a small posterior malleolar fracture. And I would agree with Rajesh that this ideally could be CT scanned, although it's not imperative. But for the general orthopedic surgeon who is seeing this patient, they must recognize that this is a very significant pronation external rotation injury with a huge intraosseous tear and a significant risk of intra-articular injury. Now that we've reached this stage, the presumption is that there is, you said that there was a non-union at the fibular fracture, so it is quite clear that there is a talar shift. The syndesmosis is opened up quite significantly, and it is quite clear that the ankle is unstable still. there is obvious fibular shortening. If you compare it to the original X-ray, the fibula has shortened, presumably at the non-union site. So at this stage, again, I think it might be useful to get a CT scan, and I would probably get a CT at this stage, firstly to ascertain whether there is a fracture in the incisura itself. Sometimes that can block it, but as Rajesh said, that there might be the AITFL, which is stuck inside. The second bit is one was recognized. This is 3 months down the line. The medial side is going to be full of gubbins. There's going to be a lot of fibrous tissue and scarring. So clearly this requires a revision. And once you have decided that you take the screws out, you'll have to check to see if the fibula is short at the non-union site, and one may require to fix it. But the most important thing is you need to clear the medial side of fibrous tissue and scarring and open up the syndesmosis to ensure that you reduce the fibula into the incisura anatomically to get the rotation right. One of the problems here is I think the fibula is slightly externally rotated. So if you looked at these screws on the lateral view, it looks like the screws are at the posterior edge of the fibula. I may be wrong in that interpretation, but that's what it looks like. And if you put it posteriorly, the fibula will automatically, it'll be compressed in the back and it will not be compressed in the front. And I think the external rotation needs to be corrected. And that could be one of the reasons why you need to fix the non-union to get your rotation right. And I usually put in screws which are quadricortical. I tend to engage the far cortex of the tibia in addition, which I think will afford it extra stability. And
Thank you so much. So yes, I mean, as you said, this had to be revised. It wasn't an easy revision due to obviously 4 months down the line, chunky patient, and had to open the medial side to clear it and then reduce the syndesmosis under vision. And
sorry, can I just interrupt there? If you looked at your X-ray now, it looks like the syndesmosis screws are more centrally positioned on the fibula too, and I think that makes an important difference in concentric reduction of the syndesmosis, so that you're not pushing the posterior side too hard and opening up the front, and I think that's an important consideration too.
Thank you. So just to summarize, the take-home messages from this case are that it's potentially difficult case and should be operated upon. There should be a senior supervision. The syndesmosis should be reduced as accurately as possible. Get a CT scan if you can, and then open reduction of syndesmosis to make sure, or at least make sure that the reduction is anatomical as much as possible. Placement of syndesmotic screws, 4 cortices, if possible, if you're using 3.5. And then fibular fracture, that is debatable, isn't it? People might argue that whether you need to fix the fibular fracture in the first place or not, then people can go either way. And either approach is right, I would have thought. Would you agree?
Yes, yeah, I would certainly agree with that.
Okay. Thank you so much. So we now move to our next case. And this is 84 years old gentleman who has got multiple medical comorbidities, blood pressure, ischemic heart disease, type 2 diabetes, and it's a bimalleolar fracture. And it was decided to treat this injury conservatively using a total contact cast, which was applied in theater. And this is what the reduction looks like. I think fair to say that reduction looks pretty good here. The plaster itself, maybe I'm not sure, but yeah, I mean, overall, I can't criticize this management. Would you support this? This is how you could have treated somebody with medical comorbidities, 84-year-old, non-surgically in a total contact cast? Reasonable thing to do or not?
Diabetes is the magic word here. We all recognize that diabetics have innumerable problems, both when it comes to wound healing, the precipitation of Charcot in an individual of this nature. there is no criticism of putting a TCC on. And indeed, as you know, there is a study going on now about TCCs in ankle fractures, trying to treat them conservatively. Again, you know, I deal with diabetics in the way I deal with non-diabetics, but I take extra precautions. So if this patient came to me, I would say this is a displaced fracture. If he hasn't got any peripheral ischemia and he hasn't got previous ulcers, etc., I might have considered fixing this using locked plates and following the same principles of osteosynthesis and periarticular fracture fixation, anatomically reduce the articular surface and put a robust form of fixation. What I would do differently is probably to keep them in a plaster for much longer, double the time of non-weight bearing, and take the usual precautions and watch out very carefully for Charcot coming on the scene, which with all of its attendant problems. If you're talking about this particular instance, the plaster is holding the fractured complex just about, okay? There's already the beginnings of a migration of the medial malleolus. And so if I were going to be treating this, I would see this patient on a weekly basis, possibly x-ray them on a weekly basis too, just to ensure that the plaster is actually doing its job and they're not slowly subluxing inside the plaster, which is the worst of both worlds because the medial skin is under tension. You'd start to get immediate problems with it.
I agree, Harry. As you mentioned, the current trial is going on for younger patients, but I was part of the original AIM trial, and I did treat a lot of patients. And in the AIM trial, I think it was recommended that these patients should have sequential X-rays every week for the first 3 weeks. Yeah. And unfortunately, what happened that this patient, the follow-up plan wasn't great, and then 6 weeks down the line, they were seen in the clinic with X-rays. Obviously, things had become like that. So, Rajesh, what are your thoughts now at this stage?
Okay, now this is becoming challenging at this stage. First of all, we need to know the soft tissues. Are they still okay? Because there is a tendency for this to progressively drift laterally if we don't do something about it. So if the soft tissues are all right, then this should be fixed. And in my hands, if the patient has poor mobility with comorbidities, the best option would be to have a hindfoot nail to realign the ankle.
Can I just ask, would you have chosen hindfoot nail in the first instance when you saw the initial X-rays? If I just go back, can I just poll between us? So Rajesh, how would you have treated in the first instance? He had diabetes, but didn't have any neuropathy and had medical issues. So in the first instance, your choice would have been to treat it in plaster, TCC, or hindfoot nail, or ORIF.
Frankly speaking, in diabetics, I'm a bit more aggressive. I tend to treat them with double the amount of internal fixation. But if the soft tissues are not permeable, then I would have treated it in total contact cast, but kept a very, very close eye on it, as Harry said.
Put me on, I got a question.
Harry, in the first instance, you would have fixed it, or?
Yes. I think if the biological environment was satisfactory, the patient was optimized for his diabetes, he was a reasonably reliable, compliant patient, I would have probably done a fibula pro tibia fixation using a locked plate on the lateral side, connecting fixing the fibula to the tibia with 3 screws, and I would have fixed the medial malleolus with a couple of screws. That would have been my optimal way. As I said, I really don't differentiate between diabetics and non-diabetics as long as the vascularity and the patient profile would allow it. Okay. I would certainly consider, in somebody who might think we've only got one bite of the cherry, the patient is not totally reliable, and the omens are poor, then I would probably have considered a nail as a primary form of treatment.
Hi, guys. There's a question from the audience, if I may, Manish.
Yes, Yogesh, go ahead, please.
Okay, so the Abhishek Arora wants to know, would there be any role of a fibular nail in this case, and what's the view of the faculty?
I personally prefer to do a fibula pro tibia type of plating, which is a much more stable fixation in this age. Yes, fibular nail is possible, but I find it very difficult to perfectly reduce the ankle with a fibular nail.
Yeah, I would concur with that, Yogesh. I think fibular nail has got the potential to cut out. The rotational stability is poor, and it would be nothing compared to a good fibular protibia fixation.
Make it 3. I'm not a fan of fibular nail either.
But that makes 4 of us anyway. But what I'm going to do is I'm just going to keep a watch on the question from the delegates, and I'll just convey it to you. Just because you are discussing, you won't have a time to look at those. So
yeah, no, they're not coming to me anyway. No, thank you, Rajesh.
Oh.
So 6 weeks down the line, this is where we were, and then as you've said, I don't think there were. I mean, I thought that one bite at cherry, and I did a hindfoot nail for him, and I think the patient did reasonably well. Until 6 months. So we now move to next case, which is not an ankle. Now, this is a patient which very kindly Harry submitted. So Harry, over to you.
Okay, this is a young man who presented to the accident and emergency department having fallen down a ladder, and whilst he was coming down, he landed heavily on one of the rungs of the ladder, which resulted in a hyperdorsiflexion injury to the ankle. And he presented to accident and emergency with this. There's quite clearly a profile anomaly at the back of the heel. The skin looks somewhat dodgy and ischemic. And he had x-rays done. And that was what he had. Perhaps I'll open it out. Perhaps Rajesh, you might want to comment on what you felt.
Yeah, this is one of the rare orthopedic emergencies. This has to be treated urgently. If that skin is allowed to stay overnight, that skin can easily necrose. And then covering that area is a big nightmare. So these are one of the few patients where I would, like a compartment syndrome, I would go in whatever time the patient comes in and reduce that fracture to detension that skin.
Can I then ask then if there isn't a foot and ankle surgeon on call, what would a general orthopedic surgeon do in this circumstance? I mean, how is he going to, he may not particularly be keen to open a calcaneal fracture at 10 o'clock at night to fix it. What would your thoughts be on that?
Okay, so in my case, I have gone in as a sort of have been rung by my colleague to come and fix this, which I have gone in because it's so much more easier to fix it primarily when it happens rather than delayed.
But you're a nice guy, Rajesh. Well, not all foot and ankle surgeons are nice guys.
Sometimes when you plantar flex the foot significantly, that skin can have some time to survive and be fixed overnight, but not always. So try to put the foot in plantar flexion, see what happens to that skin. If it's still white, call your foot and ankle surgeon or trauma surgeon.
I completely agree. What about you, Manish?
No, I think that's very, very sensible what Rajesh has just described. I mean, I personally agree that on a practical front, it's difficult to, take this patient to theater at midnight, and especially if you're a general orthopedic surgeon, better to detension the skin and put them in plaster, wait till morning. But yes, don't wait it for too long. Just try to do it ASAP first thing in the morning.
I think I agree with Rajesh. This patient should have been put into an equinus plaster to at least look to see if that will detension the skin a little bit. Unfortunately, the patient was sent home to come to the fracture clinic the following week. But luckily, the patient was in so much pain. He came back a few hours later saying, look, I can't bear the pain, and happened to see one of the senior orthopedic trainees who recognized the danger of this. And he was taken to theatre. I took him to theatre 8 o'clock in the morning. We did, as you can see, the skin is still a bit dodgy, but I did do an extended lateral approach because this is how I fix them. I use screws to push the tuberosity fragment back in, but they never stay. They are very often cut out. So I use a tension band wiring system on the lateral side to try and get added purchase, and I use the wires going through the screws. So it's not a true tension banding effect, but it's very effective in keeping the fracture there. This is one of the Bristol group techniques, which I've found very useful in this fracture. But the lesson is never. I've got horror stories where I've had, skin grafts and infections into the os calcis, and this is an interesting fracture in diabetics and in the elderly, because it often starts off as a stress fracture and one fine day it pulls off, and that is the danger in patients like that, where there's been a slow fracture progression. You often find that they tend to miss. And I have actually got a patient who was admitted into hospital because they thought he had a diabetic ulcer in the back of the heel. This fracture was not recognized until they got an X-ray. So the lesson is, watch out. This is a genuine, serious orthopedic emergency and has to be tackled in that fashion.
Absolutely. Yeah. And this is Achilles, isn't it? Achilles pulls the proximal fragment, and that's what there's nothing. You have to fix this fracture. I don't think you can argue that you would get away without fixation. Yogesh, are there any questions from the floor, or we move on to our next case?
No, at the moment there aren't any questions. But just one little comment, if I may.
Yeah, sure.
Well, this is a very, very good technique Karthik has used, but I also got limited experience of using the tightrope on it. So remember that is also a useful device to consider in case of this sort of fractures.
That's very interesting. I've never used tightrope there.
No, I use it. It worked for me. So
excellent. Okay. Harry, Rajesh, have you used tightrope for this injury?
I have used cannulated screws, but I have used 6.5 cannulated screws. The only two things I would like to say is they need to engage the plantar cortex, otherwise it will pull off. So if you're using the screws, make sure they are engaging the plantar cortex.
Correct.
And very rarely will you be able to close reduce it, because that skin gets puckered into the fracture site.
Yeah.
So more often than not, you'll have to open reduce it. And I personally prefer screws. I have no personal experience with tightrope.
Neither have I, sorry.
Yeah, no, same. So in interest of time, we'll move to our next case. The more we can do, the better it is. I think we still have time. So the next case, let's see what this one is. I think this is one of yours, Rajesh.
Yeah, so this is, again, a 21-year-old lady who's quite large, had a lot of alcohol, dancing on the table, fell off with this injury. Now, as you can see, it looks like a trimalleolar fracture with a high fibular fracture, a bit similar to the Manish's case, first one, but this has an additional component of malleolar fractures. This highlights my point of these fractures need a CT scan. Can we go to the next slide, please? Okay, so initially you can reduce it, which can give you an impression that this seems to be a very benign fracture now, where it's perfectly reduced, high fibula, and a small posterior malleolus. But if we go to the next slide, it will highlight how much articular damage this patient can have. So this patient has got a lot of comminution of the medial malleolar fragment. The posterior malleolus is also comminuted, although after reduction, the syndesmosis has been reduced quite nicely. So the take home for this case would be, in these patients with posterior malleolar fractures or syndesmotic injuries, do a CT scan. You'll be surprised about the amount of articular damage that these patients will have. Does Karthik or Manish have any comments, or else we can go to the management?
No comments.
So far, what you've said, Rajesh, I agree completely. That's how it should be managed.
I think we've entered a new era, really, once the Aintree classification has come through, which highlights the anatomy, the pathophysiology of posterior malleolar fractures, and also offers an algorithm for treatment. So it's well worth taking a peek at the Aintree classification. I think the importance is to recognize, as Rajesh said, you have to recognize that this is a serious injury, and we have to get it absolutely right. And perhaps it's quite useful to understand rather than using the Weber classification, which doesn't really have anything to say either about the soft tissues or the posterior malleolus. It's useful to use something like the Logger-Henson, where an appreciation, even for the general orthopedic surgeon at the entry point in the ED, if they can understand the mechanisms, then they would recognize how severe a fracture is and how unstable it is.
Absolutely. Now, Rajesh, you've done a fantastic job, but from the point of view of general orthopedic surgeons, especially at DGH, where they might not have foot and ankle expertise, what would your message that familiarize yourself with the posterolateral approach?
Definitely so. Familiarize you with your posterolateral approach. It's very, very simple. It's the fear of the unknown. There's only a sural nerve which can be easily identified and retracted. And then there is nothing else between you and the bone. So, and the other thing I would like to highlight is the posterior malleolar fracture is very, very, very similar to a volar Barton's fracture of the wrist. You would never fix a volar Barton's fracture with a screws from dorsal to palmar. Then why would you like to do something different for a posterior malleolus? It is begging for a buttress plate, and it stabilizes beautifully well with a buttress plate.
And then once you've done it, you don't need syndesmotic screws.
Yes, most often the syndesmosis will become stable because by fixing the posterior malleolus, you're stabilizing the PITFL. So to assess the syndesmosis, and in many cases, the syndesmosis becomes stable after fixing the posterior malleolus.
Okay, I'm going to ask both you and Harry, what's your position? Do you put your position prone or and then turn them supine, or do you put them in a recovery position?
If I'm going to use a posterolateral approach, I use a slight variation because I go very close to the tendon. I struggle with the idea that if I use a posterolateral approach and I have to fix the fibula, it makes for elevating and stripping a very large soft tissue envelope. So I use an incision which is paratendinous. So I put them on their lateral side and then flick them over to a supine position to fix the medial malleolus. But very often I've tended to use the posteromedial approach, which again, I find very much more central, and I'm able to fix both lateral and medial components of any comminuted posterior malleolar fracture. For those, I tend to go prone, and I can fix the medial malleolus medially, and I can fix the lateral malleolus laterally. So I use a 3-incision approach to minimize the amount of stripping. That's just me. There are many ways to skin a cat, and you can do it where you find it comfortable. My interest, rather than the approach itself, is what is the order of fixation that you guys do? Do you fix the lateral first, the medial first, the posterior first? How do you work it?
So I go for the lateral malleolus first, then I go for the posterior mal, and then I go for medial malleolus.
What about you, Rajesh?
I do the same. I actually do a posterolateral approach. Reduce the fibula, make sure the posterior malleolus is also reduced, then fix the fibula first, then the posterior malleolus, and then the medial side.
Yeah.
Okay. Interesting, because I tend to do it the other way.
As you said, there are so many ways to skin the cat.
Clearly, yeah.
Yogesh, do we have any other question?
Yeah.
Or we can.
Yeah,
okay, go on then.
Sorry, we got 2 questions on this case, and then there is a 1 or 2 from the previous one. But on this one, there is a question from Mukund Deglurkar and Satish Jainapadi. Can you just expand on the syndesmotic fixation in case? Because somebody says, is there a syndesmotic fixation there with a screw or tight rope, or is it not? Why is it not? So Rajesh, could you kindly enlighten on that?
Okay, so this one is one of the cases where I fixed the posterior malleolus and the syndesmosis was still opening up, which happens in around 20%. So if you see carefully, there's a tightrope across it, which is stabilizing the syndesmosis. But in these cases, you use tightrope only if you fix the fibula, because your fibular plate will then restore the length alignment rotation of the fibula, and the tightrope is just for the rotational stability.
So just following up on that, Yogesh, is if you've reduced the posterior malleolus and fixed it, you've reduced all of the other components of the fracture, it is still imperative that you check both in the sagittal and in the coronal planes. You check the stability of the syndesmosis, because if you had a comminuted posterior malleolar fracture, some components of the PITFL might still be hanging around in loose fragments, attached to loose fragments, and you may have instability. So the important thing is, after you've fixed it, you recheck the stability of the syndesmosis. You cannot simply presume that just because you've fixed the posterior malleolus that it's all stable and fine. You need to recheck it. It's really, really important.
Yeah,
because the initial messages that came through was once you fix the posterior malleolus, it's all going to be fine. And as Rajesh correctly pointed out, a fifth of these patients will continue to have a degree of instability.
Yeah, I think that's why those questions I highlighted, because I know this is going to highlight that important point which we needed to make everybody aware of. So that's why those questions. There is one more question about the medial side. The plate which used is like an L plate. So they are saying that is there any advice on using a simple plates or any specific medial malleolar plates for the medial side?
Okay, so here in this case, it's a vertical shear type of a fracture of the medial malleolus. So that's why any form of buttress plate will be fine. This contoured the best in this particular case, where I could engage and buttress all the fragments. But a 130mm plate, a T plate, or any hook plate will be sufficing as long as you use it in a buttress mode.
Thank you, Rajesh. Thank you.
Do we have time for one more case?
Yeah, we got 5 more minutes if you want to run the next case.
Okay, so actually this brings beautifully to the medial malleolus. So this is a case, this is a university student, 21-year-old student who again had this injury and had this fixation. And in the interest of time, this is what happened. So, Harry, what do you think about it?
It's a simple question going back to how you define the fracture. What is the mechanism of injury? And that's why you don't say this is a Weber B fracture and this is how you fix it. What is quite obvious is the alignment of the fracture line is possibly more sagittal than a routine fracture. We don't still know whether this was an unstable syndesmosis or not, because that hasn't been defined yet. So certainly you've got a significant disruption of the medial side. So it's a failure of the medial side with the inevitable consequence of talar rotation. So you've already got an incongruous joint there. You can see that the medial side is opened up. So there is potentially a syndesmotic disruption there. And you can see the alignment of this fracture now, which is almost vertical. So it's a front to back sagittal, and that is the correct fixation. That's what you need to do, because putting 2 screws in there is not perpendicular to the fracture line, and it will not hold the fracture. You need a buttress mode plate, which will not only compress medial to lateral, but will also buttress the fragment and prevent it from sliding up. And that's the lesson to be learned from this.
Thank you, Harry. Yeah, and we were having the discussion. So obviously this case, you can use whichever plate, as Rajesh said. You can use 1/3 tubular. You don't need to use any specific fancy plate, and just a simple plate would suffice for a vertical medial malleolar fracture. Guys, I think our time is almost up. 4:15. We are 4:15, so bang on time. We have one more case, but in interest of time, I'm happy to hand over to the organizers. I think we are all done here. Thank you so much. Thank you so much, Rajesh. Thank you so much, Harry. And Yogesh, thank you for getting the audience involved.
Thank you very much. I think fascinating session. Amit is over to Amit.
Hello, hi. Thanks, Manish, for that excellent session. Next session is, I think, the best of the best for excellent surgeons talking about infected arthroplasty conundrums. I hand over to Nikhil Shah to start the session, and there are still about 130 delegates still listening on to that. So well done.
Any feedback?
Yeah, we can hear you now.
We can hear you, Nikhil. I see you nicely.
I can't see Ridian and Andrew yet. So if we can welcome Ridian and Andrew to the screen, excellent. And just waiting for Ridian to join as well. Welcome, Ridian.
Yes, BIOS tie, isn't it? A BIOS tie is a hallmark today.
Right. So it's a pleasure and a privilege to be here to moderate this session. I have great pleasure in welcoming Andrew Porteous and Ridian Morgan-Jones as our two-star knee surgeons to this wonderful session. I'm sure you know both of these nationally and internationally renowned knee surgeons quite well. So just a brief introduction of both our guest speakers today. Andrew began his career in South Africa and then had an interest in knee surgery. He has done his fellowships in Bristol and in Australia. He has also traveled extensively for fellowship and advanced training to America and Canada. He is presently the president of BASC, and he predominantly runs a complex tertiary revision knee service that deals with complex arthroplasty, failed knee replacements, and focusing on infection. What I also learned today is that Andrew has a love for different types of sports, particularly cricket. And we did say that if we start talking about cricket, then knee replacements will take second priority. So welcome, Andrew. And the next speaker is Ridian Morgan-Jones. I know Ridian personally for over 12, 13 years now. He was my first mentor when I got chosen as AO faculty. Perhaps you'll remember Ridian in those days with your interest in Elizarovs. So Ridian also did his fellowship in South Africa in osteomyelitis and knee surgery in Australia. He runs a complex tertiary referral practice in Cardiff, dealing with a lot of infected knee replacements. Ridian is one of the pioneers in pushing the envelope for knee revision surgery and is an advocate of single-stage revision in well-selected patients. It's a privilege and a pleasure to have both of you. So if I can hand over to Andrew to start the session. Thank you very much.
Great. Well, thank you so much to Nick and to BIOS for the invitation. I know on both behalf of Ridian and myself, it's a great honour and pleasure for us to be here today, recognising the great contribution that all the surgeons with links with India contribute to the British orthopaedic fraternity. And also, if I can perhaps pass on our condolences to all those members of the Indian community who've suffered perhaps harder than most over the COVID crisis. What we'd like to do in this PJI discussion session, predominantly we'll focus on knees because that's essentially what Ridian and I do. But a lot of the principles, I think, are readily applicable to other parts of orthopedics and PJI as well. So what we're going to do is start with a couple of scenarios that I know some of you will be really experienced with arthroplasty and infection, and some of you will want more tips that are useful to you on a day-to-day basis. So we'll start with a couple of scenarios and discuss through those. We'll move on to a couple of cases to discuss, and then perhaps round up with what we think are useful take-home messages that you can bring into your daily practice. So perhaps if I start with the first scenario and put this to Ridian, the concept of the leaky wound and its link with infection, but perhaps if you just look at your first primary knee replacement, what do you do in terms of trying to prevent this becoming an ongoing problem? So day 1 or 2 afterwards, the dressing's soaked. Where do you go from there?
Well, good afternoon, everybody. And I'd like to echo Andrew's sentiments and thank you ever so much for the invitation. This is a not uncommon scenario. And I certainly have a regular concern about dressings that are soaked. I try and have a no-touch policy to leave the dressings intact for as long as I can. 7-10 days if possible. But when they soak, and they will, you need to have a strategy. And for me, it starts in theatre with a closure. I've moved on to barbed sutures recently, and I think that helps some of what I do. I use tranexamic acid intraoperatively. And despite that, we still get some soaked dressings because we do, in this country, worry quite rightly about DVTs. And the way we use thromboprophylaxis in the UK is possibly at variance now with other parts of the world. But we do use quite powerful antithrombolytics, and we will see soaked dressings and oozing wounds. So my strategy is manifold. I'll first of all stop the physio. I'll put them in bed. I'll give them a splint, a cricket pad, just to stop flexion. And I'll stop antithrombolytics for a period. Now, day 2, we'd hope to have patients going home by day 2, but not everybody can achieve that. And if by day 2 the wound is leaking, I think you are committed then to keep that patient in for several more days. It's not going to settle straight away. I think you need to rest that leg, rest the patient, and probably commit them for another 2 or 3 days in hospital until you're certain the using has stopped.
Yeah.
In the majority of cases, that's all you need to do.
Yeah, and I think you're right. It's a case of just not dismissing it as it's leaky, it'll stop at some point. And also the pressure from management to get them out when you're still worried, because I think we all realize if they do go home and they bounce back 2, 3, 4, 5 days later and they still have bloody dressings and they've fiddled around with it at home, we're then down a much darker and complex path. I suppose the other thing to consider quite early, apart from I'd obviously do the things Ridin's mentioned, I'm also quite liberal with using post-op tranexamic acid on the ward. So they'll often get 3 oral doses, 500 milligrams a day, TDS for 24 hours of tranexamic. And yes, stop the physio, everything halts, because now the number one priority is getting that wound sealed. And also we'd have quite a low threshold at this point for going for a negative pressure dressing as well. Particularly in those sort of higher risk patients where occasionally we'd put them on in theatre, but I think certainly if you've got a dressing that when you take off the soap dressing at 48 hours and it's still got that sort of slight leaking to the wetness to the wound when you take it off, we tend to go for a negative pressure one as well. And I think that probably is just a little added thing we've got these days that can probably help.
Yeah, I think that's a great point, Andrew. I think in terms of the health economics, I think putting a negative pressure on all primaries is a case, it's quite hard to make. The high-risk patient, I think there's a very strong case to make. But, if you're day 2 and you put a negative pressure on, it may save you a day of inpatient care. You may be able to get them home quicker, even if the wound isn't quite there. So you can actually save money by using negative pressures aggressively early in this group of patients.
Yeah.
And I could ask you, in terms of tranexamic acid, I agree with you with the post-op orals, and I'm starting to use that more myself. Intraoperatively, I use both IV and topical. So I'll have a gram at the start, or 1 or 2 grams at the start. And when I've closed the capsule, I'll inject 10 cc into the capsule when I've got my closure. And I think that there's good evidence that both work well.
Yeah. And I think also if you're on that journey of trying to manage without a tourniquet, that more people are sort of on that journey now, having tranexamic soap swabs over your cup bone surfaces also seems to help. You at least get accustomed to the more bloody view that you're getting. If we move on to this is now 10 days and you've tried all the bits and pieces and perhaps the ooze isn't quite so bloody anymore, but it's still a wound that hasn't sealed and it's still a bit leaky. Where are you now in terms of your concern or your next step?
Yeah, so I think the day 2 patient doesn't worry me. I think with good attendance to the patient, the vast majority settle. But you do occasionally get these patients that go from a bloody discharge to a serious discharge. And what that tells you is that capsule isn't closed. We've got direct contact between the inside and the outside and vice versa. I think you need to be aggressive with these. And, day 10, I'd probably say day 7. If day 7 you've still got a leaking wound, I think you've got to be aggressive with them. You could argue that maybe negative pressure is aggressive enough. Day 7, it's late. And personally, I would take them back to theatre. I would do a formal washout, and I do that myself. I don't think it's a middle of the night operation. It's consultant-led, elective surgical theatre. Wash it out. I suppose the big question mark is, do you change the bedding? And I think you probably should, because if there is a risk of infection, you want to treat this aggressively. It's a rarity, but I think you have to recognise it happens and happens to us all.
Yep. And the reason I put 10 was I think at 7 days, a lot of us might go, but it's still more controversial. I think by the time you get to 10 days, it's becoming more and more clear that just sitting on this longer is not going to help. If we then move to another scenario that always seems to happen last thing on a Friday is someone who comes into A&E to the on-call team, and they were happy with their knee replacement, so no issues with that. But they've recently been a bit unwell, and then they come in with a short history. They've got a temperature, raised CRP, and you've got your registrar there at 7 on a Friday night wondering what they should be doing. So for those of us that haven't seen an OBS chart on a ward for a while, that's a reducing blood pressure and an increasing pulse rate.
Yeah, so, and it's always 7 o'clock on a Friday.
Yep.
It's never 2 o'clock on a Tuesday.
No.
Look, this is a septic knee, and it's septic until proved otherwise. And this is a sort of knee that you admit, you plan the theatre when it's safe to do so. You've got to make sure that they're stable, but they may not stabilize until you debride the infection. And this is a deep infected joint until proved otherwise. The questions I've got, Andrew, is, I would aspirate at point of access, send it off. I'd go for broad spectrum antibiotics in the theatre, send multiple samples. But for me, look, this is a deep infected joint until proved otherwise. You're aggressive. And look, 7 o'clock on a Friday, you go that evening or first thing in the morning, depending on local circumstance, the patient's stability, access to theatre, but mainly the clinical scenario.
Yeah. Look, I think one of the differences for me here is sort of whether you are treating the infection or initially we're just treating sepsis and stabilizing a septic patient. So I think there is a difference between what you're trying to achieve with this patient. So certainly at that time of night on a Friday, I'd be saying that the definitive attempt at clearing the infection doesn't happen until the right person is there to do it. But they need IV access, they need their urine output checked, they need the support and perhaps input from ITU because they're decompensating as a septic patient. And yes, you ideally want an aspirate first because then you can put them on antibiotics. And if you're not managing to stabilize them and control their general condition, then they may well need a washout or an open washout or something to decompress or reduce bacterial load and stop them dying and having organ failure. But that is sort of a first aid thing. And your proper definitive attempt at clearing the infection is something that could then perhaps be delayed for the Saturday if you've got an experienced arthroplasty person around, or if you've actually decompressed the load, they've been on ITU, their kidneys are good, they're on antibiotics and they're stable, you could do their definitive DARE or first stage or whatever you're going to do on the Monday or Tuesday.
I'd agree with that. I think this is probably the one role for arthroscopy in PGI. It's a stabilizing procedure. I mean, what I have seen in the past, though, is that the arthroscopic debridement, the mini washer, works really well. The patient is clinically better. And then you're lulled in this false sense of security because you've made them clinically better, but the deep infection's still there. And again, you give them a prolonged course of antibiotics and they stay well, but it'll come back.
Yeah.
So temporary measures are exactly that. It's not instead of definitive surgery. And you can argue DARE, 1 stage, 2 stage, but you need to have a definitive procedure, as you said, by the right surgeon at the right time.
Yeah. So I think for the on-call guy, treat the sepsis, get a bug, start the antibiotics, and do a first aid washout of some description if you have to, but don't be conned into thinking that that's treated the infection. That needs a proper job at another time.
So Andrew, sometimes in some DGHs, you don't get the arthroscopy stacker on an evening. Would it be acceptable to dry tap the knee with a wide bore needle in theatre under full aseptic technique and just aspirate as much pus as you can, and then you have debulked it and then do all the rest that you've just said, but you're not able to formally arthroscopically wash it out?
Yeah, so I think that there is some advantage to aspirating to dryness just on the basis that pus under pressure is what tends to make you sick. So patients with sinuses almost never become septic. So, there's some advantage to that. I think if you're actually on a trauma take and you're not familiar with arthroscopy and the stack isn't available, if you even just did an inch or so incision in the scar above the patella where you've got no soft tissue coverage issues, and you just did a sort of mini open and you got your pulse lavage in there and washed things out, then you haven't messed up things for the next step, and you've sort of saved the patient's life. You've done their first aid. And particularly if you're talking about someone who is maybe not that familiar with arthroscopy, they're better off doing that than trying to force a trocar into a joint replacement and struggling with that. So sort of a mini open above the patella in the line of the incision is unlikely to cause harm that your sort of arthroplasty PGI guy would be worried about, a couple of days later if they had to go back.
Yeah, I completely agree with that. I think I would favour mini open atherectomy, suprapatella, as Andrew says, over probably a tap. But again, this scenario is not that common. The more common one is the low-grade grumbling infection. The patient's systemically well, but there's infection there. And again, slightly different scenario. Here we're presented with sepsis, and it's recognising the sepsis and treating it both systemically and locally.
Yeah. So if we go on to the first sort of case to look at, this is one of Ridian's that you'll probably recognise. 68-year-old, no comorbidities, 12-year-old knee replacement, 12-month-old knee replacement, but it's been painful and swollen ever since. And those are the x-rays there. And the initial investigations appear to be pretty normal.
Yeah, sure.
And do you want to just give us some update on that case or what your concerns were?
Yeah, absolutely. So this was, as happens, this patient's daughter was a nurse on my unit, and she was worried about her dad, and said it's a good knee replacement, happy, good pain relief, but it's been grumbling. And the local surgeon had done a workup, inflammatory markers, full blood count, normal. CRP was, top end of normal, but normal. Bone scan, not sure that was the best investigation, reported normal. It's within 12 months, everything's hot. And the surgeon said, look, it's a bit angry, it's a bit inflamed, it'll settle, you just need to give it more time. But we're 12 months out, and he's still grumbling, and he's still swelling. And what worried me was that looking at these first x-rays was on the medial plateau of the tibia. There's just a little bit of lysis there. And often that's the very first indication of anything going wrong. And I think it happens medially because we strip that when we do the exposure. So there's a little vascular area there, and that's a great place for infection to start. So having taken the history, examined him, I took some new x-rays, and if you click forward, and again, and there we go. So this is when he came to my clinic. CRP is now 18. It's not normal, but it's not awful. His symptoms have worsened. And if you look here, there's progressive lysis. So that same area, medially, there's now more bone loss. So that's a progressive sign. Clinically, he's much the same, a bit more pain, a bit more swelling. But, it wasn't a normal knee. And I think the problem here was because the surgeon hadn't proven something, he'd said it must be normal. Well, actually, sometimes you've got to repeat things. And all I did was repeat x-rays, repeat scan, repeat bloods, and the picture developed. So here we did an aspiration, and precoagulation is negative stuff. And that's quite a common one for these low-grade grumbling infections.
And I think the important bit as well is that while some patients may just continue to have pain after their knee replacement, to continue to have a swollen knee replacement for a year is a concern. And certainly, a painful swollen knee within the first year is definitely infected until proven otherwise. So as a standard sort of approach, one has to go that extra mile, and probably the aspiration's the bit that pinches the deal. But also, that unless there's another good reason for a CRP of 18, it's exactly what you expect with a low-grade chronic infection.
So this is excellent. And if you look at the lateral now, there's lysis behind those posterior condyles as well. And so if you get lysis posterior condyles, lysis medial tibial plateau, I think that's almost diagnostic of an inflammatory condition, infection in the knee.
Yeah.
So the question I had for myself with this patient, is it a DARE? Is it a 2 stages or 1 stage? And for me, it's not a DARE because we have bony involvement and it's a long history. Andrew, would you agree with that, or would you think there's still rules?
I think the in our sort of take-home messages later, we'll have some of the key bits for DARE, but I think it also needs to have been a successful, happy knee that you want to salvage, whereas this chap's never been happy. And I think as soon as you start getting lysis at the interface, you can't be sure that this is a well-fixed implant where it's worth putting them through a DARE. So I think for me, once I see those lytic areas, particularly the femur is more worrying at the back there. DARE's off the menu, and then it's just a debate about 1 or 2 stage, which I think, there are a couple of criteria where all of us would do 1 stages or all of us would do 2 stages. And there are quite a few where you could argue it either way, and it depends a bit on your experience and the setup of your unit and the availability of techniques and kit and so on.
Absolutely. So for me, this was a 68-year-old male, no comorbidities. It was a good organism. There's no skin issues with the limb. So I went for a 1 stage, and I went for primarily uncemented fixation. And there's the immediate post-op X-rays, and it was actually quite remarkable when I explanted. The lysis you saw on the X-ray was only part of it, and all around the tibia there was a significant lysis. So the tibia literally just popped out, and once I debrided, I was left with a big cavity, and that was the largest tarsal sleeve available at the time. It was adequate, but it was bigger than I was planning.
Yeah, and I think it's the lysis is always worse than you think.
So one of the things, Andrew, with this is not only a significant clinical problem, but we also encounter this often in medical legal and negligence work. And if you have a chronically painful knee that gets fobbed off for a year, 2 years, and then the infection becomes more and more established and more difficult to treat, that can cause clinical harm to the patient, and then that can become a very expensive medical legal bill. So one of the things that we have is if I do a knee and if he's not happy at a time where I expect him to be happy, I have a low threshold of getting a second opinion, which is completely unbiased, so that I'm not biased looking at my own knee.
Yeah, no, that's a very good point. And it's, my knees are never infected, but my colleagues always are. So it's always worth someone else putting an independent view on it, because we will always be hoping, because we're so invested in that patient that we don't want it to be, you need an independent view. And that's where the whole, team working bit becomes so important. This is not stuff to do as a lone ranger. You do need your colleagues around you for when it goes wrong, but also just to give you a bit of a common sense check occasionally when you've got your blinkers on. So yeah, excellent point.
Hi guys, very fascinating discussion, Nikhil, Andrew and Ridian. This is Yogesh here from Cardiff studio. Would you be kind enough to answer some of the questions the delegates have been putting on the chat?
Yeah, sure.
Okay, so one of the question Devendra Khurana wants to know is that if, for your second case, if the aspiration is negative, would you go as far as doing the synovial or bone biopsy for the suspected low-grade infection?
So this is from the first 2 cases?
No, this is the last case which you put in just now for the infection, Ridian. That's yours.
Yeah, no, so for me, the 2 groups aspirate, the ones that are obviously infected and all you need is the organism, and those are the painful, swollen, unhappy knees, and they're the ones you do in theatre. And I personally have a low threshold for doing EUA, aspiration, arthroscopy, and taking synovial biopsies if I'm in any doubt. Most of the time, you've taken the history, you've examined the patient, you've got some baseline blood profile, and then you do your first aspiration. And most of the time, you'll get everything you need. You can throw in synovasure, leukocyte esterase tests, D-dimers. There's lots of other tests out there of increasing expense. But I'd have no problem in repeating bloods, repeating aspiration if I'm in any doubt. And certainly arthroscopy is a big part, or increasing part, of my workup for complex cases.
Thank you. And for the first case, the Vikram Desai wants to know, when the wound was leaking after your primary total knee replacement, he said, is there any role for using the suction dressing a bit earlier?
Yeah, so I think that's something we tried to sort of cover a little bit, that if I've got a patient who is high risk, so they are diabetic on steroids and they are obese, I will probably put a negative pressure dressing and pick whichever one you like, but we've got the Pico in our theatres. I will probably put that on in theatre. If it's a standard wound, but just the next morning the dressing is really soaked and I'm worried, I'll put a Pico on with that first dressing change. So an early use of negative pressure for the high-risk ones, or if you're having a problem at 24, 48 hours, I think would be my advice.
Thank you.
I'm throw into that extension splintage and rest.
Yeah.
Yeah, so really old-fashioned orthopedics, but it works.
Yeah.
Thank you very much. Over to Nikhil.
Pleasure. If we go on to our next case here, primary knee 2009. So then at that point, this man was only 50, persisting wound leakage and had a debridement. Then had a revision which was within 5 or 6 years because of loosening of the base plate, and then a subsequent further 2-stage revision before the patient was referred. So, Ridin, any sort of warning bells and red flags that are talking to you from this case?
Yeah, so I'm listening to that and I'm thinking this was infected from day one, wasn't it? He's had a debridement, maybe they didn't identify an organism, he's loosened early. Again, was it infected, low-grade organism? And then eventually the infection has come out. So I think this has been a primary infection from day one. You may not be able to prove it, but that's what worries me. And also doing half a revision, doing a tibial-only revision in 2013. Was that the case, or did they revise both?
Yeah, it was just the tibial base plate, I think, that was revised. Yeah.
And again, that's maybe a whole different topic, but partial revisions, there's evidence for and against. I'm very, very selective in when I do partial revisions. And if there's any inkling of infection, I do the whole thing. I may do 1 stage, maybe 2 stage, but I'll do the whole thing. But so I think this has been a low-grade pulmonary infection all the way along, and I assume it still is.
Yep. So, I mean, these were the x-rays when he was sent down for an opinion. And obviously loose on the femur, possibly loose on the tibia, definitely infected, and still a staph as the organism, which turned out to be the same organism as when they did the first washout some years back.
Andrew, could I ask?
Yeah.
So one of the mistakes I've made in the past is to think the patella is really well fixed and patella revisions are really difficult. So maybe I've left in ones I should have taken out.
Yeah.
Was this year? Had you had the patella revised previously, or is it I've seen it before. The primary patella has been left in despite several revisions and it's still infected.
Yeah. So I mean, I've only once ever left a patella in with an infected case when it was an uncemented one where I knew I would just fracture the extensor mechanism by getting it out. But otherwise, I think if there's infection there, you've got to get the patella button out. And if you're left with a shell at the next stage, well, that's a problem for another day. The infection is the main problem. And so, yes, still infected. And so obviously here I've gone for a static spacer. One could argue a mobile, but he's already on a 3rd or 4th procedure with infection and major bone loss as well. So do you want to just make a comment on perhaps the static spacer you would use, Ridin? Because I think it's pretty similar to what we would do.
It's very similar. And looking at this X-ray, I can see you've got the carbon fibre rods in the middle there.
Yep. Yep.
Yeah, so you can see the outline of those, the shadow, and around it looks like several mixes of cement. And I can see little islands in the cement. So you've added antibiotics in there. So you've gone for a very broad spectrum antibiotic spacer. It's a 3rd revision now, maybe 4th revision. You've got to worry about soft tissues and contracture. And if you go static spacer, then it's going to be a tight knee at the end. So I'm assuming you're going to be planning a hinge mechanism second time, so you can release extensively.
Yeah.
And knowing you can put a hinge in successfully, static space allows you to treat that infection better, I think, by resting the limb, resting the bones, but in particular, resting the soft tissues.
Yeah, and I think we'd have the same philosophy that where possible, if the bone loss is minimal, the soft tissues are good, go mobile, the function's a bit better and the tissues are a bit better when you go back. If it's getting more of a disaster case, just let it all rest, keep it static and come back another day. And you can see a tubercle coming off there for the access because he was pretty stiff. And one of the issues, not specifically a topic for today, but obviously bone loss becomes an issue to try and deal with as well. And lots of different ways to skin that cat, whether you go with cones or sleeves. Subtle differences, but probably for most cases doesn't make a big difference which you choose. It's the system you're familiar with. And obviously just trying to sort of reconstruct it. But all of that is secondary. That's the fun bit to do later if and when you've cleared infection. So all of this makes no sense at all if you haven't cleared the infection.
Completely. And they're great slides, Andrew, showing how radical the approach has to be, how radical the debridement has to be. And your reconstruction fixation, we have many options now. But it doesn't matter what you use. If you haven't debrided, you haven't done things properly, you don't get that second chance.
Yeah, and it is, I think, part of the issue of the right people doing it is the people who are used to doing big exposure, used to being able to remove dead bone because they're not worried they can reconstruct that later. They can debride capsules and out the back of the knee if they need to, because they know they can deal with that. I think if you're tentative, you don't do this often, you will perhaps not be as aggressive with your debridement.
So, Andrew, one of the most enlightening moments of my career in treating infections was Ridion's description of the tricyclic debridement.
Yeah.
At first, I thought he was jesting that we need to go on tricyclic antidepressants when you get an infection. But Ridion, if you wouldn't mind, just summarizing that concept that you have so beautifully described.
Nick, if I can just pause you there, because on our summary take-home slide,
excellent.
We have that exact process of Ridion's to go through. But excellent. Essentially, just to finish off this case, because I know we're getting towards the end of our time, if you can clear the infection, then you can get back the function and the reconstruction and everything else. But clearing the infection is the important bit. And then I think because we are coming up to sort of about 5 or so minutes left on what we've got, if I just skip through the one other case we were going to discuss, which was quite similar, and go on to this debriding slide. Now, it's something I've been going on about for a couple of years. Ridion's certainly been going on about it for a lot longer and raised, as you said, all our awareness about it. So he needs great credit for doing that. But there are a lot of stages to the process of debridement. The bit I've added is the bit like the 1980s shampoo adverts, which is where you have to lather, rinse and repeat and keep doing it until it's clean. But perhaps, Ridion, if you can talk us through the other steps that you've sort of popularized.
So it's not, so mine is ever so slightly different to Andrew's, but very marginally. So I talk about surgical, mechanical and chemical. Surgical being exposure, explantation, cutting out any obvious dead bone and membrane. Mechanical, when you're reaming the canals up and down, you're scratching, correcting the bone surfaces and using high power pulse lavage, always high power myself, to both wash out any debris, but also if there's any biofilm left over, high power lavage makes the odematous. So when you do your next cycle of mechanical surgical cleaning, it's a bit more obvious what you're taking out. I do that 2 or 3 times. Then I finish with a chemical attack. And under tourniquet, I'll use hydrogen peroxide, alcoholic chlorhexidine, and acetic acid. They're my poisons of choice. But there are modern ones available, back tissues out there at a cost. Chlorhexidine, definitely, Beridine works, lots of things. I would tend to use chemicals in combination and you choose your poison. But, you know, it's that cyclical thing. It's about having a stepwise approach. Instead of, you know, I look at other people's lectures and they say I did a radical debridement, a tumor-like debridement, an aggressive debridement. Well, that's just subjective terms. You have to define the steps you are going to use again and again so you can get reproducible results.
Yeah.
And
I
again,
think all the infection work sort of succeeds or fails on your debridement, and the antibiotics help a bit afterwards.
This is becoming a more common medico-legal allegation as well now. So recently I've come across at least 3 cases where the allegation has been that the surgeon did not perform an adequate debridement because it wasn't documented in the methodical manner that it was done. And then it's very difficult to defend such a case where you haven't documented each and every step that you have done properly.
Yeah, no, I think that's a fair point. And as we're sort of coming towards the end of the session, Rudy and I just had a couple of things that we thought were useful take-home messages. But use the resources to keep yourself up to date. There's a lot of stuff that's come out of the BASC Revision Working Group in the last year, a number of articles and symposia in the knee, as well as a specific post on PJI in the knee, which you can get off the BOA website. Perhaps the other bits summarizing what we did earlier, active management of your early leaky wounds. So don't just watch them, do the interventions with the negative pressure, the rest, the elevation, the stopping the anticoagulants. If it's prolonged ooze, it's serious, get the second opinion and have a low threshold for taking them back to theatre. If they're septic, presenting on call, it's about sepsis support, getting a sample and starting antibiotics. You may want to intervene with your first aid, wash out for the septic load, but properly treating that infection is done at another time. In terms of DARE, do it if it's a good implant that's well fixed with a short duration of infection in an optimized patient, and it's an extensive debridement with the documented stages we've talked about, and it's not by a junior out of hours. This is a sort of consultant level attempt at saving a joint. There will be some parts of the country, either in parts of Wales or Ireland, where the network system that's coming in may not be rolled out there at this stage. But even if you're not working in a system with a network, you must have a departmental pathway for how you discuss these, how you refer these, and whose friend you have on fast dial to be able to discuss the cases with. I know mine's Ridian, so it's always good to have a good friend in the background.
It's a great thing, trust me.
And then perhaps the final thing, just to round up the PJI thing, is always try and get the organism, because that's going to be your key for any of your medical management. Always do a good debridement, because that's probably the most important step of all of it. And then with the new network systems that are coming out, it's a case of trying to get the right surgeon in the right unit in an MDT network type situation to do that job, and then developing those networks and relationships so that the units that do some revisions, but maybe not very complex ones, you find the right threshold in your area for what you discuss, what you hang on to, what you send on, because for the patient at the end of the day, getting the right intervention the first time around is certainly going to help with this infection work. But Nick, I think from Ridian and myself point of view, those were the main messages, but obviously are there other questions or anything else you want to put to us?
So there were 2 things that if you can share your wisdom with us. One is the culture negative infection. So you have got infection, but you've tried your best and you can't get the organism. And that's becoming increasingly common, according to what Parvizi was saying last month in one of the updates he gave. And the second point was about seronegative infections, where your bloods are normal, but you know that there's an infection. What's your experience or view on that?
So everybody gets culture negative infections if they've got a decent series. I was in Cardiff, about between 14 and 18%. Jay Parvizi talks 25 to 30%, and I think that's a bit high, to be honest. And I've got to ask why they're a lot higher in Philadelphia than they are in other parts of the country. But every series you look at should be reporting culture negatives, because they exist. That may be culture negative pre-surgery. Perioperatively, when you do multiple sampling, you should increase your yield. In terms of what you do with it, again, it's philosophy. For me, a culture negative infection, I'll treat exactly the same as a culture positive. I'll make a decision on 1 or 2 stage based on the patient primarily, the limb, and the organism to a lesser extent. The data that is published out there, and that includes my own series, will tell you that culture negatives do just as well. Whether you do a 1 or 2 stage makes no difference. The culture negatives are generally low threshold organisms, low virulence organisms, sensitive organisms. So I wouldn't worry too much about them. But that's easy for me to say. I think we've got to have a debate about how we do this. I know that the Bose would say culture negative equals 2 stage. That's a debate we can have. Andrew, maybe think differently.
I think the only other comment I'd make is that some of the microbiologists will tell you that the way things are cultured in different hospitals is different. So occasionally having a more reference center PJI place do your samples, you might get a few less. They may not culture, but you can also do things like send off a PCR, which micros will routinely do if there's concern about that. But at the end of the day, there will sometimes be ones that you just know are infected clinically or on histology, for example, and you just can't name the bug. And that's when you have to go broad spectrum, but also think of the weird ones like TB or funguses and so on, which you may not have cultured appropriately for the first time around.
That's great. Thanks. Just we'll wrap up in 1 minute, but just your take-home message about seronegative infections, where the bloods are normal. What's your experience with that?
So classically, that would be the coagulase negative, the low virulence infections. Yeah. And 5% of all infections have a negative CRP. It just is. That's why, look, we don't rely on one test. It's about the history, the examination, x-rays, bloods, repeating them, aspirations, biopsies. It's everything together. And then you can add in the most expensive tests you want. None of them are at 100%. We're still at about the 95 to 98% efficacy with almost all tests.
That's great. Thank you very much indeed. So Andrew and Rudian, thank you very much for a wonderful session. It was certainly very educational for me. I hope our audience has enjoyed it. So with your permission, we'll sign off.
Thank you.
Very much.
Pleasure. Thank you. Goodbye.
Bye-bye.
Symbios is the foremost opinion in the design and manufacture of custom hips, with over 30,000 implantations Europe-wide and 20-year published clinical results which are supported by the most robust National Joint Registry data. Symbios is your clinical partner in finding accurate reconstructive implant solutions for the most active, high-demand patients, with or without complicating hip dysplasia.
Good afternoon, everybody. The next session is one of the most exciting ones of the conference, and it's the prize distribution ceremony for the best poster and the best podium of the conference so far. We're very grateful to our sponsors. I will first announce the names of the sponsors who have supported these prizes, and then afterwards I will announce the name of the award winners. So the first prize for the best podium has been supported by Lida, and thank you, Lida, for supporting this prize. The second and third prizes for the best podium are supported by Symbios, and we would like to thank Symbios for their kind support. And for the posters, all the 3 prizes, first, second, and third, are again sponsored by Symbios. And again, a very much grateful and thank you to Symbios for the support towards the BIOS. We are also very grateful to Quilter, who has supported all the abstracts that have been submitted to the conference. Moving now to the announcement of the best podium prizes. So the first place goes to Naveen Joseph Mathai for his presentation on restoration of elective spine surgery during the recovery phase of the COVID-19 pandemic. Now, interestingly, there's been a tie for the second and third place for the podium presentations. So we have decided to give a joint second place prize to two of the speakers. So in no particular order, the first second place goes to Sanjay Sonanis for his paper on the experimental study on the various configurations of the tension band wiring technique for the patella fractures, an introduction to the horizontal figure of 8 tension band wiring. And the other second joint place goes to Rishi Agarwal for his paper on sacroiliac joint fusion using the HA-coated screws versus titanium triangular dowel, a prospective comparative study. Moving to the best posters, the first place goes to Chiranjit Dey for his poster on testing a framework of safe elective surgical practice during the COVID-19 pandemic. The second place goes to Keith Tambuwala for his poster on effectiveness of a green COVID-19 pathway at an elective orthopedic site. And the third place for the poster goes to Phil Belcher for his poster on patient satisfaction and Boston carpal tunnel questionnaire assessment following the Volant technique for carpal tunnel release. Congratulations to all the winners. Thank you to all the judges. And next up is Mr. Ashish Khurana for the vote of thanks.
Good afternoon again. We are to the end of a deeply engaging and hugely enthralling 2 days full of facts and figures. I must extend my deep gratitude to the First Minister, Professor Mark Drakeford, our Health Minister, Baroness Ellen Morgan, and Christine Rees MP for supporting this conference. Your addresses were inspiring and outlined a direction for the Welsh NHS as a whole. I must extend my sincere thanks to Professor Bijay Singh and Professor Amit Tolat, the exiting and the incoming BIOS presidents, for their infallible efforts in enriching this society. I would also like to thank Mr. Bob Handley, the BOA president, for his engaging address to the conference and providing a deeper analysis to the difficult post-COVID orthopedic challenge. I would like to thank the entire national and international faculty. Their fantastic talks and panel discussions provided a great insight into the various aspects of trauma and orthopedics. And indeed, the entire organizing team of BIOS 2021 under the able leadership of Amit Chandathya and Professor Kashav Singhal. Their untiring efforts and attention to detail helped in delivering a successful hybrid conference. And to the sponsors who provided an invaluable contribution to science and learning. I also thank our technical and marketing team from Clockwork for the help with overall planning and organizing. What you saw on your screens was just the tip of the iceberg. These pictures show the complex and high-tech studio that they created. And of course, all the attendees, over 800 people registered for this conference, without whom the meeting would not be a success that it was. BIOS is known for spouse and family social interaction. That was probably missing to some extent due to the current COVID circumstances. We indeed made up a little bit of the opportunity that we had during the dinner last night. We hope that we would be able to meet in the usual fashion for more interaction in the years to come. And on that note, and with a big thanks from Cardiff, over to BIOS 2022 at Mansfield with Vikram Desai. Thank you.
Hello friends, we have had a veritable feast of educational activity over the last 2 days, and from the BIOS Central Committee, a huge thanks to Amit Chandathya and his fantastic team here for organizing and executing this virtual event. There were more than 850 registrations for this event, and more than 500 were logged in today. A fantastic performance. Thank you very much, Amit, and we are hugely grateful to you for this.
Thank you very much.
We have a special award for you, which unfortunately has been held up due to COVID, but will be sent across to you.
Thank you.
But I would like to give you this token of our bow tie today.
Excellent.
Thank you so much.
Thank you. Thank you very much. It's been excellent.
I would also like to thank the Clockwork marketing team for their fantastic support to this meeting. And without them, I think this would have been very difficult as well. All the members of the Cardiff team, please do come up on stage so that we may all get together. thanks to top and slide.